Can I please call upon Dr. Jain to start the session? Thank you. Over to you.
This is a 20 minutes. Good morning, and it's a distinct honor to be here today in Bhubaneswar, and it's a great privilege to be part of morning session which is presided by Dr. Mehul Amin, and it's an honor for oneself to actually share our innovation that contributes in variety of patients, starting from post-detection to longitudinal monitoring. And today I'm going to talk about these biomarkers, how relevant they are, not from the diagnostics, but especially the biomarker circulating tumor cell has been discussed widely for its pros and cons. And I would like to share some of our findings close to about 10,000 patients in Indian settings. So the dynamic duo, circulating tumor cell and circulating DNA, when you combine this biomarker, I think it gives us significant magnified value in monitoring patient, both from the primary as well as from the metastatic disease. So the content I would like to roll around the role of biomarkers testing in precision oncology era, while our main goal is to treat the patient at the pace of the evolution of an cancer. But in personalization, I think we often ignore the progression of a disease through this kind of a biomarker, which would probably lead to a metastasis. Say early stage cancers, for example, when patient is in stage 1, especially, it is considered that the patient would not have any metastatic cascade onset because we don't see those biomarkers. Although circulating tumor cell is there since 150 years, but most technological challenge that chemical science has been actually facing is how to capture these rare circulating tumor cells, which are extremely low in abundance. And therefore, the sensitivity was actually an issue, especially in the early stage cancers. So in 2004, US FDA approved first circulating tumor cell in metastatic setting for predicting the survival, overall survival of cancer patient, especially in the breast cancer, second in the colorectal cancer, and the third was prostate cancer. So that was evolved. But later on, we realized that not much of the distinction was evaluated for circulating tumor cell of their role in early cancers because of a sensitivity and false positive and false negative component. Now, very lately, we know that the circulating tumor cell and circulating DNA has represented very well in colorectal cancer patients, especially in de-escalation of a treatment, because all of us know that there's always a debate whether to treat patient 3 months or 6 months in colorectal cancer patient. And there are some studies like Dynamic and Miracle have actually come forward to state the role of this biomarker. Secondly, when there is a DNA present and when there is a DNA absent post-surgery, you could decide whether patient require an adjuvant therapy or not. And in Indian setting, de-escalation remains an important pivotal. Breast cancer, definitely this circulating tumor cell and ctDNA has been used to reveal whether there is a dormancy of breast cancer in this patient and is there a minimal residual disease. So while minimal residual disease in liquid biopsy is now at the forefront, but I would like to actually call a term called as a cellular residual disease, especially in an early stage cancers. I would like to say the most problematic area for circulating tumor cell has been actually lung cancer, where the tissue is very large. But there are reasons why even in a late lung cancer patients, you do not see a dissemination of circulating tumor cell, and why don't you capture it? But our whole Indian data on 265 patients. And if time permit, I would like to talk about few of the cases that has been actually very recently presented in ASCO and ESER and ESMO. So who we are, I think, as a scientist who returned from US and Germany, having an options to actually work in those countries and, do an accelerated research. As in, all of you are patriotic, and therefore I also stand a patriotic scientist to do something, especially in a challenging area. So me and my co-founder Arvindan started a startup company in 2013 with taxpayers' funds, by the way, let me acknowledge, on a problem like circulating tumor cell detection technology, which would take 10 years of a time at least, with 0.1% of a success rate. And that was a high-risk innovation that actually Department of Biotechnology funded, and we started our journey in 2013. Fast forward, in 2019, we became India's first medical device company to get an approval for any technology that was actually evaluated in this country. The regulatory pathway was actually not known, but remember, a company which was actually approved having a CTC technology in US in 2004 probably started their journey in 1980s towards this kind of an distinction in letting know people what is actually role of this biomarker. Because in 150 years back, when British scientist Paget and later on Ashworth published a paper where breast cancer patient post dissection, they found that there are some unwanted cells, and Dr. Mehul Amin would say actually the presence of these cells from primary tumor to coming to the distant organ through a narrow capillary itself is challenging, and the plasticity plays a very important role, because the size of circulating tumor cells typically in any transition, whether it's an EMT or MET transition, would be about more than 10 micron size, while the capillaries will be lesser than 5 micron size at a site. But post-surgery, post-resection, there's an assumption that you have taken out actually all the margins because you cannot see it. But today the beauty of this, post-surgery, you can say whether there has been some residual disease or not. If you find a single fragment of a DNA, and in last 2 years, I think OneCell has contributed immensely in increasing the sensitivity of this kind of an assay. And in 2020, we formed OneCell as a joint venture between very strong AI/ML company in US and with my company Actuarius. We published a lot. Last year we had, for your information, 10 ASCO abstracts. And I am very humble to say with humility that this year we want to actually put about 24 abstracts. And that is what is the power of a data in this country. So frugality is important, but you cannot have actually $2,000 test for circulating tumor cell, which is today the price in US. Can you make it tenfold? Can you make it more sensitive? Can you make it more accurate? Can you make it more precise? And frugality doesn't allow it. So I think the scope of my talk today is actually only limited to these 3 terms that all of us already know, that MDR is a problem. And if you look, that the metastatic relapse actually is always there in first 5 years. So if I ask first question, in early stage cancer patient, when you had a surgery, when you have a CT-RT, when there is no PET scan positive signature on this patient, why actually patient come back? And only cause for this is actually live circulating tumor cells. And therefore, they become a seed to metastatic progression of a disease. DNA does not contribute in progression of a disease. It doesn't proliferate the disease. Say, for example, in breast cancer, HER2 positive patient, all of us know that there could be a dormancy, ERPR for example. Patient can actually survive without disease for 20 years. But when the disease comes back, as we say, everything is written in the blood, and what goes around actually comes around is actually represented by circulating tumor cell, because they are telltale signature of a metastasis in even early stage of a cancer. Only data was not there. The second component, as I mentioned, cancer dormancy is an issue in breast cancer predominantly, and we do not know today why some circulating tumor cells are actually not eliminated when 1 gram of a tumor can shed 1 million of circulating tumor cells on a daily basis. But fortunately, 99% of them are actually eliminated by our immune system, T cells. But the cells which will have actually a power to remain in a circulation through PD-L1 expression is now known that they are not taken away by the immune system. In fact, they deactivate T cells. And very late data states that while your CPS score for IO therapy is important, but the representation of a PD-L1 as a secondary biomarker, then cytokeratin, is extremely important to know which patient will actually have a progression of a disease. And we have more than 1,000 patient data to say that which cancer patients with the CTCs will have actually this disease. Minimal residual disease is a new toy in the town and a toy store. And earlier it was in hematological cancers, but solid cancers it's known. I have actually borrowed this slide from Dr. Gandhara, who presented this representation of a journey of a cancer patient from screening to neoadjuvant therapy to MRD to recurrence and selection of therapies, and then monitoring responses and finally determine the mechanisms of resistance. We know that there is not a single therapy which actually doesn't lead a patient to resistances. Science has not been able to discover drugs of this kind. And the reason is because we do not know actually this kind of cells which are actually exposed to any pathway in a life cycle of a metastatic progression or a proliferation comes into the resistances. And that clonal colonies are very important actually to determine. So if you look at ups and down of a ctDNA or CTC numbers, represents falsify that patient is actually disease-free, while it is not. It's a limit of a detection, including actually PET scan, CT, MRI, which says that the patient is actually has a disease or not have a disease. And that limit of detection through your guidelines is now actually going to be very, very important through this kind of a small biomarkers, including CTC and circulating DNA. I would like to actually press here an information that while ctDNA has significant role in diagnosis, you start on first standard of a care is very, very important when you start a chemotherapy, for instance, with 1,000 gene panels or small 15 gene panel. But ignorance of actually not detecting patient for circulating tumor cells at that time of a point as a baseline remains a dogma of a cancer, because later on, these patients who have been responding well will come back, and that actually is a problem statement I will present later on, specifically in 3 cancers. So this is what is the past, and most of the oncologists, when we meet, they actually are in the past what actually US FDA approved this technology in 2004. If you look, there is a probability of overall survival in 3 cancers, breast cancer, colorectal cancer, and as I mentioned in prostate cancer, and even urological cancer. This is obvious that the patient will actually have a worst outcome who represent 3 or 5 circulating tumor cells. While there was no scale to number what number of cells are actually important, and there's a study that came later on actually diminished the role of circulating tumor cells, especially in oral cancer detection and diagnosis. But let me tell you, one single circulating tumor cell's presence itself is actually a worst outcome, not 3 cells or 5 cells, because of a sensitivity and false negative and false positive, especially when you contribute actually leukocytes as a circulating tumor cells. Now there is a second question of a transition, EMT transition and MET transition. As the cells will come in the blood circulation, they will tumble upon a variety of pathways, and they would actually get into the transition mechanism. So epithelial cells, solid cancers can, the cells can be picked up by anti-epithelial cell adhesion molecule, which is only technology which actually is approved today in the US. Let me actually, educate myself by this review by Cohen, which is very seminal review that was published very recently. If you focus onto the central figure today, the dynamic changes in ctDNA following treatment responses is threefold. All of us know that primary resistance is the main cause of the lesser overall survival. Many patients actually do have ctDNA reducing numbers in the second stage, and that's where actually the recurrence comes. There is good enough science to know why patients recur. The best case scenario is when patients do not have ctDNA on the onset of actually standard of care, as well as in the longitudinal monitoring stage. That is what is a remission. The remission is not a static state. It is a dynamic state. And that dynamism can be actually accounted by biomarkers like ctDNA and CTC with a dual combination. Why this technology is so difficult over to any other technology in biological sciences is because it's a bloody hell challenge to identify specifically with specificity those epithelial cells. But remember, one cell at a time can be captured, and it can have an ocean of an information, especially when you can capture one single cell and do a genomics with 1080 gene panel. And we have been studying multiple clinical trials in US and in India to show that the tissue was gold, the DNA is actually next gold. But we now find that there is a complementary information that comes out from CTC, single circulating tumor cells, which might represent equivalency to that of a tissue or the blood, or it might actually dissociate something from other biomarkers. And the technology, as you see on the left-hand side, standing in Bhubaneswar, I feel, in India, you cannot actually have technologies which are expensive. It cannot be affordable, especially in the over-diagnostication. I call this chemistry as a chemical engineer on the left-hand side. There is a very good phrase, we call it as a Gandhian engineering. So by doing more, buy less for more people is actually putting multiple components into such a complex scenario to capture cell is the principle of engineering this multiple component. So that why our sensitivity today in about 10,000 patients is more than current technologies, because science has evolved with where to conjugate this kind of an antibodies. And the typical cells which are actually measured on an automated microscope in Pune lab looks like this with a cytokeratin presence with CD45 negative and the DAPI as an positive component. We have been approved by DCGI as a medical device company to offer the CTC technology with quality management system. I think few of the last points I would like to mention, look at the breast cancer, which is probably easiest cancer to have a tissue biopsy because of an presence of a tissue. 196 patient, phase 2 multicenter randomized trial in triple negative breast cancer. What it states on the right-hand side, very, very significant take-home message that when ctDNA is positive and CTC is positive, overall survival is going to be bad than actually when one of a biomarker is present. So combination of this dual biomarker can actually improve your patient's overall survival. Even if you ignore to detect this kind of an biomarkers, you will later on, give up and say that the patient actually progressed in the disease. So science has actually, galloped, and we have new technology called as an OncoIndex icon, which is actually antibody which is hooked onto 2 millimeter glass bead, where we capture cancer cell and release them live. And nobody has so far actually, to best of our information, has done so nicely and so wisely with the simplicity. This is our US patent. And we can do single cell genomics today and compare with any of your other tools. Now, what we knew that ctDNA on the left-hand side is very good, enough sensitive for 400 genes or 1,000 genes, what OncoIndex does. But what we did on the left-hand side, we took about 100 patient sample, where we find that about 20 to 25% of patients do not have any mutations detectable. NMDs are there. That's an universal problem. So in spite of a disease, patients do not have any DNA, and you cannot measure any mutation which can be actionable. We found in this patient that they carried circulating tumor cells in variety of stages. And when you isolate each cell, you could get an information which is on the right-hand side with a broad mutational profile, including what we know in advance. We can now further go for the protein expressions on the circulating tumor cell. You can look for the PD-L1 expression, you can look for HER2 expressions, and so on. I think dynamic study is is bringing something very, very phenomenal. If you look dynamic study in stage 2 colorectal cancer patient on the right-hand side, post-surgery, the disease reassessment for neoadjuvant treatment can be actually evaluated. So what this study concluded that the patient who did not have DNA and who had actually DNA, their overall survival was actually equivalent. That means patient who did not have a DNA should not have been treated. And this is very important when we talk about toxicity and the cost as a matter. I think very important study came as a miracle by name, significantly showed the presence of circulating tumor cells in resectable colorectal liver metastatic as a miracle trial. And what it says that preoperative detection of this biomarker did not give prognostication. But post-operative CTCs actually, when they were detected, it gave a 1-year RFS as a prognostic biomarker. So this kind of data is actually very, very important that is coming. Let me tell you, I think the sensitivity of our test. If you know Natera does now liquid biopsy finding for ctDNA on the left-hand side, the same patient sample was actually sent to US and it came to our lab. It was blinded and the test, which is very expensive, did not got any DNA. And remember, this is $1,500 test. We also did the same test. The sensitivity showed no DNA detection. Unfortunately, we found 3 circulating tumor cells test. Now the left-hand side doesn't show the dormancy of a ctDNA because of a less shorter circulating time, but this patient will be assumed as a disease-free because there is nothing at the stage, at a primary location of a tumor. But the presence of CTC, which is a disease in the circulation, probably will move from breast cancer to liver cancer, or colorectal cancer disease can move to liver cancer. And we know lung cancer can move to brain cancers. I think OncoMonitor test does this miracle of combining this ctDNA and CTC in breast cancer, bladder cancer, ovarian cancer, melanomas, lung cancer, gastric cancer, and more predominantly in the colorectal cancer. We can give parallelly the genes which are associated for the primary cancer. Now, I think for the time paucity, I would like to present actually our data in lung cancer, 265 patients. I call this as a quadrant of J&A, Jayant and Arvindan, who have been talking about this by educating. If you look on the left-hand side top order, that when both the biomarker are present in 135 patients out of 265, 50% of present patients carry both the biomarker. That's the worst outcome with patient with a high risk. On the right-hand side, if you see about 25% of patients, they were fortunate that this biomarker was not present. On the left-hand side bottom part, you will see that ctDNA was positive and CTC was negative. That means your surgery was not complete or the treatment was not complete. And the presence of ctDNA is actually predominantly associated with your primary cancer. But on the right-hand side, the best case scenario, when both the biomarkers are absent, you can be at a peace to say that these patients are going to not progress this. But if you combine these 3 quadrants, if you look, about 75% of patients carry either of the biomarker. And that's what is, I think, a dogma in a cancer. I'd like to actually stop here for any questions. That would be better than... More time? Thank you, sir. Let me select the cases. So where do you actually recommend utility of these biomarkers, and when do you want to actually consider? Not every patient qualifies to use CTC, but remember at an early stage patient prior to the treatment, when patient comes in, when you have a CT PET scan, MRI presence over there, the limit of detection of this FDG is about 7 to 8 millimeter, and that's how you confirm the disease. You take an interventional biopsy. That's the time when you actually, before the treatment, chemo-naive treatment, now you pull up the blood sample. We need only 5 ml, and CTC and ctDNA can be a positive or negative in these patients with the standard of care. I think that's a prior to the treatment is very important. After surgery, now there may be some surgeons here who would boldly say that they are best surgeon, which I have met many of them with this statement. But there is never a complete resection, especially when the disease is at the interior. And the disease, like in lung, which is actually typically comes late, and you cannot have such kind of operations very, very meticulously today at molecular or at the DNA level. So after surgery, I think you can evaluate patients for prognostication, which patients will require more chemotherapy cycles or which require more targeted therapy, who needs actually adjunct therapy that can be, within guidelines, this could be considered. Guidelines comes actually far, far, later than that of the new science. After completion of standard of care, like for example, a patient stage 1 breast cancer or colorectal cancer stage 2, or even renal cancers, gallbladder cancers, cholangiocarcinoma, where you cannot have biopsy, but you saw a PET scan, and there is an occasion where you are in doubt, especially in cholangiocarcinoma, because there is an inflammation, there is a positive radiation image that what you see. Some of the doctors, they actually try to send sample for CTC, 2 negative time points in 15 days. They are sure that patient do not have actually any localized or disease in the circulation. So I think after completion of standard of care, including the surgery, the patient could be actually look for this both biomarker. As I showed you in the quadrant on the extreme right-hand side, bottom, you could see that both biomarkers negative is actually a good response to your treatment, and these patients probably will survive longer than other patient. I think treatment response monitoring, for example, it is assumed that there is a guideline, you have done 3 cycles or 6 cycles, and the patient actually is now fine. I think if at all we are serious about letting patient to have maximal overall survival, you need to monitor this patient after 6 months, after 3 years. I will tell you that the difference between HER2 positive patient and triple negative breast cancer is already known. So patient with TNBC, we know that they need to be monitored very frequently. For example, in 3 months, we have some patients who have been monitored 15 time points, especially in pancreatic cancer, when doctors said that patient is completely disease-free, and we find actually tumor cells. We don't know when these tumor cells will cause a disease, but if they present with the PD-L1, we know that this is a bad case. So patients, especially with an Herceptin treatment ongoing process, you don't know when to stop. So many a times, because of a cost, because of a toxicity as in pricing, there's a guideline you continue on Herceptin. And we know that how many patients can afford it for a long time. So there are some doctors who actually send blood sample, look for these biomarkers. When there is a negative biomarker over there or absence of this biomarker, they consider patient for de-escalation for 6 months of a time until patient is completely without this biomarker. I think unresectable and advanced disease is obviously that there is much role to know whether even targeted therapy has improved. So number comes in importance handy when chemo-naive, treatment-naive, if there is a number of 10 cells per 1.5 ml. Post-surgery, the number is going to increase by 3-fold because lymphatic drainage has been hampered. There are more territories for disseminated cells to come in, and therefore immediately after the surgery, 7 days, the numbers actually comes higher. But as the time progresses, the cells will be eliminated, and you will find the lowering of circulating tumor cells after 6 months of a time. And if patient actually has a good immune response, the patient will not have these biomarkers. So longitudinal monitoring, case by case, in personalized era, is most important, which is my take-home message today. Thank you very much.
Thank you so much.
Thank you so much for the wonderful talk, sir. Questions? Yes, yes. Sir, please be here. No, sir. The questions are there.
Thank you. Thank you so much. That was very informative. My question is, do we have a sense of what the clearance of these ctDNA is? Is there individual variability? I mean, do some patients clear it faster post-surgery? And the reason I ask is that we are using these now to make medical decisions about who should get adjuvant therapy. So what's the optimum timing for us to draw these tumor markers?
The washout period should be minimal 7 days. Many clinical trials actually look for the second sample after 21 days, especially in the Miracle trial, if you see it. So yes, I think protein biomarkers like CA are very standardized, and we continue to believe more on them. But proteins have long circulating time than ctDNA. The longer the molecule with molecular weight, they are going to be thrown out faster. So CA markers are actually now going to, be on the backstage very soon. But 7 days is washout time, and 21 days probably is the best time for looking at a patient. But it also depends upon a tumor load, size, right? Its location. Lung cancer stage 2, for example, for you and the pathologist is going to be same. But if the tumor was at a different location, the DNA that actually is a dead component from the dying cells, they need a way to actually come into the circulation. So breast cancer, say stage 1, HER2 positive, is by pathological system. Apology, Dr. Mehul. I think that's a wrong way to stage the cancer patient. Today, the staging could be done on a liquid biopsy. I dare to say, because we submitted one ASCO, I think one publication, and reviewer was hampering that you cannot say liquid biopsy can stage the head and neck squamous cell carcinoma, one of a study with Tata Memorial Hospital, where we showed that disease-free patient carry circulating tumor cells. It's not a loco-regional disease that what you have been saying so. If there was a systemic disease, why do CTCs and DNA would be in the head and neck squamous carcinoma cell? These biomarkers are ability to travel, and we are discussing that, especially brain cancer patients, glioblastomas. If you take a blood for DNA, you would not get a DNA. That brain barrier will not allow it. But we have now several patients in US as well as in India, where patients come to the clinic close to Pune, we pull up the DNA, doctor, we isolate the DNA from the blood. In glioblastoma, we don't find it. But we get DNA fractions in CSF, which could be denatured. So there's a pre-analytical, caveat over there. But what we surprisingly find, there are intact circulating tumor cells. Where they come, how they cross from the lung cancer to go there, that science, we can discuss it later on. But 70% of the time, glioblastoma patient, we find circulating tumor cells. Now, enumeration number is not important here. Because of a power of capturing and releasing circulating tumor cells from the CSF fluid, one doctor in Delhi has actually put a very interesting case we are now communicating. This circulating tumor cells can give an information where your all options actually exhaust. So it's a wonderful science as we speak today, and this is because of an innovations and technologies. One last quick comment. Yes.
I have a 65 years old obese female with a right foot melanoma. Somehow she underwent the wide local excision. I'm pretty sure that it's T2 and beyond, not less than that. But there was no sentinel lymph node biopsy done, and there was no inguinal lymph node dissection done. No doubt there was a thorough pre-op survey, no significant lymph nodes either on the PET CT scan or the ultrasound of the right and the bilateral lower limbs were done. There were no significant lymph nodes. But then when in melanoma, when we see something at T2 or beyond, we would definitely like to have that lymph node data, the information with us, the status of the lymph node. So just because of the age and obesity, not very enthusiastic to further take her up for inguinal lymph node dissection clearance. So I have sent the sample, her blood sample, to your center for CTC and ctDNA both.
You got the report, Doctor?
Not yet. So, I'm fortunate to have you here.
So when your options are not there, I think this kind of a component.
How do you see melanoma there? Like, how many cases have you come across, and how significantly would it?
Yeah, DNA, I think you could find the DNA over there. But unlike like sarcomas, melanomas are actually problematic for at least circulating tumor cells.
okay.
Not much data is there.
Yeah. So,
Yeah, we have a very small sample of melanomas over there. Large one on sarcoma, we are submitting
Okay.
an abstract for ASCO this time. About 70 patients in sarcoma. Melanoma might be just a double digit, 10 or 11.
okay. All right. Yeah, what are you going to do?
We look for the DNA, what is there, if there is a DNA that is being enriched. We would also look at whether there is a disease that is coming from elsewhere, if there were circulating tumor cells. Because, yes, the disease is melanoma, right? But whether it was primary or secondary, are you aware of it?
Primary.
It's
The
a primary.
yeah.
So we unlikely will find anything, especially the tumor cells. And this is yet another attempt that you are trying to find.
Thank you.
We can-
Thank you so much.
Thank, thank you so much, Dr. Kandare. I would like you to please stay here for a group photo after the session. I would request the chairpersons also to stay back for the next session. Is it fine? I'll first like to invite the chair for the next sessions, along with to co-chair our chairpersons, Dr. Atul Sharma and Dr. Manas Ranjan Pradhan. Next is the keynote address on communication pathology results for personalized medicine. How are the surgical members of the Society of Urological Oncology using pathology reports to guide the treatment for prostate cancer? For this, I would like to invite Dr. Murli Varma, sir, to give the keynote address.
Thank you. Thanks to the organizers for inviting me to be part of this fantastic conference. It's a particular pleasure to interact with clinicians. You know, often we have pathologists in their own silos, clinicians in their own silos, and since I'm going to be talking about communication, I think it's great to have both together. Okay, let's see if I can move this. Okay, this fantastic conference started with a fantastic lecture by Dr. Mehul Amin. Now, Mehul showed us how the potential of artificial intelligence. I'm afraid now I'm going to go back into the future. So I'm going back to our basics, back to H&E. I've been 40 years in pathology. I have seen numerous shiny new toys. So when I was in training, we had electron microscopy, DNA ploidy, flow cytometry, immunohistochemistry. All of these were going to sort out all our problems. All of them helped, but none of them have been complete. Today, we've gone to more modern. We've got the drones. We've got the molecular testing, the digital pathology, the AI. Again, all of these could have a role. But let me tell you this. New toys are great, but let's not forget our gilli danda and our marbles and our old toys that we used to enjoy. We need to optimize our basic techniques. H&E is fantastic, because just think what you can do with H&E. Yeah, you know, the amount of prognostication that we can do with H&E. Serous carcinomas of the ovary, we can say low grade and high grade are two separate diseases. They have different molecular. I can say that by looking at the H&E slide. That's the power of H&E. So let's forget the power of H&E. And as I always like to say, you know, when you have a cake, the icing looks nice. But don't forget about the ingredients of the cake. That is the H&E. So what I'm going to talk to you today is going to be a little bit, different. I'm going to talk about the reporting of histopathology data and the interpretation of histopathology data and suggest to you a very radically different approach. Now, that doesn't mean you have to accept what I say, okay? All I ask you to do is to seriously consider what I say, and then you can reject it, and that will be fine. So currently, what do? We collect a lot of data. And what do we focus on? We focus on getting this data accurate, precise, reproducible, and of course, we want a complete histopathology report. And at the end of it, we also think about communication. In my opinion, we've got the priorities wrong. I will try and convince you that precision is less important than proper communication by the pathologist and proper interpretation by the clinician. When we talk about communication, I'm afraid generally we are talking about cosmesis. So we are talking about making the report look good, right? It's a makeup. So it's a synoptic report. It's about how we present the report. It's all about presentation. That's not what I'm talking about. I'm talking about communicating the message that you have seen. We need more focus on communicating the pathologist's interpretation, especially in complex and borderline cases. So I don't have much time here, okay? So I'm going to go through this very, very quickly, just very briefly. So for those of you who want more details, so these are a couple of publications that we had previously. I was very pleased to collaborate with Anita Borges in that diagnostic histopathology paper. And then there was a mini symposium in diagnostic histopathology where we had a series of papers which included one on pathology reporting in general, saying that communication is key. Okay, so if I'm going to ask you to change what you've been doing for the last 40 years, I'd better give you good reasons, right? So why do we need to change? I think there is a communication gap between the pathologists and clinicians. And to be honest, I don't think it's a communication gap. It's a communication canyon. It's a Grand Canyon between you and me, okay? And why is that? So just think. Do you know of any clinical, oncologist or surgeon, an oncologic surgeon or an oncologist who would look at a radiology report but not look at the radiology images? Of course not. They would always look at the radiology report, but in conjunction they look at the radiology images. So if there are any nuances which are not there in the radiology report, they can pick it up from the images. The other thing is radiology is anatomy. Surgeons are very comfortable with anatomy. Histology is all imagination. I have not seen a prostate gland, right? I've seen cross-sections of the prostate gland, and then I don't have a computer to do the three-dimensional reconstruction. I have to imagine it, the three-dimensional reconstruction. Expecting surgeons, or I might dare say even oncologists, to do this mental exercise when they don't look at the glass slides is asking too much. So surgeons don't do histology. So if you see a surgeon at a microscope, he's probably doing a robotic surgery rather than reporting the radical prostatectomy. So surgeons view the radiology, but not the pathology. So that means they're entirely dependent on my black and white report, on what I have said, the text that I have said. And that's where we have a communication gap. So our reports have to bridge this communication gap. So in my opinion, clinicians do not need to know how to diagnose histopathology. They need to know radiology because they're going to review radiology images. But when it comes to pathology, the important thing is they know the significance of the word. So when I say cribriform, you don't need to know what cribriform means or what are the criteria for cribriform or whatever else, but you need to know what the clinical implication of cribriform is, and even better, if you know what the limitations are. So that's more important. So it's an understanding that's required. So I rarely show slides at MDT meetings. When we have a multidisciplinary meeting, I don't show histology slides. I think it's a waste of time. So, but sometimes I show them this and say, what is the Gleason score? Well, it's a breast cancer, right? I could show this, and I'm sure most will say Gleason 6, okay? Who knows, and who cares, okay? So that's my point. Clinicians don't need to see histology. So let's look at some communication issues that we have between pathologists and clinicians. The first one is information overload. Pathologists love data, right? We like to share our data. So we like to collect a lot of data, and then we give it all to you. So here's a report where there's cancer only in one half of the prostate. And that's a report only of one half. So what do we have in there? 11 measurements. There are 9 measurements in the text, and there are 2 measurements in the conclusion. Now, do you seriously expect a busy clinician to go through all of that? So what's the problem with having this extra data? One, it's obviously a waste of the pathologist's time and potentially the clinician's time if he were to read all of that. But more important than that, the urologist might miss relevant information. We had a case in Wales where it ended up with a lawsuit because it was a wide local excision of the breast. The pathologist had given the distances to the margin from every single margin he could think of. One of them was 0. He didn't say it was margin positive. And the patient came back with erectness. And then you get typographic errors. The more you write, the more you've got to check. So here's this report. You've got all this stuff there. Up there in the text, it says 3 plus 4 equals 7. Bottom line conclusion, 3 plus 3 equals 6. Which is correct? I don't know. Then you got the issue of variable reporting. Now, something is inevitable. Now, when you got a continuum in morphology, it's inevitable there will be variation. And that is part, it is inherent. You got the variation in clinical practice. You present the same clinical data to two patients. One patient will want surgery, the other patient will want surveillance. So that variation, so in my opinion, the greatest variation in medicine is not the pathologist, is not the clinician, but is the patient. Because every patient has a different risk tolerance between risk of the disease and risk of the treatment. But the one that we can avoid is when we get variations because we have different rules. Because we got different group of experts sit together and come up with different rules. And that, I think, we should try to avoid. So we had the problem with Gleason grading in 2019, where ISUP and GUPS came with different recommendations. So in a radical prostatectomy, 3 plus 3 equals 6, with less than 5% pattern 4, ISUP would exclude it and call it 3 plus 3 equals 6, tertiary pattern or minor pattern 4, while GUPS would include it and call it Gleason 7. Does it matter? No. Clinicians, these patients go for PSA monitoring. So what is the Gleason score? Nobody cares. So but the point I'm making here is the same message. So one is saying that the glass is half full, the other is saying the glass is half empty. But by having different rules, we are confusing the pathology community and the clinical community. So that's where I think we can avoid this. So the organizations can get together and come with a common way. A more significant one is IDCP. Now, this has been hugely controversial in the pathology community. We've had these huge arguments in academic meetings, and now it's translated to regular practicing pathologists who are seeing more and more of this. So ISUP says that to include the IDCP in the Gleason score, GUP says exclude it. So 3 plus 3 with cribriform IDCP would be 3 plus 4 equals 7 by ISUP, or 3 plus 3 equals 6 by GUPS. Now, all this sounds very different. Now, 3 plus 3 with comedonal necrosis IDCP would be 3 plus 5 and 3 plus 3, right? So it can be a big difference. But is it actually a big difference? So what does GUPS actually say? So what GUPS says, exclude the IDCP from the Gleason score, but then add a comment regarding the adverse prognosis, and generally do not offer active surveillance. This is bad news. So what are they essentially saying? Manage this patient as a high-grade cancer. Don't manage this patient as a 3 plus 3. So both are saying the same thing. GUPS and ISUP are not saying different things. They're saying the same thing, but in a different language. And again, it's a communication issue. So this is what, there was a paper published by clinicians saying that, and so this was an editorial we had written about it, that this can confuse clinicians. So the point here is that GUPS and ISUP are saying the same thing. It's only the way they're communicating it. GUPS is communicating the message in a comment. ISUP is communicating exactly the same message in the Gleason score. Now, finally, the bane of our life. 90% of my biopsies are straightforward. My second-year trainee can do the biopsy at least as well as I can. The problem is when we get the borderline cases. So the borderline grade. So that's the one that takes all my time. The rest of our cases takes no time at all. The borderline is a Gleason 6 or is a Gleason 7 or so on. Low grade, high grade. So like this sort of case, is a Gleason 6 or is a Gleason 7? This is from an inter-observer study where even among experts, there was significant variation. Many experts called it Gleason 6. It was almost, I think it was 60-40 between Gleason 6 and Gleason 7. But this is significant, right, clinically, because this could change the patient's management, the Gleason score. And this is not just about the Gleason score. Urothelial carcinoma, the grade could definitely change whether the patient gets BCG or no BCG. But we know there's significant inter- and intra-observer variation, even among experts. So what can we do with this? So now I'm going to try and convince you that these borderline grades, precision probably doesn't matter. We don't need to be precise. So this is a couple of papers again. So if you want more details, you can go through these. So this is a paper in an editorial in JCP where we had eminent pathologists from gynae, GI, so multi-specialities to make this point. So the point I'm trying to emphasize here, this is not just about prostate cancer grading, it's about all grading. And what we have explained in this paper is that when it comes to borderline grades, precision is not critical. In borderline cases, it is all about communication. This is a paper we had published previously where Sean was one of the co-authors, where again we emphasized that communication is the key. So when we look at Gleason score, what do we have? We have a continuum. Yes, it is a morphological continuum, but it's also a biological continuum. And in this biological continuum, we've got arbitrary cutoffs. So if we take, now these numbers are obviously made up, the risk of EPE, tell me. So I like to know, if the urologist wants to know, is this case Gleason 6 or Gleason 7? My question to the urologist is, what would be the minimum risk of EPE that you want for Gleason 7? No answer. What is the minimum risk of EPE that should preclude active surveillance? Is it 3% EPE, 5% EPE, 10% EPE? Again, there is no answer. So this is my point. These cutoffs, it is not just arbitrary morphological cutoffs, they are also arbitrary biological cutoffs. So what is the minimum where in that spectrum it should be to call it high grade or to call it Gleason 7? So when you get these cases that are in the borderline, the bad end of Gleason 6 and the good end of Gleason 7, the tumors are no different, right? So it's like a PSA of 19.9 and 20.1. 19.9 is intermediate risk, 20.1 is high risk. But those two patients are not different, right? So it's the same thing here. So for that reason, I think it would be entirely reasonable. So if you've got a patient who is very reluctant to take any risk of the tumor, it would be reasonable to treat tumors even at the bad end of Gleason 6. On the other hand, a patient who's very reluctant to get treatment, it would be entirely reasonable to have surveillance for the good end of Gleason 7. So either option, because these are much the same. Now we do that. I'm not saying something that is unique. We do that every day for treatment of hypertension. In hypertension, you've got these cutoffs, which are again arbitrary. So if it's normal, bad stage 1, it's straightforward. But the ones in between, you consider the other risk factors. So same way, when you get a borderline grade, you consider the other risk factors that go in. It's not only the other, and most important of all, the patient's risk tolerance. Now what about these studies that tell you? These studies tell you that clearly there is a difference between Gleason 6 and Gleason 7. Or I could show you similar Kaplan-Meier graphs for urothelial carcinoma, saying there's a clear difference between low grade and high grade. But it's very important to remember that these graphs tell you absolutely nothing about the borderline cases. What these tell you is that the obvious cases of Gleason 6 and the obvious cases of Gleason 7, those borderline cases, the cases that on Monday I would call it low grade, the same slide on Tuesday I would call it high grade. It's on the cusp, right? Those are arbitrarily divided between, some of them will be in the high grade category and some will be in the low grade category. And more important than that, their outcome, as I said, is similar. So their outcome will cancel out each other. So when you get these graphs, the borderline ones, the borderline one which has been called low grade and the borderline which has been called high grade, their effects will be canceled out in the statistics. So what the statistics shows you is that the obvious low grade is different outcome from an obvious high grade. So if I look at this, again, now for simplicity purposes, I'm using like bladder, okay, low grade, high grade. Now clearly, tumors at the good end of high grade and the bad end of high grade are biologically very different. So in this situation, reproducibility is critical. It is very important to distinguish. But it's not a problem because as I said, my second year trainee can very confidently distinguish between a good high grade and a really bad high grade. The problem is at the cusp between low grade and high grade. This is where my second year trainee struggles and I also struggle. So we all struggle. But in this situation, these are not biologically different. And if you communicate this to the clinician, then reproducibility is not critical. So eventually, why do we struggle? Why do pathologists struggle with tumor grading? Again, it's not just about Gleason grading, any tumor grading. Grade is a morphological and biological continuum, but we report it as if it is a discrete variable. Take PSA. PSA is a continuum. So it's less than 3 normal, less than 10 low risk, etc. But you don't record the PSA in the patient's notes as less than 3, 3 to 10, 10 to 20, and 20 plus. You would record the exact PSA value, so you know whether it's close to the cusp or it's away from the cusp. The problem is, as pathologists, we don't do that. We are giving you, so when we only report low grade and high grade, we are doing a bit like saying less than 3, more than 3. So if a bladder TURBT report says high grade, this could be a tumor at the lower end of high grade, which some experts would call high grade, some experts would call low grade. The same expert on Monday and Tuesday, one day will be low grade, other day will be high grade. So that patient, it would be reasonable to at least consider treating that patient as low grade, to give that patient the option of being treated. You would have to tell him that there is a risk if you're going to take this. You are at the bad end of low grade, but that is an option. On the other hand, if you got the tumor at the bad end of high grade, that's a no-brainer. The patient might still choose not to be treated, but the urologist cannot recommend that. The problem is, how does the urologist know? Because if the report does not indicate where the individual case lies. So if all the report has is high grade, as I said, the urologist doesn't look at the slide. All the urologist can see is this black and white words, high grade. So how does he know which one of these two it is? So what do I do in my practice? Personally, I don't spend too much time worrying about the borderline cases. So when I'm looking at the Gleason score and I'm trying to decide whether it's Gleason 6 or Gleason 7, I do a quick one. So if I've got a case, I'm really worried, I can't decide. I try hard to put it as Gleason 6, right? Because we know that we are overgrading a lot of patients. But if it's a real 1, I might report it as Gleason 3+3, focally bordering onto pattern 4. So I am communicating that. So if the clinician wants to ignore that stuff in the parenthesis, he can do that. And he can simply treat the person as Gleason 6. But on the other hand, I'm providing that information. For practicing pathologists, there's another big advantage of doing this, is if your case gets reviewed outside and they change your Gleason score. So if you report it as 3+3, the reviewing pathologist calls it 3+4, it looks as if there's a big change. Obviously, you got it wrong because he's the expert, right? But if you have reported it as focally bordering on pattern 4, it's very clear that this is a borderline case. Same way, if you got 3+4 = 7, a borderline case, just amounting to pattern 4. Now, this is more important in bladder, where you got just amounting to high grade, is, I think, useful. So, but then we had this with Gleason score 3+4 = 7. So where it may be a good 3+4 or bad 3+4, then obviously now what we do is we don't just report it as 3+4, we give the percentage pattern 4. Right, so we've got that there. So again, you've got a spectrum of the percentage of pattern 4. So if you have very little pattern 4, it may be suitable for surveillance. If you've got a lot of pattern 4, near 50% pattern 4, the patient may not be suitable for surveillance. But remember, there's a problem here. Percentage, by definition, has a numerator and a denominator. If the denominator is very small, you will get a spuriously high percentage. So 80% pattern 4 in a 2 millimeter tumor and 80% pattern 4 in a 20 millimeter tumor may not be the same beast. Again, you don't need precision. So, again, sometimes pathologists try to get this percentage pattern 4 precisely right. And I have seen this in practice where on review, the reviewing pathologist has changed the percentage pattern 4 from 30% to 40% or something like that. It's silly to do that. So let me show you this. So when we start talking about precision in prostate biopsies, these are 2 large studies comparing the biopsy Gleason score with the radical prostatectomy Gleason score. The one on my right is from Sweden. The one from the left is from Hopkins. These are big-name pathologists. They certainly know how to score, how to grade prostate biopsies. So let's see, how did they fare? 4 + 4 = 8. About 50% of these patients were upgraded. Okay, we know that. Okay, you got the sampling error. But look at this. 4 plus 4 equals 8. 1 in 5 of the patients with 4 plus 4 equals 8 in a biopsy would have either 3 plus 3 or 3 plus 4 in the radical. That is a big jump. Now, this is partly got to do with sampling error, and partly it's got to when we report the worst score, right? So what happens is you got a 3 plus 4 tumor, one of the cores happens to hit only the pattern 4, and we end up reporting it as 4 plus 4. But it's not just about the 4 plus 4. 3 plus 4 equals 7, about 20% are undergraded by biopsy. 3 plus 3 equals 6, about 30% are. So you get the grading in the biopsy is only an estimate of the true tumor grade, which is what will decide the patient's outcome. So personally, I, again, don't spend too much time on deciding the percentage. So the way I do it is, if I've got a case that I'm struggling here, whether to call it 3 plus 3 or to call it 3 plus 4. Today is Tuesday. Monday, I would have called it 3 plus 3, but on Tuesday, it's 3 plus 4. So I report it as 3 plus 4. In that case, it's less than 10% pattern 4. So the message I'm giving the surgeon is, this is a borderline, it's on the cusp between 3 plus 3 and 3 plus 4. If I've got a case where I'm struggling, really, whether to call it 4 plus 3 or 4 plus 4, so it's got about, it's got around 95% pattern 4. Again, if I'm going to call it 4 plus 3, call it 90% pattern 4. Precision is not required. If I've got a borderline case, which is sitting there in the middle, right, around 50%, again, if I'm going to call it 3 plus 4, then I will call it 50% pattern 4. If I'm going to call it 4 plus 3, then I'll call it 60% pattern 4. It's the same message that I have given the clinician. And then let's briefly, I think I've got a few minutes left, so I'm going to cover this. This is all very scientific, right? Pattern 4. It sounds very extremely scientific when you look at our report, right? Let's think about what are we comparing. What is your numerator, what is the denominator? Are we comparing the number of cells with pattern 3 with the number of cells with pattern 4, or the amount of prostate involved by pattern 3 with the amount of prostate involved by pattern 4, or the area of pattern 3, area of pattern 4? All of these are different. Let me show you this. Here's a biopsy. Now, on this side of the biopsy, it's all pattern 3. On this side of the biopsy, it's all pattern 4. So how do you grade this tumor? So if you go by area, then there's almost certainly more pattern 3 than pattern 4. So that's 3 plus 4 equals 7. But if you actually count the number of cells in the pattern 3 area and the pattern 4 area, that could well be 4 plus 3. But the important thing here is that it may not be either of those two. These could well be from separate tumors. In this case, were from separate tumor. There was a Parad's 5 lesion anteriorly, and obviously the needle had hit this 3 plus 3 tumor, and then sampled the edge, the tip of the iceberg kind of thing of the pattern 4. So the important thing here is to communicate that it is to communicate that you can score it as 3 plus 4, or you score it as 4 plus 3. Even in the single core, the important thing is to communicate that there may be a separate high-grade tumor. So this patient definitely should not be managed as a 3 plus 4, right? So personally, I would probably call it 4 plus 3 to make sure that this patient doesn't go into surveillance, right? So the point I'm trying to make here is that precision is less important than communication, and I said report interpretation. So here's a case, 80% pattern 4, grade group 3, at least intermediate risk. In our institution, these patients would get a bone scan and definitely would not be a recommended active surveillance. Now, that is fine if you got a 20 millimeter tumor. But if you got a 2 millimeter tumor with 80% pattern 4, that may not be appropriate. So the point I'm trying to make here is the pathologist's job does not end when you sign your report. It is also your duty to help the clinician interpret the report, and not just at the MDT. So when you have a complex case, I know it is harder if you're in a private sector where you're dealing with numerous clinicians that you don't know at all. But it is important to communicate. That communication often is for me, it's often by phone. Because I do have the clinicians I work with, I have their mobile numbers. I would text them, are you free? I want to talk to you about this case. Now, that may not be feasible for all of you. But as much as you can, you should try and communicate. Write it in your report. You may write it in coded language if patients are going to read your report. but that this is an unusual case, and it's a good idea for you to get in touch with me to discuss this case. Okay, final, okay? I've got 2 minutes left, so let me deal with a very different communication issue. So far, we talked about a problem. This has all been communication between pathologists and clinicians. This is a problem between a different type of communication. I think many of you, I'm sure, report the percentage of core involved by cancer. Okay, so individual core, whether 20%, 30%, whatever, how much of it. And this is used in some of the nomograms. What's the rationale of this? If you think of it, it just doesn't make any sense, right? A 4 millimeter tumor in a 5 millimeter core is 80%. A 10 millimeter tumor in a 20 millimeter core is 50%, which is likely to be the larger tumor, definitely not the 4 millimeter tumor. So this clearly is not very scientific. So why did we come up with this? So why did the experts recommend this? The main reason for that, as I said, more benign tissue cannot make the tumor behave better. It's like saying a breast cancer in a bigger breast is going to behave better than a breast cancer in a smaller breast. That's clearly nonsense. But then the rationale, it was a sensible recommendation. The recommendation was that pathologists said it's going to take them too long to do measurements. Percentage is easier. It was a simplicity. The problem is the experts did not communicate that to the practicing pathologists who actually do the work. And that resulted in several pathologists, certainly in the UK, and I suspect there will be some in the US too, who measure the tumor, measure the core length, take out their calculator, and then report 17% core involvement. Like if you see the report I just showed you, right? You got 47% core involvement, 67% core involvement. So they have measured the tumor length as well as the core length. So by not communicating it, that what we wanted them to do, we had the reverse effect. We were trying to save them time, we made them waste their time. So my take-home messages, in borderline cases, focus on message communication. Personalize your reporting based on the clinical scenario. I think as pathologists, I think we think far, far, far too much about specimens and data. I think we need to focus less on data, more on the patient. As I will end with this, a very nice, pretty album, but you can't post any letters with these stamps. Unlike this pretty album, pathology reports have practical utility. So don't just, because the data is pretty, that is not a good enough reason to put it in. Thank you for your attention.
Thank you so much, Dr. Verma, for the wonderful talk. And as a surgical oncologist, I cannot agree more that we need to communicate more.
So I just have, thank you for setting the whole conference on a provocative note, and it's a very good message. So I have just basically 3 comments. So I don't think anybody will disagree on the message of communication. And thank you for reiterating that. And that's why this conference is so good, that we can all communicate with each other across disciplines. The comment about the borderline cases is also very relevant, that we need to do it more. My experience, and I have led pathology reporting in the US for 15 years, and there are 2 issues that I think I want you to think about. Yeah. First is, when you express borderline and uncertainty, they don't think it's a borderline case. They think it's a borderline pathologist. So it's just sort of, hey, these people don't know what it is, and they think is it really 3, and they are not 4. So I'm just giving you that. And that has led, unfortunately, in my opinion, to reliance on like normograms and companies like Oncotype DX and all, which will give you percentage. So what I would like you to think is clinicians want definitive opinions. So I don't deny that we want communication, but the clinicians are busy. They're saying, don't bore me with 3+4. Tell me what it is based on your guidelines. With 3+4, I need to manage the patient and the cost and when I'm going to do the surgery or whatever. So they like numbers. And that is why, in fact, most of the new companies that are coming out are giving a number, and the clinicians like a number. So just wanted you to respond. Yeah, and we are not disagreeing, but...
Oh yeah, I quite understand. I totally agree with you. Now, this is where we have got the same problem with I'll answer your question because it's related. About how many tiers do you need for grading? Now, clinicians like few tiers. If I give you a 10-tier system, to incorporate that into your algorithms and nomograms would be a nightmare, right? So, like bladder grading, so clinicians like a low grade, high grade. But I feel strongly that we should not do that. Pathologists should report multiple tiers, which you can then convert into a 2-tier system. So if you give me a choice, if it was left entirely to me, fortunately, many of you might say very fortunately it will not be, I would have a 10-tier system for bladder cancer. I have no problem with G1 to G10. And then the clinicians can decide whether G1 to G5 is low grade, G6 to G10 is high grade. Or G1 to G3 is low grade, G3 to G10 is high grade. They can decide which one. And for the pathologist, it's actually easier because now I don't have to worry whether it is G4 or G5 or G6, G5 or G6. It's whether it is G3 or G7. That is what will matter. So the spectrum. And we do that with, so to answer your question, Mehul, I think again it's about communication and education. I think this, again, I don't blame the clinicians. I'm sorry. I blame the pathologists. I blame us. So we have given you all the impression that this is all black and white. And you know, I've heard this many times, that clinicians can't deal with uncertainty. Sorry, give me a break. You guys deal with uncertainty every day of the week. I mean, every patient, you're dealing with uncertainty. If a patient comes with chest pain, for the cardiologist, there are several reasons of chest pain, and the cardiologist is going to go by probability, right? So is it more likely to be a heart attack or less likely? So dealing with uncertainty is part of a clinician's daily workload. I think as pathologists, we need to explain to clinicians that pathology is just like clinical medicine. There is always a gray zone. For us to pretend there is no gray zone, personally, how do I put this? It's almost bordering on scientific fraud, okay? So if I pretend to be certain when I am uncertain, I don't think that is scientifically correct. So you have to convey that to it. So if you obviously try to be certain, but the other advantage of what I'm telling you here is that you are catering to both groups. So if I put 3 plus 4 equals 7, or just amounting to high grade, or high grade just amounting to high grade, the clinician can ignore that. So he's still got his high grade. But if you got a clinician who wants to stratify, risk stratify his patients, want to offer his patients more, he has that option. If you don't provide him that, he can't. He doesn't look at the slide. So that's it, right?
Thank you for taking into consideration what we view your pathology reports, so really appreciate that. I think nuclear medicine has dealt with this for a long time. I mean, especially now with PET imaging, they give us SUV, mean, max, things that really are completely a black box for us. So Mike, in addition to all of the messaging that you had, I think a very relevant one is what's in the body of the text and what's in the impression. And I think most community physicians, I can swear it, only look at the impression. So where your messaging can be really a strong message would be more focused on the impression, where you've got a lot of uncertainty in your body of your text, but could the impression be the final statement?
So that's valid. I think, and again, it's an interesting one, how the pendulum has swung. When I was a trainee, histopathologists were essentially like Arthur Conan Doyle, I think, failed authors, okay? So we couldn't publish our books, so we write 3-page reports, which essentially nobody writes. Okay, so that was where everything was decided, the square cells, the shape of the cells, and things that clinicians were not interested in. Today we've gone to synoptic reporting, but my worry is that the pendulum has moved too far. So the problem with synoptic reporting now is that it looks, in a borderline case, you still have to put the comment. And I do see that many pathologists don't do that. Synoptic report is great for bog standard cases. For most, 90% of cases, synoptic is fine. But those remaining 10% of cases, it is very important to put a comment in there. So I agree with you that I think we write too much in our, so we do put, I'll give you going back to my Henry Ford days, where I think I trained under Mehul. Mehul was my consultant when I was in Henry Ford. And we used to have a very whole report, and we were allowed to do this only for benign biopsies. Skin, comma, right leg, comma, curettings, colon, seborrheic keratosis, full stop. That is the report. So we didn't write this basically about describing it or features of seborrheic keratosis. And to be fair, even in cancers, yeah, we could do that. So it's essentially putting a synoptic report in a linear format rather than a vertical format. So that, yeah.
Hi, Morelli. Excellent talk, thanks. I just have one question, because I try to, for cores that have a very small volume of cancer, and they have glands that appear to be pattern 4, I've been having this strategy of saying like the focus of tumor is too small to grade. However, I see something that looks like pattern 4, and the comeback I've gotten is I need a grade because this, is necessary for me to make a decision. And what I tell them is like, well, if you want me to lie to you, I'll give you a grade that's probably false. But the reality is that even with a 1 millimeter, 2 millimeter focus, they are willing to make a decision many times if you have any pattern 4. And, again, I think that that's an issue that the guidelines, if you go to NCCN, right, like the grade is one of the things that will define management. But they don't take any consideration about these cases. So my question to you is, do you think at some point we could consider putting a comment on adequacy of the biopsy, for example, for small cores, when cores less than 1.5 centimeters are considered inadequate, and that can be taken into consideration?
Is always going to be where you draw those lines, right? So, what is adequate, what is not inadequate, it's a judgment call at the end of the day. To your question, we had done a survey, I can't remember, it's a few years ago, at least more than 5 years ago, where we surveyed oncologists and urologists. So we gave them various scenarios, 1 millimeter focus score, 3 millimeter. So this was one case with each one had the tumor line and the scope. How would you treat the patient? No price for guessing. They just ignore the millimeters and look for the largest percentage number. And so 80% would have treated as focus score. So in practice, I think, yes, we have, what I would do in my practice, I would give them the Gleason score, but I would then add a comment that this Gleason score may not be reliable because of that. So it's all about, in these borderline cases, to communicate that. No, I think what the clinician and the patient really need to know is this a straightforward case or is this a borderline case? Because in a borderline case, the patient has more options. If it is a straightforward case, there are fewer options.
Thank you so much, Dr. Verma. Can I please request the speakers and the chairpersons to be center stage for a photograph?
Probably a good pathologists I use to take the back. They're not used to coming forward.
I request Dr. Atul Sharma and Dr. Manas Pradhan to stay back, please. I invite to co-chair the session Dr. Sanjukta Padi. She's here. The next session for the day is by Dr. Atul Batra. He'll be talking on GU cancers, making sense of Indian data and emphasis on conducting a collaborative research.
Good morning, everyone, and thank you, chairpersons. Thank you, organizers, once again for giving this opportunity to present this. After assuming that we have the definitive diagnosis from a pathologist and we are not in the borderline, then we move on to the treatment. And disclaimer that I am a medical oncologist, so most of the data that I would be showing, I wouldn't be showing a lot of data, but would be more of a clinical research data, and after we know the diagnosis. So we'll go one by one into common cancers and the GU malignancies. The first and foremost is the prostate cancer, and we begin with epidemiology. How many cases do we see? It is around 38,000. What is the incidence? If we look at the incidence, it is around 5 per 100,000. Now, if we compare this with the Western countries, it ranges over 50 per 100,000. It's almost more than 10 times. Now, are we diagnosing less? There have been studies that have looked at Asian data that overall, as such, there is a lower incidence of prostate cancer. But what is happening with time is that the prostate cancer incidence is increasing. We have never been into screening programs. Most of our patients do present later stage. So we are seeing that prostate cancer is on a rise, and after 70s, it does become the most common cancer. We're also seeing that it's increasing in the urban registries. If you look at registries, this is the registry data that comes from urban registries. Almost all are showing a steep rise of last 10, 15 years in the incidence of prostate cancer. Is there a variation around the country? Yes. We do see that in cities like New Delhi, Mumbai, the incidence is around 11 to 12 per 100,000. So that's almost double the national average. And if you go to rural areas, it goes to as low as 2 per 100,000, which is a lot lower than the national average. And if we compare with the Western data, it's almost like 30 times less. After knowing the diagnosis, when do we diagnose our prostate cancer? Now, this is extremely important when we compare this. Around 40 to 50% of our patients actually have metastatic disease to begin with. Now, if we compare this with the Western data, it is almost like 10%. So now if we're looking at the mortality from prostate cancer, almost half of our patients that are diagnosed every year, like 37,000 is the national number with new diagnosis. And if we look at the deaths, it is almost as high as 18,000 deaths because of prostate cancer. Why do we have so many deaths? It's because we are diagnosing them late. We're diagnosing them when it is metastatic, it's high volume, high burden disease. Now, coming to research that has come from India over the last, say, 15, 20 years, we've seen a rapid increase. This is prostate cancer. So if you look at, there's a massive increase. Now, if you look at the clinical trials, this is the clinical trials. It's 46 clinical trials. And of these, there are 30 randomized controlled trials that have been conducted over the last 20 years. Now, if you go into further depth, it is actually most of these 30 are global international trials, which are industry sponsored, and we have been a part of it. So we are doing less clinical trials for sure, but now it is increasing. Now, how do we treat our prostate cancer patient? This is registry data. This is not coming from, this is population-based data, which kind of doesn't give you the right picture of what's happening in the metastatic disease. Because once it says systemic treatment, it could include ADT, it could include ARPI, it could include chemotherapy, and at any point of time. So it's a random mix of number. When we look at real-world data, there's actually scarcity of how are we treating our patients. We know that metastatic castrate-sensitive prostate cancer has seen a paradigm shift in the management. Like few years back, before Charted and Latitude came, it was actually just ADT to begin with. Then came abiraterone, then came docetaxel and abiraterone, and now we are dealing with a triplet therapy. Docetaxel and abiraterone, or docetaxel and darolutamide in combination with ADT. Now, we do not have any data that compares this triplet therapy, what we call, like ADT, docetaxel, and either of abiraterone or darolutamide, with a doublet that includes just abiraterone or darolutamide. The comparison has only been with ADT plus chemotherapy. Now, would such a trial be conducted? Unlikely. Can it be conducted in India? For sure, this can be conducted. We see so many prostate metastatic patients, that is an opportunity to conduct and collaborate. What about genetics and prostate cancer? We didn't know anything about genetics till 2016 when the New England paper was published by Pritchard et al. And we came to know that 11.2% of metastatic prostate cancer have a genetic mutation, most common in BRCA2. What happens in India? Do we know? So till now, we do not have any published data. We are in the process of publishing this data from All India Institute of Medical Sciences, where we did it in 276 consecutive metastatic prostate cancer patients. And we found that overall, our germline mutation number is the same, that's at 11%, but there's a difference in the mutation profile. BRCA2 is still the most common, but in place of CHEK2, we have ATM mutation, which is more common. And as we go down, it's RAD51, PALB2. The spectrum of mutation is somewhat different, and we did not find any founder mutation though, but still there was a difference in the pattern of mutations after BRCA2. What about prevalence of somatic mutations? Do we have data from India? Overall, it suggests that around 20 to 25% of patients with metastatic prostate cancer will have HRR mutation in somatic mutations. So this was a multi-center studies conducted across India, and this was just looking at the prevalence of HRR mutations, where this was presented at ASCO GU last year, and we kind of screened 213 patients, of which we did sequencing in 192 patients, and we found that around 21.4% patients had a pathogenic or a likely pathogenic mutation in these genes, BRCA2 again being the most common. Now, in this space of prostate cancer, what all opportunities do we have? So the biggest opportunity, I think, is answering the question that's comparison of a triplet therapy with just ADT plus ARPI. We do not have data to this, and there isn't going to be answer to this. Meanwhile, there are several changes that's happening in the paradigm treatment of prostate cancer. A larger study on prevalence of germline mutation, I think, is also a need of we know our population is diverse across India, and we still do not know if there are any founder mutations that are present in different parts of the country. In this regard, we are collaborating with TMH and kind of doing the 2 institutional data at least to bring out if we are seeing such mutational profiles across metastatic prostate cancer. Then real-world treatment patterns. If we look at data from even the Western world, we're seeing that still around 30 to 40% of metastatic prostate cancer in the community are still treated with just ADT. Not even a doublet, and we are talking about triplet therapies. So we also need to know what are the real-world patterns. We still see prescriptions where patients are treated with ADT alone, which I think every oncologist would agree is not what a patient should receive at this point of time. Then there are some encouraging clinical trials that are going on in India. Dahlia is a multicentric trial, which is a Tata initiative, where a triplet therapy is being compared with ADT plus docetaxel plus a full dose abiraterone versus a low dose abiraterone. So that's a multicentric trial where we are also participating. Then we have in space of metastatic castration-resistant prostate cancer, where we are looking at HRR mutation, either somatic or germline, and then it's a phase 2 trial. We're giving them carboplatin-based therapies, and PARP inhibitors have typically been very expensive, although the cost has come down now. This was very, very briefly about what's happening in the prostate cancer space. Moving on to the next tumor, that's renal cancer. Again, we see around 17,000 patients every year, and the incidence is increasing for both these cancers. Prostate is increasing, RCC is increasing. Now, what do we look at? What kind of patients do we look at? There are 2 kind of data that comes from when we talk about renal cancer. One is from a urology clinic, where most of them are incidental to find, and around 8% had metastatic symptoms. Overall staging, around 17% had metastatic. This was a small study, 142 patients, but when we look at data that comes from a larger center, we see around 40% of patients being metastatic. And if we look at the age profile, we see a lot younger patients. That's almost a dictum that all diseases are diagnosed almost 10 years earlier when we compared it with the Western data. Now, we've also seen a paradigm change in the management of RCC, with immunotherapy being the standard of care in the first line or in the second line. Earlier it was second line, now it's the first line. But we still know that the penetrance of immunotherapy is as low as less than 5% in the community, which is mainly because of financial reasons. And low-dose immunotherapy, there have been so many studies that have been conducted in this space. In head and neck cancer, the TMH study that came in head and neck cancer, where it became the standard of care. So likewise, there have been several studies. Several institutes are practicing a low-dose nivolumab in combination with cabozantinib or a low-dose nivolumab alone later in the lines. We know it works because we know how dosing of nivolumab was done. It was actually done as per the maximal tolerated dose, which is not the right way when we talk about targeted therapy or immunotherapy. And this is how chemotherapy was dosed so that we could see the maximum cell kill. But this acts by a different mechanism. We don't need an MTD. And we have seen responses. All of us are doing that. But this data that was presented last year by CMC was just 14 out of 53 patients received low-dose nivolumab. And they saw that the PFS was comparable, although very small in numbers. This is another opportunity, I think, which does exist in not just in India, but in all low and middle income countries where a multi-centric trial could have been conducted very easily, comparing what happens with the low-dose nivolumab. We still treat most of our patients with VEGF inhibitors alone as the first-line treatment, and low-dose nivolumab does become an option later in line or in a clinical trial setup if feasible. So here, the challenges give us the opportunity. The penetration of immunotherapy is so less that this could evolve into a multicentric trial with low-dose immunotherapy. We don't know what are the real-world treatment patterns and outcomes data. IMDC we use all the time, but we do not have validation or an Indian score here. So these are places where we could work on renal cell cancer together. Next, and I think time would permit just this to be discussed, we come to discuss urothelial cancers. If you look at urinary bladder cancer, around 22,000 patients diagnosed annually, and data from TMH that came shows that almost half of these are non-muscle invasive. Now, if we compare this with West, again, it's more than three-fourths, which are non-muscle invasive. And however, we have a higher burden of muscle invasive and even metastatic disease to begin with. What's more disappointing is that defaults in treatment is more than those who are actually treated. So if we look at non-muscle invasive, most of them actually got treated, but default was still lower, around 10 to 12%. But when we look at muscle invasive and metastatic disease, the numbers of defaulted treatment are actually higher than numbers who got treatment. So this is disappointing, and we need not just an improvement in systemic treatment, we also need penetration of treatment to that community. If we look at the grading and staging of tumor, again, we see that 31% are T1, TA low grade, and T1 high grade as the most common, around 46%. There is poor uptake of neoadjuvant chemotherapy, but that's, I think, still a global issue that most of the early stage patients would still get a radical cystectomy as the treatment of choice. And adjuvant chemotherapy in this trial, actually, in this real world data, it was Gem-Carbo, which was more commonly used, and there was a shift toward Gemcis. We don't know how many patients received dosed in MVAC. We do not know how many patients received Gemcis as neoadjuvant. But this was a trial that was discussed yesterday, and when there was a controversy, there's a big controversy whether a node positive or a bladder CA bladder should receive radiotherapy or not in the adjuvant setting. And this is the trial which has completed accrual at Tata, and we are waiting the results with what happens. Maybe unofficially, I think it increases the loco-regional control rate, but there's no effect on survival. That's what I got to know. And but it has not yet been published. Only the toxicity results have been published. But it's a great leap, I think. This is a question that needs answer in a globally we need answer to this. Then again, in non-muscle invasive, there was a trial when comparing BCG, there was a global shortage of BCG, comparing BCG, mitomycin, and a hypothermic intravesical chemotherapy, and it showed that all three are almost equal when we look at the outcomes. So this is a very, very brief snapshot of what's happening in India across the trials and what are the opportunities we have. And to conclude, I would say all the challenges give us an opportunity to collaborate. Limited data comes in this space from India, and major challenges are inability to afford immunotherapy, but I think that's going to become soon better with the availability of biosimilars. There has been initiative in low-dose studies in breast cancer, in lung cancer. There are several multicentric trials which are going on, but in GU space, still we do not have any such trial in RCC. Scarce real-world data consortium to pool large data. genetics, we do not know our specific founder mutations, we have a diverse population, immigrants coming from other states, and we have a lot of potential to collaborate to clinical trials. We need answers to so many questions that can
India-specific consensus, and do you think there would be an uptake by the clinicians if we have such a consensus?
The first answer is straight away yes. The second, I think it varies a lot. I mean, it also depends on the settings that we work in. Working in a public sector, we have our own limitations. Even if we have such a consensus statement, we may have constraints regarding to the availability of those treatment. I think, personalize those things mostly based on what we have and logistics rather than what that statement would be. So in GU, I think the good thing is that we have several options. Like if you look at metastatic castrate-sensitive prostate cancer, there are options that are maybe available for all like ebiradron, and options like darolutamide, which again give you a very high cost treatment, and there may not be much differences. Likewise in RCC, once I think nivolumab availability becomes easier we're expecting it this year, that we should have a biosimilar, then I think the uptake would increase. But it's a very diverse country, and we have our medical system is not as unanimous. I think it varies a lot with where you work, which sector you work. So the uptake, I'm not really sure. Maybe Sir can comment. He has worked in both sectors.
Yeah, so what I would say that probably it's not difficult. So Dr. Acharya from this very own city, there's a Puri statement, because I practice GI also, Indian Academy of Study on Liver Cancer and this thing. It was led by Dr. Acharya, Dr. Shiv Sharit and this thing. So they have come up with the consensus statement. Because just like many of this thing, RCC, this HCC, hepatocellular, so there is no chemotherapy. Most of the time, this is either the checkpoint inhibitors or targeted treatment. But once you have written recommendations or the guidelines, probably most of the people would agree, because you consist the gastroenterologist, hepatologist, medical oncologist, interventional radiologist also. So this is very much feasible. Somebody has to take a initiation and a step forward, and probably it can be done. Similarly, we have this group for the Indian Academy or study group for the lung cancer. So you have the pulmonologist, because there also is a lot of interference. Basically, I won't say the interference, but this thing, so transition is this there. So there are also a lot of checkpoint inhibitors, equally important, small tyrosines, small molecules and this thing. So they also have. So similarly, I think probably this is very much possible. Maybe there's somebody take initiative and start working on that.
Thanks, Dr. Batra.
Thank you.
It's high time that we should have multicentric trials and we should draw a consensus. So the Uro-Onco Society can take the initiative. Once you have a robust data, Indian data, we can have a consensus. There is no doubt about it. So we are looking forward to it. Thank you.
Absolutely.
Thank you again.
Thank you.
Thank you so much. I have, there is a question from Dr.
Dr.
Menon.
Santosh has...
I think a fantastic presentation, Dr. Atul. Just making a comment about the numbers and incidence which are increasing. So I think prostate cancer has increased by leaps and bounds. You used to see 5 cases in a week, and now it's almost 10 cases a day sometimes. Absolutely. The other thing which is the shifting in prostate is seeing a lot of young prostate cancer. I don't know the reason for it. 20 years back, we hardly saw any cases which were young, but now we have been able to collect in last 5-6 years below 45 prostate cancer, about 50-60 cases we have seen. We are unable to do HRR testing and all that for the lack of funds patient can't afford. But we would really want to, I don't know what the reason is for this. Obviously they are driven by genetics, they must be BRCA mutated, most of them. But 20 years back, we were not seeing those cases. Younger, below 45 prostate cancer.
Yeah, we've seen 32-year-old with a prostate that
Yes,
was, I think,
same.
metastatic with a high volume, high burden
Yeah,
disease.
so most of them are high volume, high burden all the time.
And many of them do carry a mutation. When we were doing this study, there were a lot of young patients who had, I couldn't show the whole data, but I think that will be out soon. But we are also seeing, I think, a lot of patients in 30s. And they behave very aggressively. The outcomes are usually like 1.5 years. No matter what you do, they just don't
It's a nodal medicine, very
respond.
strange supraclav nodal medicine. We've seen several cases. I don't know the reason why younger patients are getting prostate cancer.
Right.
Thank you.
Thank you.
All right, thank you, Merwan.
Thank you so much, Dr. Batra. We can kindly, the chairpersons and the speaker to come center stage for the group photo, please. Quickly moving to the next session, the chairpersons are requested to be seated, so that we can take an expert opinion. We have a robust panelist over here with us. For the next panel discussion on germ cell tumor, I request Dr. Rajendranath to be here. The panelists are Dr. Sandy Srinivas, Dr. Andrea Acosta, Dr. Satyabrata Das, Dr. Soumya Surat Panda, Dr. Abani Kantananda, Dr. Sai Sharda Patro, Dr. Girish Kumar Parida, Dr. Sushant Kumar Paikray, Dr. Ranjan Patel, Dr. Fanindra Kumar Swain, Dr. Shubhrat Kumar Sahu, Dr. Sugyan Mohanty, Dr. Shyam Hariharan.
Good morning, all. As my panelists settle in, I think, wow, that's an extensive panel. We have such an elite number of panelists, and I hope we'll be able to utilize their expertise. And I think the day started off well with how we communicate with each other. So we will see in an interactive discussion. I would urge my panelists communicate as much as possible and as clearly as possible, so we'll have some meaningful discussion. So quickly moving on. So I think we cannot start a panel without remembering the greats. So starting with Dr. Srinivas, tell us more about Dr. Einhorn's contribution and what do you think, the history of our success story, germ cell tumor in brief. Can we pass on the panel?
Thank you so much. No meeting with germ cell can start without acknowledging Dr. Einhorn. In the 1970s, testicular cancer was really not a curable cancer. And then the things that really changed was cisplatin and Dr. Einhorn, really, which made an incredible difference in making this malignancy into a curable one. What I would say personally about Dr. Einhorn, even today you can call him, you text him, and he immediately sends you a message about. So I think it's not just his discovery, but his mentorship and his generosity in giving time to others is really an incredible.
Absolutely. Dr. Andy, I heard that you work with him, so maybe some personal.
He is an incredibly dedicated person. He is well over 80 years old now, and he still attends every tumor board at 7 a.m. And he takes patients as he probably did when he was 40. So to me, that's really impressive. And more impressive still is his willingness to do academic work as much as he used to. So he is an incredibly, incredibly significant person in the field of testicular pathology.
I think among the numerous that we have cured, he has cured, I think Yuvraj Singh was also his primary patient, and that's some snippets. So coming to the medical oncologist, Dr. Srinivas again, how commonly you encounter germ cell tumors in a community practice? Because when we know in big institutes we see, but do you think it's a common scenario for us to say at least a week once? How commonly you see young germ cell tumors in your practice? Dr. Srinivas?
So we happen to be we are not Indiana, we are not Memorial, but I think at Stanford, we typically see about 100 germ cell tumor patients per year. But having seen community practice, I do think that the uninsured, the underinsured patients who end up going to the county hospital, they have a much advanced stage. And I think there is an increase in germ cell in the Hispanic population now. So all of those, I think, are changing. And, the patient population, again, like the previous speaker said, it really depends on where you practice.
Absolutely. Soumya, you work in a big, tertiary care center. So is there a referral pattern? What's your, commonality of germ cell tumors? How often do you see?
Yeah, so again, we presented in this conference only. So we had around 16 cases in last 3 to 4 years whose data could be retrieved. We saw that many cases come in advanced stage, and many cases patients again they get operated also orchiectomy outside, and also they have a bit delayed presentation in our setup.
Sure. I think unlike prostate, we see very few in community practice, and that makes us even more difficult because when in an institute, everything's are in place, but we'll come to that. So coming to the pathologists, I think the communication was discussed. Usually you get a specimen saying, right, orchidectomy done, and it's all yours. So do you want more clinical, inputs? How often do you need to call back the clinician and ask, how will you, basically the histogenesis of testicular germ cell tumor? Can you just brief us?
Thank you very much for the question. That's a very relevant question because we are now moving towards what we call a developmental classification of germ cell tumors as we learn more about their link to developmental biology. So now we believe that they actually come from different types of germ cell tumor come from reprogramming of germ cells at different stages of their maturation during embryogenesis. And the ones that we find in the testis are typically only 3 types, right? Type 1, type 2, and type 3. Type 1 being typically the prepubertal ones. Type 2, the GCNIS-derived ones, and type 3 is basically spermatocytic tumor. So that's a paradigm change. So I think that's in terms of biology and the histogenesis, and there's very good support for that on recent methylation data, on imprinting data. That it's pretty solid. It comes mostly from Denmark, from Osterhuis group. So that's in terms of their origin. But in terms of the information that we need from the clinicians, I think that depends on whether it's an orchiectomy or whether it's a retroperitoneal lymph node dissection. So for orchiectomies, I would say that most testicular tumors are small enough that we are quite confident that they are well sampled and usually completely embedded, at least in our institution, unless they are massive. So I'm not too concerned about not getting a lot of information on a primary tumor. However, in the RPL&D setting, it's much more important to have information on serum markers because sometimes these resections can be huge and we can only take a limited amount of sections. We don't find any viable germ cell tumor, but we may not have information on serum markers, which could be useful for us to go and sample more.
So I was just coming to that, if there is a 27-year-old reported as seminoma and we have a very high HCG, I think it's our duty to, write that, mention to you also, because we should not miss an NSGCT component. So I think communication, as mentioned, is very key. So I think these are the main differentiators. We need to tell us whether the pathologist need to tell us whether it's seminoma or NSGCT from a clinician point of view. And of course, we have the subtypes, which will help us make the treatment decisions better. So do you generally look at molecular studies in germ cell tumor? Because we know in any other solid tumors, nothing ends with histopathology. So how far you have gone? Do you routinely do, or is it part of the research?
So personally, that's my area of interest, so I do it for research purposes. The reality is when you look at primary tumors and genomic databases of primary tumors, and mostly the TCGA data, there's not a lot that you can tell that can be clinically useful. I think what's quite well established now is that we know that tumors that have alterations in the TP53 pathway, mostly as P53 mutations or MDM2 amplifications, tend to be resistant to cisplatin-based chemotherapy. And I've seen molecular studies performed in patients with advanced germ cell tumors that don't respond to systemic treatment, just to see if there's something targetable. And I think Sandy might have a better insight on this, but I think that's the main application nowadays. I don't think there's a clinical application for molecular
Absolutely.
studies.
I think at least in upfront, the good old histopathology should be enough for us to start treatment. Quickly, Andy, just one more take on, Dr. Subhashish, is it? Subhashish Mohanty? No. So, Andy, you can take that. So, quickly tell us what has changed from the class in the 2004 classification. There is some update which has come up. From a clinician point of view, we need to be worried too much, or it's all almost same?
No, I think the changes are, mostly for pathologists, and again, trying to group this seminomas in the germinoma/this germinoma family of tumors. That's important because we know these tumors are similar, whether they occur in the test. There are some differences, but they are similar whether they occur in gonadal versus extragonadal size and in males versus females. I think one thing that has changed that could be impactful is that we consider now, for example, the neuroendocrine tumors that we see, like the well-differentiated neuroendocrine tumors, to be possibly derived from a type 1 germ cell tumor, so teratoma. So that's a significant change, I guess. But other than that,
So I think just a word on GCNIS. We need to be looking it into a specimen orphan, or do you get the contralateral testicular biopsy? Do you get that, and do we report it GCNS specifically?
So I report it when I see it. I think in an orchiectomy specimen, if I see one of the histologic types that are only associated with GCNIS, for example, embryonal carcinoma or seminoma, I don't bother looking for GCNIS. I think it's crucial to try to find it if you have a pure primary teratoma. And if I don't find GCNIS associated with a teratoma, I tend to reflex that specimen for isochromosome 12p fish, because I've seen cases of prepubertal type teratoma presenting in adults, which are published. And that's a significant difference in management. As for contralateral biopsies, they don't routinely perform it in our center, so I have little experience with that.
Thank you. So I think now we get into the clinical part. As we get into the era of precision oncology, and one of my colleagues in yesterday's conference was telling is, before the patient dies, at least once he should have an NGS testing done. So, in that era, I think germ cell tumor is one where we are pretty sure that we can manage most of them with our conventional chemotherapy, and of course with help from the radiation oncologist, surgical oncologist, and the radiologist, which we will quickly go. So this was one of my patients who had 45-year-old gentleman. He came from abroad. He had a right scrotal swelling and his completed family, and we had a staging PET CT done. and then the serum markers in Jan 2021 was normal, and he underwent a right high inguinal orchidectomy. So I would just ask the nuclear medicine specialist, how often we get a PET CT as part of the staging, in practice, or, yeah.
Actually, for staging purpose, we don't get much patients, and also it's not, as per incision also it's not indicated as it will not add any benefit in staging purposes.
Yeah, so you don't recommend it, so you don't get many patients also. I think you are in a good place. But many of us clinicians, we get, instead of doing a CCT abdomen, CCT chest, if you have a high resolution CT combined with a PET CT, it works out cheaper for us. So many of us do offer a staging PET CTs. Soumya, your thoughts on that? PET CT, do you recommend in staging, or you go by the guidelines only?
Mostly by the guidelines, sir. We don't recommend a PET CT scan.
I think it's more of a logistics issue there. So he underwent a right inguinal orchidectomy, and the PET CT showed that it was a localized disease. Radiologist, can you just tell me that even after a proper staging, will you be screening the contralateral testis and giving a report in all the patients?
Yes, sir. If patient has any scrotal swelling, then obviously ultrasound is the first imaging of choice. And in every cases, we often screen the contralateral testis also, and to look for the any mass is present or not in the testis.
Sure. So let's say in this particular patient, the contralateral testis showed a microlithiasis. Will it help? Will it have any relevance? And how would the management differ, Dr. Srinivas?
So, microlithiasis in the testes is so different compared to in the breast. So I think if we see microlithiasis, I don't think we are going to immediately send the patient to surgery. Clinical exam looking for any palpable swelling still remains the number one per guidelines. And if the exam change, I think it's good to have a baseline ultrasound first, so that if there are any changes, we can then use that to determine treatment options.
Dr. Das, I think from the surgical point of view, if you have microlithiasis, will you be keen to do a biopsy of the contralateral thing, or how would you discuss with your oncologist? Yeah.
No, thank you, sir. Actually, microlithiasis, as madam mentioned, it is quite different from the breast. As we see, microlithiasis in testis is, we take it quite benign. We do not intervene unless there is a suspicion on the ultrasound. So we will not recommend any kind of biopsy.
I think that's a point to be noted, because especially if we need to conserve the fertility, better to not to disturb the contralateral testis. And most of the guidelines say that contralateral testicular biopsy need not be a routine, which was earlier sort of practiced. So here, the final histopathology was a 3-centimeter tumor. Tumor is limited to the testis, no other high-risk features. They did the CD117, which was positive and consistent with seminoma. Soumya, what would be your option for this patient? Would you like to do surveillance if it is a low risk?
Yeah, so in seminoma, usually in stage 1, we have got the 3 options of 1 cycle of carboplatin and the RT and surveillance. For this patient, since the patient is not having the high risk features, like tumor size is less than 4 centimeter, retitis is not involved, and if the patient is compliant enough, then probably I'll go for surveillance.
So that compliance is a tricky word. You don't know compliant enough. We'll know it only after 2 years. So Dr. Srinivas, what's your experience there? If you put in a surveillance people, they all come back to you, or how do you have some discussion before you put them in the surveillance? The number of scans that are required and the frequent visits to the hospital, or then the patient says, I'll get away with 1 cycle of carboplatin. So do we have that discussion in a low risk? Or?
Yeah, I think for sure. I mean, certainly first one would be risk assessment. So size has ended up being the most important criteria. Even rete testis invasion is somewhat controversial. So certainly size to determine. So we have this discussion with all patients about their options. I would say, zero chemotherapy is always preferable to even 1 cycle. So surveillance is the number one choice for the majority. But I think you bring up such an important point about compliance. And I had a patient who was actually in jail. And for him coming back and forth was really not an option at all. So we ended up giving chemotherapy for that patient just because, getting all the scans was really not going to be an option.
So I think very clearly both the medical oncologists told that surveillance and the carboplatin, cleverly they've taken out the para-aortic EBRT as an option. So radiation oncologists, how often we see the reference given to you for early seminomas nowadays, or the medical oncologists never send the case to you?
Good morning, everyone. This is a tough question, rather. We usually don't receive cases in first stage 1 seminoma. They are usually managed by medical oncologists in most of the time.
So the case referral has significantly come down?
Yes. Usually in radiation, they are not been referred.
Sure. I think then, it's option of plenty. When we have in stage 1, we can go from surveillance to chemo to RT. So that's a lot of discussion, as Dr. Srinivas mentioned, before we take that decisions. Because as she told, no treatment is the better option because you are avoiding them of all the long-term toxicity. But then if you don't treat them and they don't come for compliance, then the treatment is going to be much more intensive in the later thing, which will come later. But I think the real thing which we need to discuss before we implement is that many of them may receive unnecessary treatment, even though they would have been cured only with surgery. So it takes a lot of time to take a decision, especially in stage 1. So again, you mentioned about radiotherapy. So what is the field that you will use, and is there any role for a dog leg field? Because earlier we used to get a lot of orchidectomies which were not high inguinal. So what are your thoughts on that in the current era?
Yes. Actually, if it is a high inguinal orchidectomy, only we can go for a surveillance. But if it is the scrotum is violated, then we should definitely go for a radiotherapy. And in that case, if the scrotum is violated or there is a pelvic surgery, then we should go with a dog leg or hockey stick modified dog leg field. Sure. But in case of only inguinal orchidectomy, if there we are going to give a RT, only para-aortic field is recommended.
Sure. So I think that's the point. If you are giving for stage 1, it should be para-aortic, and that will reduce most of the late morbidities which we see. Again, Dr. Srinivas, there's always a controversy. If we have decided to plan chemo for seminoma high risk stage 1, whether give 1 cycle, 2 cycle, do you do a DTPA scan before you take a call on that? What is the carboplatin dose that you give? Again, do you do fertility preservation before that? So few points on that.
So for any patient with testicular cancer, we have the discussion about sperm banking, especially if there is
any treatment.
If treatment is in plan. So for somebody who just has a unilateral orchiectomy, they typically tend to watch. So sperm banking is definitely a discussion for anybody getting chemotherapy. Carboplatin, I have to admit I use very little. So I've only done it maybe in a handful of patients, and the AUC is it's a higher AUC, so it's around 7, and even in your patient at 45 is somewhat older for germ cell tumors. The oldest patient I gave carboplatin was in the 60s, and it's they do have a risk for neutropenia. You have to support them with growth factors. But I think if it's the right patient, it is a much easier treatment compared to all that we do in oncology with unlimited chemotherapy cycles that
Absolutely.
we do.
Soumya, 1 word, 1 cycle or 2 cycle in your practice generally?
So I give 1 cycle.
1 cycle.
The dose is AUC 7. Again, the dose comes up something beyond 1,000. Then we are a little bit apprehensive, and we discuss with the patient of that part. So we cap it mostly at 1,000. We don't go beyond that. Again, 900 to 1,000.
But the good thing is it's all over in 14 days. Yeah. And you see, what we are worried is we have got prognostication for all. But don't you think this rete testis and size, is it really evidence-based to tell us these are high risk? and we are taking a lot of important decisions based on that. So is there any more novel risk stratification that's coming up, or this is what we are to deal with?
No, but there have been two really nice studies from Denmark, and Denmark has this unique situation where they have a national database and all patients with clinical stage 1 tumors, regardless of their risk status, get surveillance.
Sure.
So there are two very nice studies, one on seminoma and one on non-seminoma, that were published recently, I want to say last year. And the one on seminoma confirmed that retestis, especially when you also have concomitant invasion of the hilum, is a significant risk factor for recurrence, and so is size in seminoma, and so is LVI, which is, I think, a very important change with the past. I think that study had centralized pathology review. So in the past, what happened was that seminoma is very discohesive. So when you process it, there tends to be tumor spreading throughout. So many of the things that are called LVI may not actually be LVI, but with central review, when this is consistently evaluated, it's been shown that it's also associated with risk of recurrence in seminomas. And in non-seminomas, the factors that were considered of high risk for recurrence were actually panned out in that study. So I think it's important. Both factors are important, size and retestis.
Sure. I think this study also showed that once we start giving 2 cycles of carboplatin, then all these risk factors get negated. I know that's also interesting to note. Dr. Srinivas, you wanted to mention something? So I think this is the final consensus which most of us follow. If it is low risk, we try to put them on surveillance as much as possible, and if it is high risk, at least in Indian setting, we try to treat them 1 cycle of carboplatin, and if it is non-seminoma, more of 1 cycle of BEP now. But as Dr. Srinivas is mentioning, such an early disease, bleomycin in, most of us will have a heart in our mouth. Alternatives, of course, radiotherapy in case of seminoma. Do we practice RPLND in stage 1 NSGCT now from the surgeon's perspective? Do you think we should be doing it in any particular subset?
So far as, thank you very much. And so far as stage 1 seminoma is concerned, after PET-CT, there is no benefit of doing RPLND. Some trials have gone like Primates trial or SIMS trial, but RPLND is not a
I think you're right. In practice, most of us don't do staging RPLND. Absolutely. So this patient story continues. We plan surveillance strategy. In the first 3 months, he came for a regular follow-up. Then he was off to Seychelles, where he was working, where some insurance issue, he couldn't do an imaging done, and he presented in June 2022 with severe low back pain into the emergency. The ultrasound itself picked up a large necrotic para-aortic nodal mass, and we then felt we should have checked the social reasons behind, and we should not have let him go with surveillance strategy, but that was always a retrospective thought. So again, this number of scans, if you can see, there's a lot of studies, interesting studies have come up in the surveillance that says that in 5 years, 7 CTs are enough. And there was a comparison with the 3 CTs in 5 years, that is 6 months, and then 1.5 years and 3 years. Dr. Srinivas, is that good enough? Because the data says that 3 scans in 5 years is good enough, but are we confident enough as an individual patient for us to do such a surveillance strategy?
I don't know. I would be worried about that number. I think the radiation that you get with CT scans is also a concern for patients, but we tend to follow NCCN guidelines, and I think it's definitely 3 feels a little less.
Absolutely, yeah. So I think there is data that 3 is non-inferior to 7, but I think we should be sticking to more stringent guidelines in seminoma surveillance strategy. So here we actually did a PET scan again. So I think the nuclear medicine consultant was telling, we need not do in the upfront setting. So in relapse setting, seminoma, do we need a baseline PET scan for you to have a better comparison? Because end of treatment, we are going to do a PET scan to decide strategies. Do you need a baseline PET-CT or a CT is fine?
Baseline PET-CT is not mandated, but post chemotherapy PET-CT is recommended after to look at the viable tumor. And also, all the guidelines recommend PET-CT for recurrence and relapse cases because it has better sensitivity than the conventional modalities.
Soumya, you told you follow the guidelines very strictly. So in relapse setting, do you change to PET-CT or you're again CT and then end of treatment PET only as per the guidelines? Because many of these guidelines has come because of the availability of PET and waiting period of PET is there. You know that in our cities we'll get in the same afternoon if you ask for a PET-CT. So do you think that you do a PET-CT at least in the relapse setting, or that will also be as per guidelines? You do a CT and then PET only if required?
So we are doing a CT, and then if it is more than 3 centimeters, then we are going for a PET.
So as per guidelines, super. That's very nice to hear. So he received 4 cycles of EP. Luckily for us, no major tolerance issue. This was the point I was bringing up. We could have ended up with only a 1 cycle of carboplatin. He had to come off work 3 months for hair loss and all those issues. So the advanced seminoma management is very clear. If you have a more than 3 centimeter residue, you go ahead and do a PET-CT. And then if it is positive, we need to look at surgery, bar radiation, salvage. And if it is negative, you better keep on follow-up. So these are interesting few studies, Soumya, that we're looking at de-escalation in seminoma, because we know that there's a lot of data coming up in ovarian germ cell tumor where carboplatin is sort of replacing cisplatin. And we know that cisplatin is a drug with a lot of late toxicity, including cardiac, neuropathy, and hematologic. So do you think escalation strategy, because this is a trial which showed that if you de-escalate, it doesn't matter. And again, do you ever use bleomycin in your seminoma treatment?
So in seminoma, we try to avoid bleomycin. In non-seminoma,
So most
we
of
have
the
to
time you get the EP into 4.
EP into 4.
The advantage would be a BEP into 3, you will finish faster, but you won't take that risk.
Yes, we have had bleomycin toxicity as well, so that's very difficult to manage, and the toxicity are really scary in such a curative malignancy. So in seminoma, where the option is there, we can avoid bleomycin to do that. Regarding the de-escalation, it looks good, but the seminoma can have a delayed relapse as well, late relapse. So probably we'll wait a bit for the follow-up. What's the frequency of relapse in that setting, and then take a call on finally changing in
So
our own
you're
clinic.
sticking with EP into 4. Dr. Srinivas, our main worry or concern as a medical oncologist is getting into a bleomycin toxicity. So any tips or tricks from practice perspective, whom do we actually anticipate? Do we have to do a DLCO regularly? How do you follow up your patient who is on bleomycin?
So I tend to give BEP for most patients because I think 3 cycles, there's less platinum, there's less neuropathy, less risk for hematologic malignancy down the road. So for most patients who are eligible, I think BEP is a safe alternate. People who I avoid bleomycin are age greater than 40, smokers, and also patients who have somewhat abnormal renal function, which is not relevant here because most of them have it. We don't do baseline pulmonary function tests. They've really not shown to be predictive. But we examine these patients every single week. We have them come in. We have them report any cough, shortness of breath. We have one of our nurse practitioners examine them looking for any crackles. And chest x-rays, while it's not greatest, we do those. And again, for me, I feel I've had very few patients where I've had to convert from BEP to EP.
So I think another point would be the profession also. We had a national hockey player who had come. So, if we need the lung function to be pristine at the end of treatment, we can avoid bleomycin in those patients also. This is another interesting study, the SEMI-TEP study, where they actually start off with 2 EP. Then like lymphomas, they do an interim PET-CT. And then if you have a negative PET, you quickly go down to carboplatin. Then, the whole lot of side effects comes from the 4th cycle of EP, all those are reduced. And very interestingly, there was no survival benefit. So I think we are up there once we have the mature results. De-escalation strategy in seminoma would be the way to go. So if you have a seminoma residue, from the surgeon's perspective, do you think it's technically as easy as a NSGCT, or you would like to consult a radiation oncologist? We know that it will be a plastered one and it will be very technically challenging.
In case of seminoma, if residue is less than 3 centimeter.
No, less than 3 PET negative, we are not talking. We have more than 3
More than
PET
3
positive.
centimeter, still then you should go for chemotherapy first.
No, markers are normalized. We have markers normalized. There is a more than 3 centimeter residue with a PET positivity. So we need some form of local therapy. As a surgeon, how comfortable are you to do a salvage RPLND, or would you like to give it to the radiation oncologist?
No, it will be better to go to radiation therapy because post-chemotherapy surgery is very difficult comparatively.
Okay, so you would make an attempt of surgical resection.
Also.
Sure. Yes.
Actually, I beg to differ. We prefer to go for RPLND. Yes, there will be dense fibrosis around that, but in our experience, we have been able to tackle that. And
absolutely. So you make an attempt, and if you feel it is too technically difficult, only you back off. Right?
Sir, I would also like to add that particularly in seminoma, during surgery, the post-operative complications are more. So we need to counsel the patient accordingly. And if the patient agrees to the complication, the best form of therapy is
so the general
surgery.
point is it's not as smooth as NSGCT. You need to be
yes,
a bit worried. Yeah. Radiation side, so post 3 centimeter residue, surgeons not interested. So what will be your dose and planning?
Okay, if there is a more than 3 centimeter tumor, what we will go is that in radiotherapy we will go for that modified dog leg field, and we will boost the tumor, that more than 3 centimeter tumor we will boost, and we will go up to total dose of 36 gray in that case.
Sure, I think it's a slightly larger dose, absolutely. So this particular patient, luckily we got into a sub-centimeter residue at the end of treatment. He is planned for regular follow-up. It came last December, and luckily this time he is in remission. I'm not sure we'll have one more case to present. No, yep. So this was, I'll quickly go into the advanced germ cell tumor, and we had, so in a poor risk NSGCT, Soumya, what will be your plan? You know, this is the other extreme where you know that you have to go all out. So what will be your general plan in a poor risk?
Poor risk, we do consider for a 4 cycles of BP. And so in those cases, most of the patients, they will require a RPLND also at the end of the treatment if everything markers have normalized. And we do also look out for the markers coming down, but the patient is symptomatic, then the teratoma part or the growing teratoma, that has to be in concern.
Yeah. So, Dr. Srinivas, I think the Nordic group has come up with the poor risk is very heterogeneous. They say it is a good poor, intermediate poor, and a poor poor. So if you have a poor, are you okay with BEP, or you want to escalate it straight away, or you put in a clinical trial?
Some of these patients come in with quite extensive disease, especially in the lungs. So you definitely want to see if that patient bleomycin should be avoided. You have an option of doing VIP. Upfront transplant trials have been negative. So I think, we would still consider using systemic therapy, but I would definitely consider doing a non-bleo regimen for those patients.
Absolutely. So now this patient, if you have a 1 centimeter residue, post-chemotherapy RPLND is sort of standard. So do we plan nerve-sparing RPLND in a post-chemotherapy residue?
No. In case of pre-chemotherapy, we can plan for nerve-sparing and that too modified template variety. In case of post-chemotherapy, we should go for bilateral RPLND to remove all the diseases. So it can be possible, but it takes meticulous surgical care.
Sure. I think unfortunately we are running out of time. Dr. Srinivas, yes or no, do we consider NGS testing at all in germ cell tumor at any places?
I think NGS has not been very giving a lot of yield and has been somewhat disappointing in finding new targets. But I think, as Andy said, we do it in the refractory setting for patients post-transplant, trying to see if they would enroll for any clinical trials or if we can find any targeted therapy.
Sure. I think a lot of advances, including CAR-T therapy being tried. But the take-home message would be it's a rare group with good prognosis. We need collaborative effort and communication. And tumor that may need chemotherapy like seminoma, we should look at de-escalation. And as Andy was mentioning, a lot of work in the pipeline and some newer targets hopefully we'll have, including targeted therapy in the future. Thank you for a very interactive panel. Any last words, comments
I
from...
was just going to say there's been so much in this conference about circulating tumor DNA and what that role will be. In germ cell tumor, I know you have microRNA listed. I think its utility and value, especially in determining who should get adjuvant therapy, what should we do post chemotherapies for seminomas. I think microRNA is really going to change, and we really look forward to those
That
results.
would be much better than all these 3 scans, 7 scans which we are talking about. Yeah. Yes, please.
Yeah, so I think regarding the PET scan, I think the decision whether we are offering it or not, public sector or private sector, I think the cost of PET scan has been really brought down. If you go for a CECT chest, abdomen, pelvis, the cost is going to be,
Absolutely, that was
right.
brought about.
And
it doesn't matter. Yeah.
if you are, in good words with the lab or even your hospital, you can get PET CT scan even free of cost. So I think it's as per the clinician and as per one current region, you can definitely choose your PET scan versus with the CT scan,
It's the
chest,
same story
abdomen,
with
pelvis.
the PSMA PET CT.
Exactly.
We are also liberal with PSMA PET CT.
For me, the most worrying thing is, because we are practicing in tertiary care center, we get referrals that the patient had earlier been FNAC'd from the testicular mass and then underwent a high inguinal orchidectomy, or somebody just went inside and did a low inguinal or scrotal dilation orchidectomy. Now my question is, how does it create nuance, or it helps you in the decision making in the stage 1, both seminoma or non-seminoma? Do we have any guidelines for that, or do we all consider as a high risk?
So mainly, I would take that because mainly it's retrospective series. So once there is scrotal violation, surveillance should not be an option, because then there is a chance of this thing. And in seminoma, as he told, most of the time we will err towards radiotherapy if there is a scrotal violation.
So, we are getting opinions. For seminoma, I have seen one, recommendation to go for 1 shot of VEP, not even, carbo AUC7. And for non-seminoma, somebody is saying to go for the 3 cycles BEP because of this scrotal violation. So that's why I wanted any experience or any recommendation from the extreme panelist.
Change your medical oncologist.
Samya,
you want to...
I agree to that. So we will try to stick to the guidelines as much as possible, especially in this highly curative setting. So wherever the recommendation for seminoma in stage 1, you don't have a data for BEP, better to stick to carbo AUC7 just because.
Yeah, but then again, the guidelines were there in patients who had undergone, high inguinal orchidectomy, not where scrotal violation has been done. So that's why I just wanted to know whether you have any special...
Scrotal violation is done, then RT is a preferable option in that case, because the relapse pattern will be
I think the debate still remains. Yeah.
Thank you. Thank you so much. Before we proceed towards our next talk, I would request the panelists and our moderator to please come to the center of the stage for a group picture. It was a wonderful discussion. Now we proceed towards a small talk by Dr. Aditya Sareen, who would speak about beyond immunotherapy and TKI in management of renal cell carcinoma. Dr. Sareen.
So good afternoon, everybody. I think, no, it's still morning time, right? Yeah, good morning. And after such an exhaustive panel discussion, and obviously because of the time shortage, the previous panel discussion, we were able to limit it till only early stage GCTs. We would have had more discussion if the time would have permitted. Now, when we were deciding which topic should be discussed regarding RCC, so we have been discussing a lot about immuno, TKIs. So we just had a discussion and we thought, why not to go beyond immunotherapy and TKI and let us see what the future holds for us. And these are the three major abstracts, or you can say articles, which I was able to find, and to cover it completely in a short duration, which I have been given. I think this might do the justice. So beyond immunotherapy and TKI in the management of RCC, so this is the latest thing that we have to use our adjuvant immunotherapy. Just a second, let me take out my pointer. No, I haven't, yeah. So yes, so as per the latest NCCN, we have the approval of adjuvant pembrolizumab in stage 2, obviously in grade 4 tumors and sarcomatoid features. And for stage 3, you can just offer them either adjuvant pembro or a surveillance. Now, why are we, sometimes we are stuck in a situation where biopsy becomes cumbersome. You get a patient where you are not sure whether to go in or not. And most of the patients, they generally present to a urologist, and by the time they are coming to you, they might have gone for a radical or a partial nephrectomy, and you are otherwise left no way to just, respect the histopath report and you start the treatment. But I think soon this is going to change. We have the results of phase 3 ZIRCON study, which is the ZIRCON 89 along with the gerentuximab for the PET-CT of the clear cell RCC. And why? Because there is an unmet need in the non-invasive diagnosis. We are pushing more towards biopsy, and now something or other things are also happening in the terms of non-invasive diagnosis. Anatomic imaging cannot reliably distinguish between the benign or the malignant. 20 to 30% of the resected small renal masses are ultimately found to be benign. So the renal mass biopsy is invasive and performed infrequently in 15% and often non-diagnostic in 20%. So we were to see carbonic anhydrase in the clear cell RCC. This is a cell surface transmembrane protein induced by the hypoxia. And what this antibody does is it binds to the carbonic anhydrase 9, and along with this we have the zirconium. And this antibody complex is mostly there in patients who are having clear cell RCC. And this is what they have done, the Telex pharmaceutical. And with this, they have been able to demonstrate that if you administer it on day 0 and after you do a PET scan after 5 days, you can have something with the sensitivity of approximately 85% and specificity of 87% with a very few side effects. And they have been able to identify the clear cell. So if you have a patient where diagnosis of the cyst, whether it's a complex cyst or a simple cyst, and you can't go for the biopsy, patient doesn't want a surgery, I think this is definitely going to come in. If we were to see this patient, so this was a 42-year-old male with a 3-centimeter left renal mass, and patient underwent a PET axial of gerentuximab PET-CT, which is clearly positive here, and then patient underwent surgical radical nephrectomy, and obviously post-surgery, it turned out to be a clear cell RCC. Another case, again 57-year male with only 1 centimeter lesion found incidentally in the right kidney. I need 3 more minutes, yeah? 5? Thank you. So 2 minutes, it's going to be way more than that. So management dilemma is obviously the active surveillance, and gerentuximab, again, it just picked up this spot. Patient underwent partial nephrectomy. You can just see only 1 centimeter lesion. And again, it confirmed to be a clear cell. So obviously this is going to come. The next, which is trial by Dr. Pal, which is CD70 targeted allogenic CAR T therapy for the advanced clear cell Carcinoma, well, this was a brainer and it took a lot of energy, but I think in view of short of time, I will have to just squeeze it down. So what they have able to do is that they have identified CD70 and CTX130 along with the CRISPR-Cas9 gene editing to make sure it becomes a anti-CD30 CAR, which ultimately led to this thing. So this they tried in 16 patients, which were post multiple lines with, we all know, a clear cell histology metastatic setting. You can have a PFS benefit hardly 5-6 months if you have exhausted your immunos and TKIs. So what they did here was they gave this CAR T in a way that if I were to show you this swimmer's plot, one patient lived till 36 months. And some of them till again 22 months with a 81% disease control rate. So obviously this is something to look into the future, and patients where you have gone all out regarding your immunos and TKI, this might come into play. And the last trial I want to discuss is this PPAR alpha, which is TPST1120. It was given as a monotherapy and in combination with Nemo, again in patients with advanced, advanced solid tumors. So one part of the trial did contain, RCC. And if we were to see the maximum, this patient, they did well till 15 months. So this is where we are heading, and if you can just see how the patients, post Nivo, Ipi, Cabo, Everolimus, and now after 8 weeks of the TPST1120, their lesions have been gone. So obviously this is something to look forward. So this is the first in class oral inhibitor PPAR alpha, and first in human study for TPST1120 alone or in combination with Nivo, which supports the proof of concept. So in conclusion, it is going to come and it is well tolerated. So yeah, thank you.
Thank you so much. Thank you for that talk. I would request you to stay back for the next debate. You are the speaker. Can I please call upon Dr. Sean Williamson, Dr. T.S. Ganeshan, Dr. Rabindra P. Sabnis, Dr. Sumit Panda to please chair the next two sessions. I would request Dr. Sareen to take up for the topic speaking for the motion, RCC, adjuvant immunotherapy is the current standard of care, and Dr. Sri Gopal Mohanty would be going against him. So over to you. Can I have Dr. Rajiv Rajendranath on the stage for the expert comment at the end of the debate?
So I hope organizers are not going to cut my time this time. 6 minutes again. We are running short and he's squeezing my. Okay. That's okay. That's okay. Just a second. So in the past 20 years, we all have seen how immunotherapy from its microscopic or electron microscopic era, it has gone and revolutionized the treatment in our way of practice. So obviously I will have to speak for the motion, and adjuvant immuno is current standard of care in RCC. So the first question, can TKI cure patients in the advanced metastatic RCC or even in adjuvant RCC? I think we all know the answer to that. TKI is in the adjuvant setting, a lot of heterogeneous data. The best of best is you can just say a SHORE trial, which was having 2,000 patients, had patients of intermediate high risk and very high risk RCC, randomly assigned to sunitinib, sorafenib or placebo, had similar DFS, similar OS, again, a lot of toxicities you can see with both sunitinib and sorafenib. Then you have, the only positive trial was the S-track trial, which the hazards of 0.75. Again, there was no OS benefit in the adjuvant setting. We, as medical oncologists, we want OS benefit all the time. We are after and chasing OS. So yeah, this TKI as well, it didn't do that. And nonetheless, given the paucity options in this setting, the drug was still given the FDA approval, given on the basis of the DFS benefit only. Now, coming to the PROTECT, which was the pazopanib trial, again, this trial compared the different doses of pazopanib, whether the 600 or an 800 mg. Again, the DFS was similar, and it did not did not improve with the placebo. And the DFS improved to be higher with the 800 mg dose. And I can give you in writing that at least none of my patient I have been able to give 800 mg dose in an adjuvant setting. By far, one of my patients is taking 600 mg, and that too, I know how we have been able to, contain the side effect and the toxicity. Exatinib, again, it failed in the ATLAS trial, demonstrated the DFS benefit. And sorafenib, girentuximab, obviously it is again in the development, and sorafenib, it has again failed in the Everest trial. It did show some benefit in the higher risk subgroups. But again, everolimus is also not something a patient-friendly or a medical oncologist-friendly drug. So what was the lesson from all the TKIs? We have the S-track trial, where on the basis of the DFS, you have a DFS benefit of 0.75, and the PROTECT trial, you can give 800 mg pazopanib, and I'm sure we all have been under water because of the side effect of these TKIs. So can checkpoint inhibitors cure patients? Well, let's see. So I'm starting with the CheckMate 214, which made the, soil for our Nivo-Ipi combination in the first line metastatic treatment naive RCC, where Nivo-Ipi and combination was given. And you can just see here you have the separation of curve in the form of the response, the duration of response, and the ORR. They start to separate within 6 months of initiating the therapy. And this is the longest data set that I can show you with CheckMate 214, where approximately 30% patient treated with Nivo-Ipi experienced long-term remissions. And mind it, this is I am talking about in the metastatic setting. What about the intermediate and the poor risk? We have at 90 months, 25.4% versus 8.5% PFS benefit. And obviously, in the favorable group, the graphs, overlapped. And somehow, sunitinib did better by 5% as compared to the Nivo-Ipi. But then again, we all know cancer is a heterogeneous disease. There is nothing homogeneous about cancer. If that would have been, this would have been like treating diabetes or hypertension. That would have been sometimes a lot easier job. So hazards for the OS with Nivo-Ipi versus sunitinib remain stable for 8 years. And this can surely be taken as a point how much longer your immunos can work. So there was a deeper and durable response in the overall study population, and results represents the longest follow-up in the phase 3 trial of the first-line advanced RCC. So now a lot more adjuvant trials were done. Now coming on to the finale, Keynote 564, where advanced RCC, again, metastatic, included, metastatic post-surgery. Those patients were also included, and adjuvant post-radical nephrectomy or a partial nephrectomy, they were also included. And patients were converted from metastatic to a M0 kind of a scenario, considering them to be an oligometastatic. And the latest readout, you can just see from the DFS benefit, in the first readout, you can have a 32% reduction in the risk of disease recurrence at 2 years. And at 2 years, at 48 months, you can see again 10%. So at 48 months, DFS rates is to the tunes of 65%, and in the placebo, it is 56.6%, approximately 10% benefit. Again, we oncologists, we want OS benefit. Well, now here we have approximately 5% of OS benefit, and at 48-month OS rate, again, you can see 91.2 versus 86%. So overall survival, I think I will have to just skip and rush through it. I will just go with the final few slides that Keynote 564 adjuvant IO is significantly increased the OS, the hazards of 0.62. OS benefit was observed across the subgroup. You can have a durable immune surveillance if you start an early immune checkpoint blockade. And obviously, for me, the pros will be DFS OS benefits have been improved. It has changed the standard of care. Favorable safety profile. It was a global trial design, better tolerability than the TKIs, that's for sure. And you are using in other malignancy as well, like in lung melanoma. So you have the, again, NCCN latest guidelines, the approval of adjuvant immuno. So with this, I rest my case.
On the stage to speak against the motion.
So, very good morning, everyone. So, adjuvant immunotherapy is the current standard of care in RCC. I will be talking against the flow. So, whenever I think this adjuvant IO therapy role in RCC, if it's a standard of care, then I'll obviously think like, oh really? So, I'll be taking it with a pinch of salt. So, why that I'll be showing in the next slides. So, let's look at this current NCCN guideline, which is saying that benefit of adjuvant treatment in a resected RCC, so post-nephrectomy. So, adjuvant treatment has not got any clear-cut benefit. So, here even in clear cell high-risk localized RCC, so role of adjuvant treatment is not yet clearly established. That's what the current NCCN guideline. And let's look at some immunotherapy data in the Checkmate 914. So they have included stage 2, 3, all these RCC cases post-nephrectomy. They have compared nivo-EP versus placebo in the adjuvant arm. So they have given nivo-EP for 24 weeks versus placebo, and the primary endpoint was DFS. We can see here there is no DFS benefit. So the Kaplan-Meier curve both are overlapping. The hazard ratio 0.92, p-value 0.5. So this is a negative trial. So showing no benefit of nivo-EP combination versus placebo post-nephrectomy. Again, look at this PROSPER trial. They have compared perioperative nivolumab versus placebo. So preoperatively 2 cycles of nivolumab followed by nephrectomy, and then adjuvant nivolumab for 12 cycles versus only nephrectomy and observation. So again, this is the primary endpoint was recurrence-free survival. We can see here the hazard ratio again is 0.94 for recurrence-free survival. So there is again, this is a negative trial, so no RFS benefit. So both of this trial, Checkmate and this PROSPER trial, both are negative trial for immunotherapy in the perioperative and adjuvant setting. So as this keynote 564 has been well explained by our beloved Aditya sir. So I won't be going in detail. So although this is a positive trial, but I would say rather there is a smart selection of cases as inclusion criteria. So they have included T2, P-T2 with grade 4 sarcomatous features, not all P-T2 cases, what was taken in the previous all immunotherapy trials. Then high-risk cases like P-T3, T4, like basically stage 3 disease and stage 4, those are all post-nephrectomy and post-metastatectomy. There was no evidence of disease post-surgery. So then let's see, so what are the challenges? So, okay, this is the NCCN guideline for stage 2 with grade 4 and sarcomatous histology and clear cell and stage 3 disease. Although the stage 4 also, which are post-resected, there is no evidence of disease. Then the challenges is like, what about the non-clear cell histology? What about the non-European population in keynote 564? And what about PDL1 negative population in keynote 564? Then how frequently we see this stage 2 with grade 4 and sarcomatous histology and stage 3 clear cell and operable stage 4? So how frequently we see all these cases? Again, how many Indian patients are eligible? Again, affordable for this adjuvant pembrolizumab. Let's look at the first point, the non-clear cell histology. This is the Indian data from AIMS Jodhpur, showing that the non-clear cell histology prevalence is about 1/3 of RCC cases. So again, there is no data supporting adjuvant immunotherapy benefit in this non-clear cell RCC type. Second point is, did Indian patients benefited in keynote 564? We can see here for OS, the hazard ratio was 0.54. But if you look at this forest plot, the non-European population, rest of the world, you can see the hazard ratio for OS was 0.81. So anything like hazard ratio 0.81, I would take it with a pinch of salt. I would say the magnitude of benefit is not that promising. Again, look at the PDL1 negative cohort. So PDL1 CPS less than 1, the hazard ratio again is 0.83. So although in a ITT population, we see the hazard is a 0.64, so it looks like the drug is like a tiger. So in reality, if you look at this cohort, PD-L1 negative cohort, in this Asian and European, this our Indian cohort, it's really like a cat, what I feel. Look at this epidemiology. This is again Indian data from AIIMS Jodhpur. Stage 1 to RCC are seen in 2/3 of cases, 65% of cases. Then again, dissecting the similar data, it was presented by SGPJ Lucknow. This is again Indian data, showing 68% cases are stage 1 and stage 2. Stage 4 cases are 15% only, and stage 3 cases are 15%. Out of stage 4, 2% are operable. So dissecting all these findings, doing some more calculation, if you see, altogether 14 to 15% cases are only fitting to the NCCN recommendation of adjuvant immunotherapy in Indian context. If you see here that stage 2 with grade 4 and sarcoma dead. So we find stage 1, 2 cumulatively it is about 66%. So if you think stage 2 again 20% also, with grade 4 and sarcoma dead is about 3 to 5%. So stage 4 is 15%. Again out of the 2% operable, so about 0.3%. Take it even 1% also. So stage 3 with clear cell. So stage 3 is 15%, clear cell is, the 70%. So 10%. Cumulative everything, 15% is fitting to NCCN recommendation. Then what about the affordability? This is our Indian TMS data showing that out of 15,000 patients, 2% received the immunotherapy. So out of all patients who are eligible, only 3% are able to afford for the immunotherapy. So combining everything, 15% are eligible for immunotherapy in Indian context. Out of that, only 3% are affordable. So out of 15%, 3% is like something about less than 1 or 1%. So I would say it current standard of care when I am not writing, prescribing the medicine, and I will be subjected to like it is a medical negligence. So I feel in my practice, being in India, if only 1% are going to get the medicine, I won't take it as a standard of care. So again, adjuvant immunotherapy is not the standard of care for me in all RCC. It can be used in very few selected high-risk patients. Thank you, everyone.
Thank you. Thank you so much. Can we have the expert come in, please? Okay, Dr. Sareen, please come for the rebuttal. I will give you 1 minute, sharp.
So number one, whenever we are talking in the academic forums, the cost should not be considered. We all the time, bang on talking about cost and cost. But I think in the current scenario as well, the cost of immunotherapy is going down, and another year or so it will go further down. So the cost should be taken out. The second point, when we are talking about these forest plots, mind it that when the trial are being planned, they are not being planned here to take it CPS score in the primary endpoint or a secondary endpoint. These come later on in the forest plot as a subgroup analysis. And with a pinch of salt, your patient with CPS less than 1, I think they were hardly 42 patients only. If we were to do a cross-trial comparison, then I need 2 trials, one with CPS less than 1, and then the other one, it should be CPS more than 1. Then it would make more sense to give a generalized statement. And the third, well, put your hand on your heart, will you give immuno to your patients in stage 3 or not? Even you have, if one clinical trial data showing OS benefit, what else you need along with the DFS benefit? We have seen the DFS benefit approval in the TKIs. Here you have one trial, obviously it's a heterogeneous disease, but you have OS benefit over here. So with this, I rest my case.
Yeah, thank you. Dr. Shrikopal, would you like to?
Yeah, thank you. So first of all, I would say that finance is not all about everything. I would say before finances, what I said, like 15% are eligible. I'm not talking about, so beside affordability, it's only 15%. So our topic is in all RCC. So it is standard of care in all RCC. So definitely it's not all RCC, it's very selected patients. And the second point what sir has asked, that in clear cell RCC, high risk patients, stage 3, whether you are going to give, yes, I will definitely give, provided, and that stage 3 clear cell, only 10% of all RCC Indian context. So in those 10%, I will be giving the patient is affordable, definitely, but not in all RCC. That's what my point is.
So, do we have anything from the chairpersons? Would you like to? And then we take the final comment from the expert. Dr. Salim.
I think both of them have put the points very well. Clinically, when we see the patients, the dilemma still continues as to whether to give adjuvant therapy, especially in a scenario where radical nephrectomy has been done. and you have a T3A disease, what is to be advised? The clarity is still not there. And I think time only will tell what exactly is the thing. But both of the points are very well taken. Thank you.
Thank you. Doctor, okay.
Sorry, is there room for time for a question? So I think this is such a debatable point. You know, not all patients, it's not just staging alone, right? Ask a pathologist, you know, it's all about amount of necrosis, you know, what other features that there are. So you have to take into consideration what's the % risk of that patient to have recurrence before you offer 1 full year of therapy. Neither of you pointed out the side effects. I mean, to take a full year, there's financial toxicity, but 1 in 5 of the patients on Keynote 564 ended up stopping the trial because of side effects. And the last thing that I would like to consider is that, you know, you showed Checkmate 214, where there is a tail at the end of the curve, where some patients may be cured. We now have 2 trials, the T-NEVO trial and the CONTACT-02, both in the refractory setting, saying that if you have had exposure to immunotherapy, your likelihood of a CR is 0. So I think, you know, we should also think about, is there true harm in exposing this patient to 1 year of immunotherapy? And if that patient relapse, have we made a change in their natural history about what subsequent therapy they would get?
Thank you. Sir, can we please have the final comment from you, Dr. Rajiv?
Most of my points have been covered, but I would add that with the keynote update, it is definitely very valid for us to use pembrolizumab for 1 year. But as in life, each trial we can criticize after the trial decision comes out. The stage 4 NED actually drives a lot of advantage in the trial, because in a pure adjuvant trial, why did they take a stage 4 NED? We are stuck with non-clear cell because they were clear criteria. They could have easily included non-clear cell also. I think the data is coming up. So even if we know that they are very high risk non-clear cell, they may benefit. We don't know whether to use it now. But again, if you look at from an Indian perspective, we have nivolumab, axitinib, sorafenib, all generic, but none of them are working. The only product in the patent is the one which we have, and now whether it is to be given for 1 year or 6 months like Herceptin, or we can use low dose in the adjuvant setting, these are questions which will take many years, very difficult to do in an adjuvant setting, a low dose trial. So in practical, I would definitely use pembrolizumab in a patient who can afford, who fits the Keynote 564 criteria. But then it will, as Dr. Srinivas was mentioning, 20% grade 3, grade 4 toxicity has to be discussed before we make a final decision. A good debate from both of them. Yeah.
Thank you. Thank you so much. Can I please call upon our next speaker, Dr. Lucy Patnaik, to speak on, can we please have you both on the stage for some time? Sir, can you please be here for some time? Yeah, after the next talk, we'll take a group picture and then we disperse. Dr. Lucy Patnaik, who will be speaking about combining systemic therapy with local therapy in metastatic RCC.
Good morning, everybody. After an extensive discussion on immunotherapy in renal cell carcinoma, I have been given this talk of combination of systemic therapy with local treatment, that is stereotactic body radiotherapy in metastatic renal cell carcinoma. So initially, I'll go through the slides of immunotherapy in renal cell carcinoma, and later on, as we proceed, I'll try to say how SBRT has been incorporated in metastatic renal cell carcinoma. Now, renal cell carcinoma, the incidence is 431 to 88 new cases, 179, 368 deaths. It represents 90% of kidney malignancies. 25 to 30% of the patients present with metastasis at diagnosis, 50% eventually develop mets, and the common mets are brain, lungs, liver, bone, with a 5-year overall survival of 5 to 10%. Stage 1, less than 7 centimeter, 5-year OS is 95%. Stage 2, more than 7 centimeter, 5-year survival 88%. Stage 3, 5-year 59%, and stage 4 is 20%. Now this is the evolution of immunotherapy over the last 20 years. When I was a student in 2004-05, we had high-dose interleukins, interferon alpha, followed by sorafenib, then came sunitinib, mTOR inhibitors, temsirolimus, bevacizumab, everolimus, pazopanib, axitinib, nivolumab, and finally we have now nivolumab, cabozantinib, pembro, and lenvatinib. So this is the evolution in the last 20 years, which has changed the landscape of treatment of renal cell carcinoma. Now we as radiation oncologists have not stayed behind. Along with the evolution of medical oncology, we as radiation oncologists have evolved from 2D conventional radiotherapy to 3D stereotactic radiotherapy, intensity modulated radiotherapy, image-guided radiotherapy, VMAT, tomotherapy, cyberknife, carbon ion, and so on. But what is the catch in renal cell carcinoma? We know the biology of renal cell carcinoma is radio-resistant. So renal cell carcinomas are historically considered to be radio-resistant, and therefore conventional radiotherapy has been limited to entirely palliative options. But what about SBRT? SBRT has been proven to have a role in both primary and metastatic renal cell carcinoma, the IROC landmark study. It delivers a very high dose per fraction in few number of fractions, so 30 in 5 or 40 in 7, that way. It induces cell death via hypoxia-mediated vascular effects and apoptosis, whereas conventional radiotherapy targets the DNA. It causes DNA damage and mitotic catastrophe. So, role of high-dose radiation in immune modulation. SBRT has a role in immune modulation. Therefore, the biology of renal cell carcinoma has been targeted. How? High dose per fraction activates also the ceramide pathway. It induces the abscopal or the bystander effect, and the combination of radiation with systemic chemotherapy also enhances tumor kill. Now, these are the prognostic indicators in metastatic renal cell carcinoma. We have the IMDC and MSKCC models, time from diagnosis to treatment, Karnofsky performance score, hemoglobin, corrected calcium, LDH, platelets, and ANC. As per these risk factors, we have favorable risk, less than 1 score, less than 0 score, intermediate risk, 1 to 2 score, poor risk, around more than equal to 3 scores. So systemic therapy in renal cell carcinoma, as my previous speakers have already mentioned, first line therapy is TKIs plus immune checkpoint inhibitors, double ICIs like nivolumab, ipilimumab, recommended for intermediate or poor risk metastatic renal cell carcinomas. PFS is 11.2 to 23.9 months in the first line treatments. Now, how do we combine? The rationale is integration of SBRT with systemic therapy. It addresses drug resistance. So when the treatment fails to first line, the second line can be started also with SBRT. Potential for long-term control versus short-term palliation. Evidence therefore suggests synergistic effect of SBRT with immunotherapy. Localized renal cell carcinoma has various options. We know we have the surgeons here, the radical nephrectomy, partial nephrectomy, thermal ablation, and active surveillance. All these 4 options have their own benefits and risks. So none of this can be best in all the circumstances. So I'm here to say the disadvantages of each of these options and where SBRT can be incorporated. Now, open radical nephrectomy, here renal functional implications of removing the entire kidney. So average decrease in GFR is about 35%. Also in minimally invasive radical nephrectomy, GFR decrease is about 35%. These are indicated for very large tumors, more than 12 centimeter, locally advanced tumors in cases of tumor thrombus and bulky adenopathy. Same also with partial nephrectomy. The disadvantages are potential for local recurrence due to incomplete excision. And here again, it is indicated for up to 7 centimeter or larger mass, and minimally invasive partial nephrectomy can be taken up for 5 centimeter or larger, very selected and complex tumors. Thermal ablation is again an option for renal cell carcinomas. The options are in thermal ablation, renal cryosurgery, and RFA. But what is the catch here? They are used for small tumors, 3 to 4 centimeters tumors. They have to be distant from critical structures, and tumors should be ideally located posteriorly. Now this is the advantage of SBRT, where tumors can be larger, they can be more anteriorly or centrally located. Now thermal ablation is used for multifocal tumors or for recurrence after prior partial nephrectomy, advanced age comorbidities where patient is unfit for surgery, and there is a risk for hemorrhage and post-ablation syndrome. Long-term efficacy of thermal ablation is not well established. Active surveillance is again for localized, very small renal masses with very low metastatic potential. So therefore, recommendations for select MRCC patients, the American Urological Association and the European Association of Oncology, they recommend surgery, that is metastatectomy or ablative therapies, SBRT or SABR, stereoablative radiosurgery. That is a non-invasive process for isolated and oligometastatic disease. The prognosis is again influenced by the number of metastases. There are 3 situations we know: oligometastasis, polymetastasis, and oligoprogressive. Oligometastasis is 1 to 5 lesions, polymetastasis more than 5 lesions, and oligoprogressive, that is worsening of symptoms in 3 to 5 sites during the course of treatment. Now IROC showed that historically considered radio-resistant renal cell carcinomas, here SBRT can be offered as a non-invasive, effective and viable tool. This is particularly effective for tumors more than 3 to 4 centimeters, endophytic and centrally located tumors where thermal ablation cannot be offered. In oligometastatic setting, SBRT offers 1-year PFS of 64% and systemic therapy-free survival 82%. In oligoprogressive, it extends ongoing systemic therapy, delays treatment switch from one protocol to another, and maintains high local control. Phase 1 or 2 rapport trial, they showed 92% freedom from local progression, 1-year OS 90%, 2-year OS 74%. The meta-analysis outcomes are local control 97.2%, grade 3 to 4 toxicity 1.5%, and reduction in GFR is 7.7 ml per minute post SBRT. In oligometastatic settings, 1-year local control 90%, toxicity is 1% only for extracranial as well as intracranial lesions, and symptomatic benefits for bone and brain mets. Now this is the NCCN guideline 2004 for immunotherapy for relapse or stage 4 disease. We have favorable, poor and intermediate categories. Favorable, as my previous speakers have already mentioned, I need not repeat. These are the protocols for all of us in use. This is again for relapse or stage 4 disease. IO therapy naive patients, here axitinib and pembro can be used along with cabozantinib plus nivolumab. Patients who have already received prior IO, they can be taken axitinib, belzutinib, cabozantinib and combinations. This is principle of systemic therapy for relapse or stage 4 disease. The preferred regimens have already been mentioned by my earlier speakers. The Checkmate landmark, Checkmate 214 study, if we see the blue curve and the green curve, the blue shows Nivo plus EP in combination. The OS is 74% versus 60% and 52% versus 39% in poor risk category. In the favorable risk category, again we see 93% versus 88%, and as we move on, 73% versus 70%. This is again the keynote 426 study in advanced or metastatic RCC, intermediate or poor risk features. The blue is pembro plus axi. We see 86.7% versus 72%, and as we move on, 69.2% versus 55.8%. This is Keynote 426, first-line Pembro plus axitinib versus sunitinib in advanced or metastatic setting. Here also we see the overall survival is 95.6% versus 94.6%. So this immunotherapy has been extensively discussed, the Checkmate 214, Keynote 426, Checkmate 9ER. These studies have shown advantage. Where do I stand now? So first, this is a decision tree. If patient newly diagnosed clear cell MRCC, we do a risk stratification, pass it in the tumor board. Low volume indolent disease can be subjected to surveillance. Otherwise, patient can go for cytoreduction. Then again, we categorize favorable or intermediate or poor. If patient is IO eligible, we subject the patient to IO-based combo. If otherwise, we send the patient to tyrosine kinase inhibitors. Now coming to the incorporation of stereotactic body radiation therapy with immuno-oncology. SBRT delivers high-dose radiation in fewer fractions. The local control rate for primary RCC is 97.2%. Grade 3 to 4 toxicity, 1.5%. For MRCC, SBRT achieves 1 year local control of 90% with 1% significant toxicity. Also alleviates palliative cancer-related symptoms like pain, bone, and brain metastasis. 1 year local control rates after SBRT combined with systemic therapy for metastatic renal cell carcinoma. This is actually my subject proper. If you look at figure 1A, SBRT plus TKI plus ICI. So SBRT plus TKI plus ICI, this group showed the highest 1 year local control rate of 98%, significantly better than other subgroups. No significant difference in 1 year local control rate among oligometastasis, oligoprogressive, and polymetastatic MRCC settings. ORRs after SBRT combined with systemic therapy for metastatic renal cell carcinoma, figure 2A, that shows SBRT plus TKI shows 76%, and SBRT plus TKI plus ICI shows 71% higher ORR compared to other subgroups. Figure 2B shows treating both brain and body lesions had a higher ORR as compared to only extracranial lesions. PFS and OS, SBRT plus ICI showed 48% PFS than SBRT plus TKI alone, but no significant differences in overall survival has been observed. This study again by Shiva et al., Ma, Croes, and Francis, this shows patients with less than 5 metastatic sites had better 1 year PFS, 50%, and OS, 83% compared to those with more than 5 sites. The toxicity is grade 3 to 4 incident after SBRT combined with systemic therapy for metastatic renal cell carcinoma. So safety and efficacy of SBRT with systemic therapy, SBRT plus TKI plus ICI, that demonstrates the best 1 year local control rate and ORR, but was associated with greatest toxicity. SBRT plus ICI showed better treatment response than SBRT plus TKI with a trend towards higher progression-free survival, although this was not statistically significant. Now, these are the various trials and findings on SBRT. We have Singh et al., Korea et al., prospective and retrospective as well. So SBRT with cytoreductive nephrectomy, this is a study by Singh et al. Now, SBRT to primary in metastatic renal cell carcinoma, the dosage is 15 gray in single fraction, and dose escalation can be done up to 35 gray. These are the various studies. 1 minute. So these are the various studies of Singh et al., Korea et al., a retrospective study, and Korea et al., a retrospective, both a prospective study and a retrospective study. This is the summary of articles using combination of SBRT and ICI in metastatic renal cell carcinoma. So I have abundant of evidence to prove the incorporation of SBRT with immuno-oncology or immunotherapy and TKIs. So we have studies by Hamas et al., Denjina et al., Ansari et al., and Shiva et al. So where do we incorporate SBRT in immunotherapy? So in between the first author, Hammers et al., he has incorporated in between first and second cycle. Others have given after completion of the 5 cycles of immunotherapy, and the ORRs, you see 56% ORR in all the patients. Now, these are again the pioneer studies, landmark studies. The Radvax shows 56% partial response. Knives shows 19% with 1 complete response. Denchina and Ansari, they all show radiated lesion response is 70% with complete responses. So combination of SBRT with IO studies, Radvax shows 40%. They required prednisolone, details are unspecified, and so also are the other authors. So emerging role of SBRT in SABR, this is the takeaway message for the hall today in combination therapies. Novel strategies combining systemic therapies like immunotherapy, VEGF inhibitors, and SBRT are being explored. Potential for SBRT and SABR in metastatic renal cell carcinoma. SBRT, that is stereotactic body radiotherapy or stereoablation radiotherapy as we call it, is transforming the treatment landscape for renal cell carcinoma, a tumor which was historically resistant to radiation. So we are actually trying to explore the radiobiology rather than just trying to protect the organs at risk. So we have a promising efficacy of primary renal cell carcinoma and metastatic renal cell carcinoma with growing evidence. And the key points are SBRT combined with systemic therapy is non-invasive, safe, effective, and a viable option for metastatic renal cell carcinoma. And SBRT in the oligometastatic or progressive disease provides high local control and can delay the need for switch therapy or systemic therapies for approximately 1 year. Novel clinical trials exploring SBRT and SABR with systemic therapy hold promising results, and I thank the organizers, the entire team of pathologists and urologic oncologists and the medical oncologists for letting us, incorporate our tool into their treatment platform. Thank you.
Thank you. Thank you so much, ma'am. That talk was full of insights and elaborative. Thank you so much. Before we disperse, can we please take a picture, a group picture? Can we all please come center? Thank you so much. Thank you. Thank you so much. Now we move towards our next panel discussion. Can I please call upon the moderator, Dr. Atul Sharma, and also the panelists, Dr. Ghanshyam Viswas, Dr. Just a second, I'm sorry. Dr. Sean Williams, Williamson, sorry. Can you please be on the stage? Dr. Sharada, Dr. Sangram Kesri Panda, Dr. Nitish Acharya, Dr. Guru Tat Gupta, Dr. Sulagna Mohanty, Dr. Garima Saraugi. Can you please come up on the stage, all the chairpersons? Over to you, sir. We don't
I didn't know. Can I keep for the moment? I won't know this thing which all special to the belong. That's why I thought. right, till I organize this thing, so very warm good morning to all of you. And once again, extending my warm regard and thanks to the organizing team and especially good dear friend Dr. Saurav Mishra. And we are going to discuss something about the second line and beyond in metastatic RCC. Pardon me, I may not be knowing some of you personally and may not be knowing this, your specialty, so probably I'll maybe just saying the radiation oncology. Medical oncologist I do know in this thing. So that is to set the stage on role. Probably we'll start with the first this thing. So these are some of them are not here. And the idea is to discuss challenges, treatment strategies, advances in managing metastatic RCC in the second line and beyond. We tried to finish well anyway. They have cut down some time. Probably we'll try, won't exceed the time, maybe that little earlier than what they are thinking. So question to everybody is supposed to take this and probably, so this is something which is going to be more informative for the audience, including me and this thing. So what are the important considerations when treating metastatic RCC in the second line setting we take into the clinical practice? We can start from the Ghanshyam and then we come over to this side. So maybe briefly, I think that probably.
So most important today for any second line in solid tumors, there will be some sequence. So the most important will be a performance status, how well are the comorbidities controlled, and what has been offered in the first line, and what is the residual toxicity of the first line treatment. So this will be an important factor considering the second line treatment.
May add something to that?
To add to that, I think in addition to all the disease-related factors, patient preferences, quality of life, and the financial and the time toxicity of each of these treatments needs to be taken into consideration.
Very nice.
Well, me being a surgical oncologist, I don't think there is much role of surgery in already in a patient being considered for a second line treatment of metastatic RCC.
Need to consider the IMDC classification. As a radiation oncologist, I need to know the EGFR clearance status so that I can plan accordingly.
Anything, anybody from this side want to elaborate more on that or this thing? So this side, maybe Dr. Son, you would like to say about the molecular genomic markers for this?
Yeah, in terms of pathology, I just find it interesting whether you would consider anything about the histology. So you've got histology there, clear cell, non-clear cell. If there are any other aspects of the histology, sarcomatoid, et cetera, whether you would consider that for decision making. But yeah, from my side, I'm not sure of how the molecular alterations would necessarily play in, but I'd be interested to hear from the oncology side about that.
All right. Anybody, any other comment from the audience or? All right. So maybe that quickly for the medical oncologist comes to this thing, Ghanshyam, what are the available drugs which we can use in this thing?
So since today many of our patients will be on IO plus TKI, so now the ones in the second line, if somebody have probably not used because of finances or from some XYZ reasons, then definitely they will be on an immunotherapy combinations. Otherwise, most of these patients will be on some of the TKIs or maybe an mTOR inhibitors in the second line.
Dr. Sharda.
I agree with sir.
So these are, I just listed for the sake of, I think, convenience and for the younger colleagues to remember, these are the drugs which are currently available for the second line and subsequent line. Few of them are really, I think, have gone through the clinical studies, and few of them, the last one probably this thing, glutaminase inhibitor, probably is undergoing the clinical trial that is for this thing, but some of them, so last two probably are not available in the country at this point in time, but most others are easily available in this thing. So we move on to this thing. So we have partly discussed that probably, and maybe that would like to, I request the pathology colleagues to discuss little more about this thing, about the utility of the biomarkers. Unfortunately, I personally feel that there are many, I think, solid cancer, we have so many biomarkers and the treatment guiding factors which are available, but unfortunately, renal cancer has to match with this, it's still racing against the race and this thing. So the pathologist probably would like to comment about this thing, whether how can we get the help from the biomarkers to improve the treatment selection, guiding the treatment selection and improving the outcome. We have the two pathologists, Son is there, and we have Dr. Gurudat Gupta.
I think the biomarkers in RCC as such, they are not in the guidelines, especially in metastatic, we are discussing the second line. So if there is as already said, if there is a need to say identify say sarcomatoid or any other changes, then the biopsy or any other thing can be done. And role of NGS is more for variant histologies rather than for clear cell. So if you want to reclassify or something, then maybe there is a role. But as such, I don't know of the biomarkers which will help improve treatment selection in metastatic RCC.
Son, would like to add something on that?
I mean, we're not seeing too much request of biomarkers for renal cell carcinoma like you have listed there. You know, we often don't get asked to do PD-L1 staining on the tumor since they would probably be considered on a clinical grounds regardless of the staining status in the tumor. But yeah, it'd be interesting to know if any other markers like CA9 or things like that would be relevant. I know earlier we heard about the targeting of CA9. But we, at least in our practice, we're hardly ever asked to do any additional biomarkers other than maybe a NGS looking for targets in a refractory tumor.
So while going through preparing for this presentation, I probably come across these coming up studies, mainly the NGO high and low and TF high and low. Probably they may suggest the response to either the angiogenic VEGF inhibitors or checkpoint inhibitors and this thing. These are the regulatory T cell or effector T cells and this thing. Their level, if you can measure, and probably that will give you an idea whether if TF high, then probably maybe checkpoint inhibitor are likely to be more working. And if this NGO high and this thing, then maybe that these are the where VEGF inhibitors probably may be useful. And of course, probably we haven't seen that much of time is probably not far away when we have the various kind of the omics and the liquid biopsy also will be seeing in the more and more in this renal cell carcinoma and so on. Of course, probably we are not, so various guidelines are available in this thing. Somebody, the previous talk did discuss about the NCCN guideline. We have the NCCN guideline, we have the ESMO guidelines, and probably some other societal guidelines. Maybe that medical oncology can take these questions. What are the distinct drugs which you probably first let's briefly so that everybody gets some benefit in this thing. So drugs probably algorithm for the choosing a molecule as per the guidelines available.
So this depends on whether what has been used in first and second line. Anybody who has used IO-TKI in the first line or second line, the options are really limited. However, immunotherapy re-challenge has also been tried in multiple trials, but unfortunately, as Madam was mentioning, CONTACT-03 trial where they tried Atizo plus Cabo versus Cabo alone, Atizo did not show a benefit, but that was in the immediate pre-treatment. The CONTACT-3 included patients who have taken immunotherapy in the immediate previous line. So I think re-challenge as of now may be difficult except in selected cases where they have had an exceptional response in the first line and maybe at a later line we are awaiting trials. Otherwise, cabozantinib and axitinib seem promising.
So one thing which I haven't seen very often in this setting is that people using these things, a combination of the TKI and mTOR inhibitors. Probably that is something which probably may be looked into actively and this thing. Probably there data coming up and this thing. That is one thing I would like to add on to that. And Ghanshyam, do you want to add something to that?
So again, so before the IO, so what happens, so if there are patients who are on a long term on VEGF, then probably you change into the concept that either you consider another VEGF, probably the tumor is VEGF addict. And if you think that the patient has not had a good response with one of the VEGF inhibitors, then probably you will change to one of a cross resistance mechanism or totally, that is mTOR inhibitors.
So Dr. Mohanty, you are from the radiation oncology. All right, so where do you put yourself into? We had a nice presentation a while ago about this thing, SBRT, ACBR and this thing. So where do you put yourself into the clinical context of the second line and subsequent line?
Okay, so we can be a part of the immunomodulatory effect in addition to immunotherapy. So it reflects immunoreconstitution. There is calreticulin and tumor associated antigen expression when we give SBRT, and as madam already said, we had abscopal effect, bystander effect, and the ceramide pathway going on. So those will take the charge with immunotherapy.
So we come to the couple of clinical cases, probably real life cases, which probably most of us have, anybody who is practicing renal cell carcinoma or treating will encounter sometime during their lifetime and this thing. So this is a 50-year-old gentleman who had a clear cell renal cell carcinoma metastatic. Now he has progressed in the lungs. There are multiple lesions in the lung, and initially he got for 9 months pembrolizumab exited. So we may have the three kind of the scenario where patient have received in the past. It may be just the TKI, it may be combination of IO and TKI, it may be combination of the IO, and probably IO alone also. So this is one of the situation which patient had received in the past, TKI plus pembrolizumab. There are a couple of protocols which are available, so probably maybe that this time this is this thing, pembro-exitinib. It may be lenvatinib, it may be something pembro and other drugs also, avelumab, exitinib. So would like to, so question to the, maybe the surgeon, medical oncologist, everybody. So which are the situations where you prefer to do a repeat biopsy in these situations? Like lung and other cancer, colon or this thing, we prefer to do a repeat biopsy, rebiopsy, breast cancer
So
also.
we have seen this phenomenon in any solid tumors. Somebody who progress early, so we may not do a biopsy because we do understand that we are not going to achieve anything. Somebody who has been a long-term responder, that is beyond a year, so maybe in breast, lung cancer, we try to have a biopsy to find some alteration in the molecular level. But in RCC, we don't have such things because unfortunately this young gentleman who has progressed within 9 months, so if the progression in the lung is not significant, then probably we can bring into an SBRT and continue the same treatment until...
So the question right now is about the biopsy.
So I won't do a biopsy for this patient.
So maybe that let me ask this question to the pathologist. In their clinical practice, Son and Dr. Gupta, how many times you get these kind of the cases where a repeat biopsy has been done within a year of the initial treatment or this thing for reporting or this thing, if you can remember?
We get repeat biopsies of metastatic site just for confirmation of the diagnosis. And maybe they want to rule out the second primary. Maybe that is the rule, and we do prove it to be RCC, and then it is proceeded.
Dr. Son, do you often get requests for the repeat, this thing, reporting on the repeat biopsies?
Yeah, I would say if it's pretty clear clinically that it's progression of the same tumor, we often don't get a repeat biopsy. But in the situation, like was mentioned, if there's a suspicion that it may be a separate second primary tumor, then maybe in that case, or sometimes we'll see a rebiopsy if we have not seen the primary diagnosis, and so then there's never been tissue in our system, in which case we might try to confirm the subtype, like verify that it's clear cell. But I'd say often we don't have a rebiopsy very soon after the first diagnosis.
So suppose the duration would have been probably was maybe the 18 month, 2 years, then would you suggest Ghanshyam or Shraddha?
I think if it is a clear-cut progression and we have a good primary diagnosis, then maybe not in RCC, if I'm sure of this thing. I don't usually do biopsy.
Any comment by this thing, Dr. Srinivas or this thing? Would you suggest that? I'm just trying to ascertain what is the practice across the different centers and this thing.
I think in general, it's nice to establish a diagnosis of metastatic disease. I think as we try to tell our patients, you're going to go through this new therapy, it feels good to have that confirmation, but I agree with the panelists that you don't want to be doing it just for the sake of doing it. And I think in general, we haven't had a lot of new information from RCC, but I agree, I think ruling out a second primary is what has been most valuable. So in general, in our practice, I think most people would do a repeat biopsy to establish a first diagnosis of metastatic disease.
So here we are in the second line treatment, so probably, so this is, all right, so questions, so if this was a single lesion, so will the surgeons would be happy to take it out? The single new lesion.
Yeah, if
he had responded to previous, there is a metabolic response to the previous lesions, but there is a new lesion.
yeah, if patient having good prognostic factors and IMDC criteria, good prognostics.
And what would be those good prognostic factors?
PS definitely will see ECOG 1 or 2, patient can tolerate surgery, and if oligometastatic, and where the location is, that is important. It is accessible, surgical accessible area, then I think we will go ahead with surgery. Remember that, then we will give second line treatment of chemo or immuno.
Dr. Garima?
The disease is progressed. If the progression is isolation to the lung itself and it is metastatic, I will first like to check the primary bulk of the disease of the kidney. Probably the first, in the first instance, when the IO plus
this is post-nephrectomy.
Post-nephrectomy. And the progression is isolated to the lung?
So there are two situations. I'm going to ask the question to medical oncologists, radiation oncologists, and the surgeons. So for the medical oncology, the question will be different. For the radiation oncology and you, the question will be more or less the same. If there is a single lesion, where are we?
So if post-nephrectomy patient, single isolated
post-nephrectomy, post-nephrectomy, metastatic disease, pembroexitinib for 9 months, now progression. So for you, the question is, there is a single lesion, so other lesions have disappeared, there is no metabolic activity on this thing, so lung lesions, there is a small new lung lesion which has appeared, and that is the only lesion. So my question is whether do you think that doing a metastatectomy at this point in time is likely to be useful or not?
So not likely, because the disease-free interval is very small. If it is a single resectable disease, probably I would discuss with my medical oncologist what is the severity.
I would believe for a patient who has progressed within 9 months on IO, I don't think there is any benefit of doing a metastaectomy in this case. For a progressed disease on treatment.
So rather I will differ from my surgeon colleague that within 9 months. Yeah, so because somebody who has progressed on the best of therapy, so now it is better to salvage with a surgery, because likely my systemic treatment won't be much effective unless and until I put on IO plus both IOs. So I'll definitely consider this patient for an segmentectomy or an RFA or an SBRT, rather than putting this patient on any second line immunotherapy, that is post-surgery or post taking care of the local treatment.
Yeah, I agree on that, sir. Because if it's oligomers, definitely we should remove that area. But whether it is resectable or not, that is important. If it's a peritoneal based small nodules and it's suspicion beds which cannot remove, then maybe radiation oncology will take care. But it should be salvaged.
I'll come back to that. So maybe that I'll tweak further. So at this point in time, we are talking about the expertise, evidence-based, personal experience, or we are talking about some data to suggest in this situation.
So these are all evidence. These are eminence and personal experience all put together. So once you treat patients.
So radiation. So,
yeah,
do you
it's-
think that the SBRT or some this thing
Yes,
is
if it's
reasonable?
less than 3 centimeter, we can generally take it with SBRT, and with a dose, if it's central or peripheral, considering that, we can decide the dose, fractionation, and go ahead.
So in your DMG, you have a surgeon and thoracic surgeon, and you are the one and the sick, of course, medical. So is there going to be a fight between you and the surgeon?
So I will win because it's non-invasive.
You will win?
technique. Yes. It's a non-invasive technique and I can take care of.
So you will convince the surgeon?
Yes.
So yeah, surgeons are really very, very receptive to these ideas. Thank you. Sorry?
No, sir.
All right, very nice.
Sir, rather the fight will be if the patient is a government sponsor or a corporate patient, rather than.
All very interesting. So now easy. So we have started something. Noise is being made here. So the question to the medical oncologists, and this is really, really very important question for everyone here. So there are multiple lesions and this thing. Patient has been exposed to one of the best combination in the past. He had one of this TKI. He had one of this thing checkpoint inhibitors. Within 9 months is the disease-free interval. So what do we need to do next? And the reasons for that, what will you choose? Sharda and then Ghanshyam.
I think it depends on the extent of progression also. As you told, if it is a florid symptomatic patient with the lung mets progression,
So
then
it's
I would
clear-cut progression, multiple
Florid.
progressive new lesions.
Okay, then I would prefer to change the line of treatment. I would try maybe
Yeah,
cabozantinib.
everybody will change, but what will be the next line of the treatment?
I
That
would
is the
prefer
question.
cabozantinib.
You will prefer cabozantinib,
But
very
with
good.
the dictum that I would tell the patient about the overlapping toxicity, especially he has had axitinib before, and I would counsel regarding prognosis.
Single agent or along with the mTOR or this thing?
No, single agent.
Ghanshyam?
So I can have two choices here. So right at Sada said, so we can have cabozantinib, or we can have that regimen for the meteor. So combination of mTOR inhibitors. So we can have. Any of
So both are the options.
Right.
Will you go for the PD-1, PDL-1 combination?
I don't think so at this moment.
So there is the data for everything. So there is data for everything. If you really see that this thing, 426, this thing, Pembro, exitinib post, then probably half of them probably on progression got another TKI, and probably small number, 10% of these patients also received this thing, PD-1, PDL-1 combination, IO combination also. So that is one thing. That is not the all. If you see the other combination where the TKI is used along with the checkpoint inhibitors, Javelin, Renal 1, so 204 patients receive at least another one line of treatment. That is another thing, probably not, unfortunately, not many patients will be able to go on to the second line because various reasons. So this thing, they had a TKI, then followed by anti-PD-1, PDL-1 combination, or another combination using the TKI and IO, this thing. You have the CheckMate 9 ER study, only very small proportion of the patient who discontinued the combination of cabozantinib, nivolumab. This was probably not a positive study. It started a subsequent line of the treatment. So probably I would agree that probably all these are the viable options. Unfortunately, we do not have very, very good data or prospective data to tell us about what should be the sequence of the combination in these kind of the scenario. Trials are ongoing. I'll come to that in a minute or so. But probably we are really looking, many of these studies are retrospective studies. Some of the prospective trial did allow crossover, some are probably may not have allowed this thing. So that is complicating this thing. Coming back to the another scenario, this is also, I think, 42-year-old lady with metastatic clear cell carcinoma, or she was on PD-1, PDL-1 combination, and she was on this particular combination for almost 2 years or so. What are the options? So these are unresectable or unsalvageable with the use of any form of the local treatment. So question goes to the medical oncologist.
Since the patient has already progressed on a nivo-IP, I think here the patient is TKI naive. So I would like to consider a TKI, probably axitinib, cabozantinib, or even the patient is unexposed to sunitinib, pazopanib. So I think axitinib, cabozantinib,
So honestly, personally, I'm not very comfortable with using all these drugs. So I may have more experience in A combination or A drug, maybe that B drug or this thing, but not all. So what will be your choice and what will be the reason for that?
My choice will be cabozantinib because I feel in the second line that has the best data. But having said that, cabozantinib is a very difficult.
Is that easy to handle?
No, sir. It's not at all an easy drug to handle.
First slide we said that when we go on to the second line, we see what are this thing, what is the performance stated,
Yes.
what are likelihood
Yes.
or residual toxicity or this
Yes,
thing.
sir. Yes, sir.
So what you are saying is not wrong, but then probably I just want to have some kind of the discussion. So how do we come to a conclusion or this thing decision?
Yes, sir.
So among these TKI, which one is the better tolerated?
Sunitinib, pazopanib, cabozantinib, and the
Actually,
least
so none of these TKIs.
There are some class side effects.
Yes, so yeah, none of these TKIs, if you give it the right dose, they are easy to handle, not easy to handle. But again, we have seen that these, as we go down with the dose, and we have seen across all solid tumors. So the advantage doesn't get changes. The toxicity definitely comes down. So somebody would not tolerating 60, 40. So we have even tried 20, alternatively 40 and making it 30. So they does well. So the diarrhea comes down, the plantar, the hand-foot syndrome comes down. And they tolerate. Axitinib 10 milligram is not tolerable in spite of patients putting on 1, 2 antihypertensive and then putting the patients on 5 milligram. I have a patient who is on for last 1.5 years.
So, sir, there is some data to say that cabozantinib dose intensity is important actually. So that is where, and cabozantinib has horrendous toxicities. So I do prefer lenvatinib or lenvatinib.
Cabozantinib dose, that was in the first line, not in the second line.
So anyways, that's what I'm saying. Some TKIs are there, even second line. So the principle is like if you can give it in a continuum and you can suppress the pathway rather than
continuous. So it is not 60 or 40, sometimes 20.
Many
40.
times you need to discontinue actually because of the grade 3. But that is where the problem is with cabozantinib.
So you are going to
So
discontinue
Dr.
if there is
Srinivas,
a
you are
grade 3 and
welcome
more.
to chip in or probably intervene or give your opinion.
Yeah, I think the half-life matters. What the patient ends up after ipi-nivo, are they suffering from a lot of diarrhea? They're suffering from a lot of skin rash. All of those should be taken into consideration. But for a TKI naive patient, I think axitinib is a very, very well tolerated drug. And its half-life is really short. So you can, to your point, I think all of these drugs are toxic and you have to learn how to manage the side effects. And the only tool that we really have is dose holds or dose reduction. And I think amongst those, cabozantinib has the longest half-life. So you end up having to keep the drug off for at least 1 week before you can start seeing the levels come down. So I don't know, there is no right answer, and I think it's whatever your comfort level is. But some of the considerations, I think, would be the half-life of the drug.
So personally, I use axitinib, and probably hypertension is probably one of the most common problems. So it's well controlled, and sometimes you get this thing, glossitis and other these things. But I am personally, I'm using axitinib in the second line and this thing particularly.
Sir, if there is sarcomatoid histology, would that help you in deciding some of your regimen? Is there anything to say, Sean, you can take it up? Sarcomatoid is bad, rhabdoid is bad. So at progression, is there any data to say that we get sarcomatoid if it was not initially there? Because that may change the treatment plan or something.
Yeah, that's a good question. I don't often recall seeing sarcomatoid in a metastasis that was not in the primary, but then I guess sometimes we may not, if you've had only a biopsy of the primary or something like that, we may not have seen the whole thing. Yeah, that's interesting. I don't recall seeing that, but it's probably possible.
Yes, please.
My only, sorry.
So Saurabh, I would have preferred for in this case, if not TKI exposed, rather than axitinib, I will prefer a cabozantinib.
Personally, I have encountered 3 patients, one clear cell with sarcomatoid, one chromophore with sarcomatoid, and all of them, what you see in metastasis is the sarcomatoid component. This is my experience. I don't know.
I think in terms of selection of therapy, Saurabh, to your point about sarcomatoid, it's much clear in the front line that the minute you have sarcomatoid, immunotherapy has such a big role. And I think I personally would choose CP-Nivo because they have such a high chance of response and a high chance of complete response in patients with sarcomatoid histology. In subsequent lines, we are clearly not continuing immunotherapy. So for somebody who's immunotherapy exposed, I don't think sarcomatoid changes or gives us any big guidance in terms of which TKI to select.
So I'm sorry, probably this is second and subsequent line, so I don't have many questions to ask the surgeons and the pathologists, but you are most welcome to chip in any time and you want to divert this thing towards your field here. I'll be happy to if you are doing that. So this is something probably that so far by and large most of the time we talk about the garden variety, what I call clear cell and this thing. So sometimes we do encounter, obviously they also will progress to the first line treatment itself is real challenging. So if they progress in the second progress, then what are the options available? 62-year-old lady with non-clear cell histology, progression after cabozantinib. So what would be, I think, anybody in the audience to guide further or? So anybody would like to? So personally, I don't think that there are good data about that probably, but I would like to be enlightened by Srinivas, Dr. Srinivas or others or this thing.
So here it is a problem, right? Because we have limited options for non-clear cell. I think NGS might be helpful. Maybe it will give us some target that we can use. We have mTOR pathway. Belzutifan is an FDA-approved drug that we have available. But I like lenvatinib and everolimus in this situation. You're coming in with a different class of drugs. Lenvatinib definitely is a good TKI. And in combination with IO, they have shown some good responses in non-clear cell. And even Len-Ev for non-clear cell has good response. So my choice might be lenvatinib and everolimus for this patient.
mTOR and lenvatinib.
There are certain other drugs like if you do an NGS, so anti-EGFR, anti-VEGF like bevacizumab, they have some roles in non-clear cell on progression. So people have used even erlotinib in those patients.
So I hate to put this into this thing, meetings and this thing, this particular kind of the question, but that is the hard fact we face day in and day out in this thing. So Ghanshyam and Sharda and others may like to chip in this thing. What advice do you give for clinician or our colleagues and this thing who manage second line in our setting where we really have the resource limited?
So I think for last few years, so we have, since most of the generics are available, so things are rather easy. Before COVID, I think, so there were hardly any options.
But we don't have the generics yet for the checkpoint inhibitors.
So I have a trial, sir. So that's why I have no problem. I have lung cancer trials. So I have Nivo trial and Pembro trial. So I put my patients into trial. So otherwise, so now TMH, my alma mater has already given a low dose. Now beyond head and neck, so probably the second cohort is RCC, and we have now 5 centers put together low dose IO, and in fact they are doing good. So like Kumar Pravas team and Akhil Kapoor from Varanasi, they have put together a big cohort of low dose IOs in RCCs. So that's still
I
there.
did note that you will be putting up this thing. So just last bottom line, just read about this thing.
Yes.
So, but apart from that, probably every patient probably won't be able to go on to the clinical trial, and these are some of the distinct factors. We discussed really quality of life data. We really discussed about the prognosis of the patient who has prognosed, what is the stage, how symptomatic patient is, and all these
So
things.
like I have a patient on sarcomatoid who progressed on Nivo, EP, then cabozantinib. So I put this patient on, one is a new oral PDL1, that is AOR 109. So that is a dose finding study. So there are trials.
Yeah, for the sake of timing, probably these are some of the practical takeaways from this discussion. We need to tailor the treatment according to the patient's individual patient factors. close monitoring for the toxicity, particularly the subsequent line of the treatment where the resources are limited. You don't want the patient to be in the hospital for toxicity management. And again, this thing, and of course, the clinical participation. And so I can probably be just, anybody would like to get just 30-second or 20-second role for the interleukin-2 or cellular therapy in this kind of the situation. Anybody from either the house or this thing. So we are talking about the cellular treatment
So first of all, it is difficult to give even an interleukin today. And even, so otherwise, yeah, so because
any
we have
data,
used in the
Dr.
past.
Srinivas, about high dose interleukin in this? Because I heard that they are the people who are working, or probably it is coming into the.
I mean, I think since Checkmate 214 has come, the use of high-dose IL-2 has gone down considerably. And I don't know, I mean, if repeat immunotherapy is ineffective, will cytokine therapy such as IL-2 be helpful? We are really selecting patients. I mean, you're picking the marathon runner for high-dose IL-2. Are they going to be beat up after their first-line therapy to be able to tolerate high-dose IL-2?
But the point that the people who say the reason being given for the repeat use of the checkpoint inhibitors, the T cell repertoire basically, new antigens, and they can be taken care by the new checkpoint inhibitors. That is one of the theory being suggested for this thing.
Right,
Anyway,
but the data hasn't panned out, right?
Yeah.
So we have had 2 randomized trials that have been negative.
So there is a nice review in case somebody would like to go for this thing. So current evidence for recent publication for this thing. All right, so I'll probably stop here and thank all the panelists for active this thing, active interaction and the knowledge sharing, and also the audience. Thank you very much.
Thank you. Thank you so much. It was a lovely panel discussion. Before we disperse, can we please come at the center for the group picture? Thank you. Thank you so much. I would request Dr. Nitish and Dr. Ghanshyam, please be on the stage for the next. Thank you. Thank you. So we proceed towards our next panel discussion, recent advances in advanced endometrial cancer. Can I please call upon Dr. Sushil Giri to chair the session? I would request Dr. Ghanshyam Biswas, the moderator of the session, to please take it up. And while I invite the panelists, can I please call upon Dr. Siddharth Nanda, Dr. Bhagyalakshmi Naik, Dr. Arya Banidatta, Dr. Sachin Biswal, Dr. Vijayalakshmi Sahu, Dr. Nitish is already here, yeah, Dr. Indraneel Chakravarti, and Dr. Usha Shri Das. Can we please have the panelists on the stage? Over to you. Yes, you can. Please, please, please.
వచ్చింది నా
Thank you. Thank you, Chairpersons, Dr. Jeeta Parija ma'am and Dr. Sushil Giri to be on the stage. Thank you.
So last day, last panel? Okay. Okay. So thank you, Saurabh, and thank you, AstraZeneca, because this is an Astra symposium. So recent advances in advanced endometrial cancer. So everybody in the hall will agree that for last 3 years, we have been torturing endometrial cancer with all genomics and all precision. So these are all the esteemed faculties on the stage. So we talk about a poster child, we poster boy, and now, so I have coined as a poster girl now. So on yesterday's talk, so somebody said that poster child is a prostate cancer, and everybody do understand that poster boy is a lung adenocarcinoma, and there is a now poster girl like endometrial cancers. So come to a case, this 63-year female who presented with a postmenopausal bleeding for 2 months in April 2022. Ultrasound sonography showed a thickened endometrium of 2 centimeters, MRI showing a myometrial thickness less than half, and a biopsy, moderately differentiated adenocarcinoma, high nuclear grade, undergoes surgery, radical surgery on 18th of April 2022. So coming to the pathology, so it is a 3.5 into 2.5 into 2 centimeter located at the uterine fundus, involves anterior and posterior wall, involves more than half of the myometrial thickness, right and the left pelvic lymph nodes, so 0 out of 21 involved, no LBSI, endometrial carcinoma grade 1, and the FIGO staging is T1B N0 M0. So I go to my pathology colleagues, Dr. Indranil. So any further information you want to put in the report?
In the present setting, we will be needing some molecular backup also, rather than the histological. We are already staged it as PT1B. So now we would go for some molecular profiling.
So Sambit, any other information besides the molecular?
Yeah, I mean, one thing I just have to, add to the audience, conceptually we do not say grade 1, grade 2 or grade 3 nowadays. We say low grade and high grade endometrial cancer. And it's the endometrial histology. In our setting, I would not directly jump to a high-end molecular testing. I'd probably go for a MMR, IHC, which is a cheap test to know, and TP53 staining. And I would not go for pole right away. I will go in a reverse direction.
So you don't want to put them as grade 1, grade 2 and straight away put them as low grade?
Low grade, high grade. 1 and 2 are low grade and 3 is a high grade disease.
Right, great.
Yes, ovaries.
So I go to Usheshri now, so our gynec oncosurgeon. So for the house, so what are the types of surgery? So we'll go one by one. A role of pelvic lymph node dissection, so role of parietic node dissection, and the extent, staging omentectomy, part of surgical procedure or not, and role of peritoneal washing. So we'll start from Usheshri.
So for endometrial carcinoma, if it is limited to uterus, even if the cervix is involved but it is not extending outside the cervix, surgery is only simple extrafacial hysterectomy. We don't need to do radical hysterectomy for such cases. Only if there is cervical involvement to such an extent that we cannot get away with R0 resection with simple extrafacial hysterectomy, then only I will go for type B radical hysterectomy. And role of pelvic lymph node dissection, I usually follow the Mayo criteria. If the tumor size is more than 2 centimeter, grade 2 or grade 3 or any grade as such, and any myometrial invasion, I will go for pelvic lymph node dissection.
I will go to Vijayashree ma'am now. So role of parietic lymph node dissection and extent.
Yeah, I think about when we discuss about lymphadenectomy and endometrial cancer, I know there are many theories about when to do pelvic or not to do, or do parietic and pelvic. But I think since endometrial actually essentially would drain sometimes also sometimes to the paraortic. If you have a sentinel node, I think that's the best option you would have in hand. If that is possible, you have ICG and do the sentinel node. In case that's not, doing a pelvic lymphadenectomy, and of course you should, the imaging of the paraortic area should be very, very perfect. Isolated paraortic node metastasis is very rare, no doubt, but then in our practice actually when we do a lymphadenectomy, I think the patient needs lymphadenectomy, we do it up to the left renal veins.
Nitesh, so staging omentectomy, part of the surgical procedure?
Sir, omentectomy we routinely do for papillary serous, clear cell, if it's a triple MT or a grade 3 endometrioid adenocarcinoma. I don't think it would be required for a low grade endometrioid adenocarcinoma.
So Dr. Jita, so role of peritoneal washing?
So actually, role of peritoneal washing does not, does not improve or de-escalate the staging, but just for keeping, record keeping, we will put it. But anyway, but we have seen that if the peritoneal washings are positive, they do carry a poor prognosis.
So I'll go to Giri sir now. So any final comments, the clinical pearls in endometriosis?
Your pre-op diagnosis was grade 2 because mortality differentiate grade 2 and their nuclear grade is high grade. I don't know what is meant by it. So nuclear grade is high grade and it is grade 2 disease. So it is high grade means grade 3. And it has come on to grade 1 after the surgery. Little bit confusion is there. Because grade 2, grade 3 coming down to 1, grade 1 after the stage shift is not that much required. And regarding omentectomy grade 3 is not negative. It is to be done in a case where is you already told there is serous carcinoma, carcinosarcoma and clear cell carcinoma. Grade 3 is not at all recommended till now. There is no recommendation till that. And regarding lymphadenectomy, the indication of lymphadenectomy is when growth size is more than 2 centimeter, there is myoinvasions more than 50%, there is cervical extensions, and there is adnexal involvement, we should go for lymphadenectomy. And when planning for lymphadenectomy, go for pelvic and paraortic. Very simple. Otherwise, you should go for a sentinel node biopsy. So most of this holds good now. And peritoneal washings is mandatory, but it is not. It should be mentioned, but it does not have any impact on staging.
It has an impact if there is adnexal.
Yeah, that's true.
So now, so what are the factors that guides the treatment overall? So, Arya?
Stage and lymphovascular invasion, grade of the disease, and myometrial invasion if it is more than 50 or less than 50, and depending on new staging systems, intermediate grade, high intermediate grade, and advanced disease, adjuvant therapy can be discussed after that.
So, Siddharth bhai, you want to add something?
I'd like to add the age as a cutoff. I mean, age more than 60, more than 70. Those are important, and also the mutational status of the patient is very important nowadays. Like P53 abnormal is the highest risk. I mean, anything that is coming with all other factors, but P53 abnormal should be treated as very high grade. You know, sometimes, in fact, recently I discussed with Sambit. I called him up. My patient, low grade, grade 1, less than 50% myometrium involvement. Grade 1, less than 50% myometrium, no other adverse features, no LVSI, but had P53 abnormal. Then I repeated another IHC which came negative, so we had a discussion, and patient is less than 60, so real confusion is there. So these are all factors we should consider before treatment.
And that was the case, I guess, in the IHC twice, but it was done at 2 different places, and 2 different places, and it was abnormal in one and negative. So when I spoke to Vai, I said like we should go for a mutational study, because we also see cases like they come in crops sometime. They have a very low grade histology, but normally we start with the MMR and a P53, and we do in a reverse way, then the pole. We see the P53 is positive, like strongly positive, and some of those cases have actually the mutation present in the molecular study.
So there are the clinical factors, the patient factors, there are pathological and the molecular parts. So probably put together all these 10 probably will decide the further treatment. Now this patient received a brachytherapy and 7 grade 3 fractions. She was on follow-up till May 2023, till July 2023 on a regular follow-up. So now Dr. Vijayalakshmi, so what are the types of radiation you will consider in endometrial cancers? So let us stay in early stage.
In early
And
stage,
the radiation
we can
dose?
treat only on vaginal brachytherapy, 7 gray per fraction for 3 fraction. But if it is higher stage, grade is 3 or higher stage 2 onwards, then we treat with EBRT, 45 to 50 gray in 25 fraction, 1.8 gray per fractions.
So Arya, so any role of proton, because now yesterday there is a news, there is a third machine which is been in AIG, 800 crores. So after Apollo Proton, TMH, now AIG. So that will be the 26th machine in the world. So role of proton?
Till now, I think there is no indication till now, but in
Please
cases...
speak to the mic.
Till now, there is no indication. There is no benefit of proton. We have, there is no comparison with the photon and proton study in C endometrium. Rather, it is studied in pediatric malignancies and other brain malignancies. But in near future, maybe there will be some indication. But in normal radiation, as Dr. Vijayalakshmi told, stage 2 beyond, and in unfavorable histology conditions, we can give adjuvant radiation in terms of EBRT, followed by vaginal brachytherapy or SAPO.
So Siddharth bhai, so if a particular case requires a re-irradiation, so will proton be of use?
I think Ghanshyam has a point. I would definitely prefer protons for the patient who are coming for re-irradiation, because that is a big challenge. A lot of bone marrow has already been irradiated, 50 gray we have already given. So to preserve the bone marrow and to give a precise radiation, if available and if financially feasible, I'll go for proton therapy.
Right. So now Sachin, so what are the concurrent chemotherapy you are going to use while Dr. Vijayalakshmi or Arya is planning for a radiation?
Sir, concurrent chemotherapy used in C endometrium is usually cisplatin as per POTEC 3 trial, given on first and fourth week only.
So this patient is not cisplatin eligible then?
Then sir, I will prefer only EBRT followed by
No carboplatin?
No sir, as far as...
So there are carboplatin. So now, third question is that if somebody is not eligible for cisplatin and carboplatin both, then
gemcitabine sir can be tried.
So ideally cisplatin, and then probably somebody who is not, so like other cancers, so as cisplatin is not, then carboplatin. So if the patient is ineligible for platinum, then probably a category 2B, capecitabine, mitomycin, gemcitabine and paclitaxel has been used. So now continue with the case. This patient presented with a right lower limb swelling and pain abdomen. PET scan was done, which shows FDG avid uptake in the right common iliac, external and internal iliac, largest being almost 3 centimeter. FDG avid well-defined intraperitoneal soft tissue density mass, the right iliac fossa, measuring almost a centimeter. So there is a relapse. So Sachin, what are you going to do now?
In this case, sir, we'll have a multidisciplinary discussion. If the patient is fit enough and can undergo resurgery with acceptable morbidity, because we are going to dissect a lot of lymph nodes in this case, then I think we should go for resurgery, sir.
Nitesh?
Apart from the nodes, there is one peritoneal deposit. So this is almost a relapse. It's almost like an ovarian stage.
So primary surgery, only brachytherapy, relapsed after 2 years. Good GC.
I would like to challenge with some systemic therapy, but definitely go ahead with surgery, see the response, and then go ahead with the surgery. Because of that peritoneal.
So this is the imaging, if it can help you. So Ushasri now, so role of secondary cytotoxic surgery, any role of HIPEC?
No evidence for HIPEC in endometrial cancer, especially in recurrent endometrial cancer, we don't have any evidence. But if the disease is localized and she has previously undergone some kind of RT and we are not expecting to tolerate her full dose RT now, then maybe we can opt for surgery. But in this patient specifically, because she has right lower limb edema, I'm suspecting that the lymph node recurrence that is there might be compressing on the vessels, and I most probably won't be able to get it out. For this patient, I might opt for putting in a scope and see whether I can safely remove the lymph node and peritoneal disease. If it is possible, then I'll opt for secondary cytoreduction. But if not safely, if I need major vascular reconstruction, then maybe first of all, biopsy needs to be done, and then...
So the biopsy has been done, so it is a guided biopsy, shows a serous high-grade adenocarcinoma.
And first is put in a scope, see whether I can safely remove it or not. If not, then chemotherapy.
Right. So Dr. Indranil, now a guided biopsy has been done and the sample is lying with you now, so what to do?
Now we have to go for the IHCs basically. We can go for testing of the DMMR and P53 to begin with. And there is a discrepancy that I can see between the three biopsy reports, the first, second and third. So I think it would have been nice if we would have done the P53 in the initial stage. So probably this is a case of clonal evolution maybe. So we can go for this MMR testing, this P53, and depending upon the histology, we can also go for HER2 and HRR, because that will affect, and hormone receptors also. So because that will dictate the therapy. And for poly, we have to go for molecular testing.
So Sambit, so are you going to advocate HER2 for across all endometrial cancer, or will you restrict to a particular type of endometrial cancers?
So I, as a pathologist, so I mean, I should not be doing, but whenever I have a high-grade serous carcinoma, by default, I do a HER2 IHC.
Right.
In my primary report, I give a HER2 status in that. And in this case, there's a lot of dichotomy. I mean, the reports are kind of little all over the place. And usually, something which is endometrial in the beginning and having a serous is probably, I would review the slide first. Before getting into any IHC or anything, all slides.
So all
Viras, no. I mean, that is something, I mean, to me it looks little unusual. So I would, Rajan, you have... Mike.
Maybe in the biopsy slide, in the surgery slide, we can also go for P16 maybe. Something was wrong.
No, the original biopsy diagnosis is different. The biopsy diagnosis is different. On hysterectomy, it's different. You get a metastasis. I don't know, maybe, as Sambit said, I think you need somebody to review the slides.
Yes, exactly. Mostly in when you have a tumor, I know we have carcinosarcomas, difficult, clear cell, or serous. Majority of time, we do not need IHC in these tumors. I know if it is serous cancer, you have a metastatic site. You will do a HER2 and a ER and stains to prove it is the same serous cancer. So I think we should start with, I would see the hysterectomy specimen first.
Please speak to the mind. No? So Sambit, is there a role of a PDL1 now? Is there a role of PDL1 in endometrial cancer?
In endometrioid is definitely there, endometrioid.
So is it something different, like not CPS, TPS, you would do something different here?
No, we do. I mean, depending on the clone, if I have a 142, I go for a TCIC. If it is a 263, I'll go for a CPS. I would not give much importance to TPS here, CPS.
Sachin? So like the Topaz trial, BT in the biliary tract cancer, so they have area under, so probably they have done that TAP. TAP tab, more than 1% and less than
They
1%?
have the same thing, the concept is basically the same, and we take something more than 1%. And so we basically look into both the cells. But then again, I'll say 2233 is the best clone by DACO. And where we mostly go for the CPS, we try to capture as much as we can, looking at both the immune cells and the tumor cells, and go from there.
So Dr. Indranil, so 2022, all these panel were done. So ISC, ERPR, HER2 was done, the molecular was done, now 2024. So you have all the baseline. So are you going to repeat all those, including the ISCs and the molecular and the PDL1 in 2024?
It has been already been done.
So 2022, the whole panel has been done. So now in 2024, when the patient has relapsed, so are you going to repeat that? So my question is that do you repeat molecular testing on progression?
I think since there has been a change in histology, I would go for a repeat.
Suppose the histology remains the same.
Then also I think it should be repeated.
Samit?
I'll still do, even the histology. First thing is review, confirm the diagnosis, then if it is everything same, even if the histology is same, and if there is a progression in the disease, I'll at least go for a P53 and MMR.
Sachin, so in 2025, so when are you going to ask for molecular markers? So at diagnosis on a biopsy, or after surgery on a histopathology, or after relapse in a biopsy?
Sir, at this point of time, we will like to have the molecular markers at the diagnosis itself. At least the P53 and the MSI we need along with the histopathology reports.
So now these are all current guidelines and biomarkers testing. So if possible, if you can do a poll, if it is mutated, which will be in 5%, then you may not do further. If no poll mutations, then MMR. If deficient MMR, again, you are stopping at that. And then these are whole panels, and HER2 especially in a serous or a carcinosarcomas. So poll 5%, MSI 25%, and NSMP is 40%, and copy number high is 30%. And we know that if you see this curve, that at the top of the class, like Sambit used to be, the gold medalist of my batch. So he's just like the pole there, and followed by NSMP and then DMMR and P53. So P53 does the bat like me. So, and associations of histological and TCGA classification in endometrial cancers, so lot to do in the low-grade endometrioid. So now this patient has P53 overexpressed, ERPR positive, HER2 negative. So Dr. Indranil, so HER2 here in endometrial cancer, do you derive the same way in breast cancer, or you go by the gastric cancer way?
No, we classify it in the same way.
Same way?
And as 0, 1 plus, 2 plus, 3 plus as breast.
No. So how do you, so Sambit?
So there are two things. I mean, even in the US, people, some part they're doing like breast and some do like gastric. I do it like breast. I do it like breast cancer.
I think, but probably they are like the gastric cancers. So that
I mean, I know there are two theories.
Both ways, there are two, actually, both are in practice.
Okay.
And here the thing is, there's nothing called P53 overexpressed. That terminology itself is wrong. It is mutated type of staining or wild type of staining.
Mutated. So P53 mutated, ERPR positive, HER2 negative, MSI stable.
I always give a ERPR percentage. Also, I treat these cases like as if I'm looking, I try to quantify. And
So unfortunately, it was not reported by you. That's the problem. So something about Lynch syndrome, Arya?
Sorry, I couldn't hear.
Sachin?
Sir, I didn't get the question.
So do you encounter, so have you experienced any Lynch syndrome?
No, sir.
Siddharth, right?
One patient we've seen with Lynch syndrome, but this is common knowledge that commonest next malignancy after colon is endometrium, about 60%. But we haven't treated that patient any differently compared to what, maybe it was very old, like 20 years back in AIMS, Delhi, so we didn't have all these markers, all those things. So probably
Actually, it is not uncommon. So if you look into that, so probably you will get it. So I have quite a few patients in that. So now coming to Sachin. So what is the current line of management in a deficient MMR and a proficient MMR advanced endometrial cancer patient, first line and maintenance?
Sir, first we will take up the MMR deficient patients. If the patient is very much symptomatic, then we can re-challenge with the chemotherapy like carboplatin and paclitaxel. If it has recurred after a significant amount of time, like the ovarian cancer, and the time is more than 6 months. And if the patient is not fit for chemotherapy, then in MMR deficient tumors, we can go for single agent IO therapy. Pembrolizumab has been approved. For proficient MMR patients, we can do same with the chemotherapy, or in IO, we can choose lenvatinib plus pembrolizumab.
So any role of hormonal therapy?
Yes, sir. Particularly in this case, as the histology has changed to high-grade serous, I don't think we will be upfront routing for hormonal therapy. But if the histology has been same, like the low-grade endometrioid, and the patient is not very much symptomatic, we could have chosen for hormonal therapy.
Any role of targeted therapy?
Targeted HER2 is negative in this case, sir. Had HER2 been positive also?
As a overall, I am asking role of targeted therapy.
Yes, sir. We can choose trastuzumab based on HER2 status for it.
So there are trials with paclitaxel, there are now trials with Enhertu. Any other role of PARP inhibitors in a HRR positive or HRR negative?
Yes, sir. PARP inhibitors are there with durvalumab and olaparib coming now.
Okay. So this is the whole gist in 2025. So if you see the preferred line of therapy in the first line, so carbo, pacli and pembrolizumab, and they have excluded carcinosarcoma. And then we have the category 1 evidence for dostarlimab based, we have durvalumab based, and as rightly said, so carbo, pacli and trastuzumab for HER2 positive, especially in a serous carcinoma and a carcinosarcoma. And for MMR proficient tumors, so lenvatinib and pembrolizumab. For TMB high, you can have a single agent pembro, and for again DMMR, you can have pembro or dostarlimab. And on the right hand side, you can see different other drugs, single agent or in combinations, and even so many patients on low grade can be years together on either tamoxifen or aromatase inhibitors or megestrol acetate. And probably the best of responses not even seen with chemotherapy for those patients can be alternating with megestrol acetate and tamoxifen. And these are patients, I have a patient who is ongoing for last 3.5 years, 4 years now. So these are first line IO in advanced endometrial cancers. So we have data for dostarlimab, for pembrolizumab, then we have durvalumab and also atezolizumab. So probably Atijo was probably not a big positive trial, then these 3 and these 4. So dostarlimab, so where probably this was the one trial where the primary endpoint was OS as compared to Atijo or even the pembro and durvalumab, where the PFS was the primary. So this was the Ruby trial. And definitely we'll see that the patients who are MSI high is going to do good as compared to the patient who are proficient MMR. So this was the NRG trial of pembro with paclicarbo, PFS as a primary endpoint. So now coming to the DOE. So this is the durvalumab from the AstraZeneca. So durvalumab plus carbopaclitaxel followed by maintenance durvalumab with or without olaparib as first line treatment for newly diagnosed advanced recurrent EC. So Sachin, so suppose somebody is an HRR alteration is there, so definitely, so one of the choices will be a PARP inhibitor. Suppose somebody is not an HRR, So what is your take on the PARP inhibitors? So there is a cold tumor, right? So now,
If HRR is negative, then I won't be tempted in the second line to use PARP inhibitor. Maybe in the later lines when we have exhausted all the recommended treatments and patient is symptomatic, we can opt not as a single agent, but with combination we can try.
but duo is a first line treatment. So we are talking about a first line treatment here. So suppose somebody has now, this is approved in India also, durvalumab, and now Astra has a good patient support also. So your patient, a right patient who is HRR negative, so would you consider this regimen?
As far as now, sir, I do not have much experience in using in HRR negative patients. I will wait, sir, till more data is available.
So let us come to the concept of this duo. So suppose somebody is a deficient MMR, we know, understand there are agnostic markers, so you can jolly well enjoy the responses and use of any of these IOs. But somebody who is a proficient MMR, so there is a cold tumor, and you want to use this PARP inhibitor. So probably this trial gives us a food for thought that olaparib induces a damage up to the tumor cell, and immune priming promotes a more robust anti-tumor immunity, and that becomes a proficient MMR probably, so that the use of immunotherapy and a PARP inhibitors. So this was the trial design, where again PFS was the primary endpoint. So there were 3 arms, so 1:1:1. So one was absolutely, so induction phase and then the maintenance phase. The first arm was only chemotherapy, and the maintenance phase it was all placebo. The second arm was chemotherapy plus durvalumab, and on maintenance it was durvalumab. And third, so the concept, the hypothesis was that chemotherapy plus durvalumab, and on maintenance durvalumab plus olaparib. So by this time, once you are putting the patient on olaparib, the patient is exposed to chemotherapy, the patient is exposed to durvalumab, that is immunotherapy, and there is a change in the microenvironment. So all histologies except sarcomas. So like we saw in the pembrolizumab, so the recommendation is not for carcinosarcomas. So here they have included the carcinosarcomas also. So though there are only a 10% carcinosarcomas, and here Sambit, you can see the PDL ones. So they have taken a TAP score here. So 70% of these endometrial cancers were TAP positive, 30% of negative, and you can see here HRR only of 10%. So most of them were either non-HRR or so it was unknown. So this trial actually ventured into an unknown territory, and they come out positive. So that was more important. And Asian patients represented almost 30% in this trial. Now you can see the ITT populations, that is PFS and OS. So there was a significant benefit with the third arm, that is chemotherapy, durvalumab. So chemotherapy, immunotherapy, and a PARP inhibitors. If you can see the hazards of 0.55 and significant p-value in the PFS as a primary endpoint. So this was intent to treat whole population, and OS also a hazard ratio of 0.59 with a significant p-value. So coming to, because 20% patients were MMR deficient and 80% were proficient. So definitely an hazard ratio was on 0.41 significant, but if you see those patients on the proficient MMR also had a hazards of 0.57, and so though a deficient MMR had almost 31 months of PFS, which is double, but here also you can see a 15 months. So since most of the patients will be a proficient MMR, so this regimen becomes a good choice. We see the responses in across all the 3 regimens, the responses were almost the same, but you can see there is a huge difference in the duration of response. So only chemotherapy arm, median duration of response was 8 months. In the combination of IO, it was 10 months. But while adding an olaparib or a PARP inhibitors to chemo plus IO, it has crossed 6, that is almost 1.5 years. And overall survival was also different. So last, will it impact your clinical practice for DMMR and PMMR after the data understanding? So Sachin, now there is a cold tumor, and 80% of this population will have a cold tumor. So will this data make some dent in understanding of this?
Yes, sir. If the patient is, because we are treating with 3 agents, the adverse events will be likely to increase. If the patient is fit enough, and we can try this combination therapy, because the data surely is better than the other available treatment options.
So for which molecular subgroups do you expect the addition of PARP inhibitors to be beneficial? So pole mutant, deficient MMR, proficient MMR, P53 abnormal, no specific molecular profile, PD-L1 positive, PD-L1 negative, HRR mutations.
Sir, P53 abnormal and HRR mutations will be the population for whom we will consider this treatment.
So probably after this DUO-E trial, so these markers or the biomarkers, if you say, or the molecular markers, so has been brought into highlight. So if you see this survival, so you can see, so favors combinations of chemotherapy and immunotherapy. So across all PD-L1, POL, HRR, BRCA, histology. So you can see all the diamonds are on the left side. So now see this curve, and once you are adding an olaparib, see how the curve shifts again more towards your left. So the benefit, the quantum of benefit is much more once you are adding. So the TAP score, the P53 mutant, which is thought to be the worst subset, even is doing good. Somebody who is non-HRR, again is doing good. And somebody who has a non-BRCA is also doing good. So I think, so that has brought out a significant difference in those patients which was probably thought to be the rough or the worst type of endometrial cancers. So this is one slide I borrowed from Sambit oration. So the emperor of all maladies. So I think every oncologist might have gone through this by Siddharth Mukherjee. So according to Mukherjee, the book was a response to a demand of a patient. So newer trials are actually comes when we see day to day a problem. So we talked about RCC. So why to do an NGS? Why to do a repeat biopsy? Because we had nothing. So unless and until there is a thirst or there is a quench for our newer things, so then we won't have newer trials. So there was a high test for almost 10 years in many cancers, and now there are plethora of choices. So I am willing to go on a fighting, but I need to know what is that I am battling with. So these are the 3 conferences in the land of Jagannath. So we are on the day 3rd of the conference of Uro-Oncology. So on my upper right. And this very month, that is January 31st, 1st and secondary, we have James Allison, the Nobel laureate of 2018, here in Bhubaneswar, Padmini Sharma, Sangeeta Goswami, and Betty KIMS. So that will be an Immuno-Oncology Society. And the 3rd will be a 5th into oncology from the Iowa team. So thank you. So this is with my mentor, Dr. Advani sir. So for all those faculties who have come from abroad and from other parts of the country, stay safe, be safe.
Dr. Ghanshyam, before winding up, just one question to you. Sorry.
Please.
About this DOE, you have mentioned so 3 drugs. What about the financial implications and the toxicities?
So somebody said no, so the on scientific
So would you
discussion, no
recommend-
financial implication. Dr. Sarin said.
Toxicity and the finance.
Yeah. Thank you. Thank you so much. Can we please come at the center of the stage for a group picture before we take upon the final panel discussion of the event? Thank you very much. Now we come for the final and the last but not the least panel discussion of this event moderated by Dr. Sandy Srinivas. Can I please call you upon on the stage? While I call the chairpersons, Dr. Sean Williamson, Dr. Sambit Kumar Mohanty, and while I call upon the panelists, Dr. Saroj Kumar Sahu, Nuclear Medicine, Dr. Sthiti Das, Radiation Oncologist, Dr. Aditya Sarin, Medical Oncologist, Dr. Santosh Menon, Pathologist, Dr. Jyoti Ranjan Swai, Surgical Oncologist, and Dr. Saurav Mishra. No, your name is here, right?
Are we good to start? Okay, good afternoon, everybody. This is really the last session. Unlike the previous sessions, I think we have a very small, compact group, and the topic that we have is neuroendocrine tumor. We don't really have any NCCN level 1 evidence, so this is going to be real world, what do we do when we see a patient with neuroendocrine? And this is exactly what we do. We bring in a multidisciplinary group. So there is no right answer. It's mostly your perspectives in terms of how you treat these patients. If you look at neuroendocrine and GU oncology, you know, there is no one section. Everyone in the NCCN guidelines diverts you to look at the small cell. So we really don't have large numbers to really give us any answers. So really looking forward to an impactful discussion. I really want all my panelists. I don't have any data to show, so it's mostly your perspective. So let me start. I'm going to start with a case presentation. We have a 60-year-old woman. Oops. Is this mine? Yeah, it is mine. Sorry, I got confused with the prior GYN panel. So this is a 60-year-old woman. She does have a past medical history of uterine fibroids. She underwent a hysterectomy and within a few months developed irritative urinary symptoms, which eventually led to hematuria. She is an engineer. She works for Oracle. She has one son and currently living with her husband. She has no known drug allergies and is really not on any prescription medications, so relatively healthy. She was referred to urology, and an office cysto did reveal a 3-centimeter lateral wall mass. So here is my first question. I'm going to pose it to Dr. Sahu. You know, what do we do in terms of imaging choices? A lot of it is spoken about MRIs. You know, MRIs, especially from the UK group, they are really looking at it to even replace TURBT. So what would be the imaging choice? We have a CT, IVP, MRI. We spoke a lot about PET scans. You know, in India, I think PET scans are much easier. For us in the US, we need to get third-party payers to agree to pay for a PET scan. So let's maybe have a discussion about the imaging choice.
For this scenario with SOL in uterus, I would prefer to do a CT first.
CT, IVP?
Cystoscopy.
Oh, cysto already showed a mass in the lateral wall of the bladder. So now we are really moving on into imaging as to what would help us.
First of all, we will go for a CT IVP or cystoscopy.
Okay, so CT IVP is your choice. So this is the CT IVP. It does reveal, confirms what the urologist saw on the office cysto. So a mass in the bladder. So before, I just want to ask our urologist, you know, is the role of intravesical therapy as you decide about TURBT, is that a given that you do for all patients? Oh, we don't have a surgeon?
Surgeon. We have surgical oncologist.
Okay. Dr. Swain, right? Yeah. Yeah. Okay.
For all urothel, suspected urothel, they would.
So mitomycin, gemcitabine, is there a choice?
Mitomycin. It's mitomycin, generally
Okay.
mitomycin.
Okay, so now we get TURBT, and surprisingly, the patient had both urothelial cancer as well as neuroendocrine, and I'm going to show the path in a little bit. But let's stay with the, now that you know that there is a diagnosis of neuroendocrine, what additional scans would be helpful? Maybe I'll ask Saurav since.
So I think with a high-grade urothelial carcinoma and with neuroendocrine component, I would be equally comfortable with a CECT scan. If it's a neuroendocrine carcinoma, maybe PET CT scan as well, or CECT abdomen and pelvis and chest, that would be good enough for me.
Do you want to comment on brain imaging? I'm going to come to that at the end.
So probably if neuroendocrine carcinoma is there, probably would like to rule out an upfront brain metastasis also. So MRI brain contrast would also be included in the upfront investigations.
Additional thing I want to add, as it is a neuroendocrine, we should go for ISC to know the Chi-67 index. So
yeah, I have a whole list for the pathologists, especially since this is a pathology conference.
As far as PET has been concerned right now, so for decision of the either gallium dotanak or FDG, we have to see the ISC report.
Okay. So let's, in fact, I'm going to have my pathologist who couldn't actually be here. He kindly shared these slides with me. So maybe I can have Dr. Menon comment on the, on what you see on the slides.
So these are fragmented chips of TURBT, and we can see a very blue-looking tumor at low power. That's the first thing which we generally see in all small cell carcinoma of any sites. It looks very blue under the microscope. And shows a lot of crushing artifact because the cells are very high, they have a high surface tension, so they get crushed very easily when they process. So that's the first thing. I think the thing which has been pointed out probably is the papillary urethral component which is being shown. Sean, you agree with me? Probably. So when we talk of urothel with neuroendocrine, there can be two things. A typical urothel may show some neuroendocrine sometimes. That's what we call as neuroendocrine differentiation in urothelial. But when we talk of neuroendocrine carcinoma, it's either a small cell or large cell. And generally, we would not do a Ka67 on a pure neuroendocrine carcinoma, which is morphologically clearly small or large. We don't do Ka67. But yes, synaptochromo and INSM1 are the common markers which we do. For a bladder or a prostate suspected, we might sometimes also, we have started adding P53 and RB protein in these. RB, we still don't have a P53. Sean, you would do something different? Do you see urothelial with neuroendocrine differentiation?
Yeah, that sounds, I would do similarly. I mean, sometimes I do Ki67 if the question is high-grade prostate cancer versus neuroendocrine, but unless asked, I don't always do it for urothelial, which a bladder small cell, if it's morphologically obvious.
You can see the muscle is being invaded. Those pink bits are all medusa muscle bits which are totally invaded. Most of the small cells are muscle invaded.
So here's some more in a high power. Any additional comments?
The first two pictures are showing you a urothelial carcinoma, and the bottom is showing you the more.
Want the microscope? Sorry.
The bottom panel is showing the more blue-looking tumor, which is the small cell component. The top panel and the second picture is showing you the urothelial component of this. So it's a urothelial with a small cell carcinoma kind of.
So in your reporting, is it important to note the percent of urothelial?
The guidelines say even if it is 5%, we should report a small cell component because they are known to throw early METs even if the component is 5%. So that's it. So even a smaller component like 5% of small cell is to be reported. And that's what we generally do.
And then while we are with pathology, can you comment what fraction end up having a mixed with both urothelial as well as small cell?
Sean, you want to take it?
I'm not sure number offhand, but I guess often it's like this where you have a lot of small cell and some urothelial component, although sometimes it's pure small cell, we assume that it probably still arose from the urothelium even if it's pure small cell, but I'm not sure a number offhand of how often it's mixed.
Good percentage of small cell are generally, they overgrow the urothelial component because they're fast growing tumors, so they will, so we don't get the spectrum of 5%, most of them have already overgrown that 5% level.
Do you have a comment also sticking with pathology between small cell versus large cell? And can you also comment on how that matters to a practicing physician?
I really don't think the therapy matters because in generally whenever we give a report of small cell component, Amit, my medical oncologist, would prefer to give an etoposide based chemotherapy. That's the first thing. Large cell is when they start showing nucleoli is the most important. They have more cytoplasm. And they look different from the small cell is having less cytoplasm and more nuclear molding, crushing and those kind of findings. But I think when it comes to treatment, I really don't think currently, and large cell neuroendocrine is extremely rare in the bladder.
But maybe in terms of prognosis, I've read reports where large cell have a worse outcome. So
I'm not sure about that, Sean. Bladder, large cell, worse, or I don't think there are so many series.
Yeah, I'm not sure either. I think the large cell to me is a little bit less well defined. You've got the if everything's classic, we usually call it small cell, and then if it still has neuroendocrine features but it doesn't look exactly right, then and sometimes gets shoehorned into large cell, which is a little bit of a less defined category. I noticed in this picture the cells are a little bit more spaced out than you'd normally think of a small cell, but maybe at higher magnification it may look like a straightforward small cell.
And correct me if I'm wrong, so what we were, residents, so we were taught that diagnosis on the biopsy, small cell you can give comfortably, but regarding large cell you need the whole chunk of the tissue. Even if you get a report on the biopsy, it needs to be further corroborated with the surgical exploration of that particular tissue in order to label it really as a large cell. So I'm not sure whether that is the right teaching or the wrong teaching. Can we really say on the biopsy tissue that this is a large cell?
So, like I said, the features of generally small cell will not have prominent nucleoli. So if you start getting more vesicular kind of nuclei and nucleoli with more amount of cytoplasm showing neuroendocrine markers, we would probably think. But I don't know how much it matters. To be very frank, we have not seen so many large cell neuroendocrine in the bladder which are pure. As far as I know, they're treated pretty much similarly, at least at our center, pretty much.
Okay, that's awesome. I have some more stains for you. So these were the ones, I think synaptophysin and Ki67 were mentioned. Any other markers that would be important?
So in small cell, we now routinely doing P53 and try to do RB protein as well. Yeah. More in the prostate, less in the bladder actually, more in the prostate small cells.
Would you do any genomic testing? I mean, does that help in small cell? Is that part of your practice?
So, doing a genomic testing, it's always good for medical oncologist. And we are hovering in an aggressive and rare zone where you have rightly said you don't have any pretty much guidelines. So I think you can have a customization of the treatment chart. You need to discuss it with the family. You never know, you might find the needle in an ocean. So yeah, I think why not to do it if finances are not in concern.
So basically in neuroendocrine carcinomas, NGS would mostly show either a TP53 or RB mutation, which is ubiquitously present across most of the NECs. That is what is defined. Other than that, actionable mutations, PDL1, MSI, although we can just think of doing them, maybe as he was saying, we may find one odd patient. For most patients, probably there is not much to be achieved with NGS.
But I think in this patient, does the presence of urothelial change anything for you?
So,
I mean, in general, we think of the worst player here, which would be neuroendocrine.
Exactly.
But does the presence of UC make you think about other things that you might
So
want?
one thing is, I would feel here is that probably there was a common clone which was present and now it has diverged into differentiation into a neuroendocrine component, and based on the neuroendocrine component, probably I will treat this patient. That is what I would do, rather than the urothelial component.
You might find FGFR alteration in that, and that can, further confuse us regarding the treatment, because if you are having an FGFR in a patient with a neuroendocrine majority of the component, you really don't have data. So, in order for me to use an FGFR inhibitors in the second line or the third line, so it has to be a purely urothelial. It can't be a combination of a urothelial and a neuroendocrine. But yeah, that will confuse the oncologist, I think.
I wanted to add, the moment we start looking at small cell, by default the clinician is going to take it as a muscle invasive bladder cancer. That's the first thing. So that becomes a completely different line of management, and I think the biology is going to be driven by small cell neuroendocrine component.
So even if it is T1 with the neuroendocrine, your point is that you would treat it as a, yeah. And then now that you have neuroendocrine is confirmed, any role for PET imaging? Do people want to change their staging criteria?
If it is a neuroendocrine, then gallium CT Dotanuc PET CT is for the staging purposes.
So you would do a PET?
Yeah.
Okay. Okay, so now we come to management. So patient has high-grade neuroendocrine, does have a urothelial component. The PET scan is negative for distant disease. What would be the role of management? Maybe I'll start with the surgeon colleagues.
So, since it is a muscle invasive cancer, we have to be surgery will be the option. But since it is a neuroendocrine differentiation in a small cell, we will start with the neoadjuvant chemotherapy, followed by radical cystectomy.
So you're going to refer the patient to the
medical oncologist.
Okay. How about radiation oncology? Do you bring in the radiation oncologist at this time, or is the patient?
Even setting we can think depending upon the pathology report and what is the grade. It's already grade 3, and what is the margin status and other things. But we start with the neoadjuvant chemotherapy followed by surgery.
Some local therapy.
Yeah.
Okay. We would love to hear your thoughts about radiation.
Yeah, I will concur with our surgeon that we need to give some neoadjuvant chemotherapy before starting for any local therapy. But like I would said, because we are considering radical cystectomy here, so we can go for better bladder conservative approaches with concurrent chemoradiotherapy as well. Because there's some evidence that both after neoadjuvant chemotherapy, if you're offering local therapy between surgery and radiation, I would say the survival rates are similar, and we can offer these treatment as well.
Okay.
And And if we suppose we are also thinking that we will give a radical treatment, then we should go for a whole pelvic along with the drainage
I'm
lymph
going to come
nodes.
back to the field in a
Yeah.
second. So we are going to go with, so the panelists agree that for somebody with neuroendocrine, giving systemic therapy is really the key, and both our surgical and radiation colleagues agree that it should be with medical oncology. So maybe I'll have my two medical oncologists comment on what type of chemotherapy, and especially given that there is a urothelial component, what would your choice of chemotherapy be? Maybe I'll start with Dr. Sareen.
Yeah, so obviously we have already done the PET scan, we have done the MRI brain as well, because now the neuroendocrine component is there. And the patient main complaint was hematuria. Even if after TURBT that has not settled, I think that takes precedence. You need to settle the hematuria, and then you can think about, starting with your neoadjuvant chemotherapy. Because if you have a patient with ongoing hematuria and you plan your neoadjuvant chemotherapy, your chemotherapy is going to take some time for it to work. So either you put the patient on a concurrent CTRT upfront, or if the hematuria has been controlled, then rightly said that you start with the neoadjuvant chemo. Now, for the neoadjuvant chemo, my go-to protocol is going to be an etoposide or platinum-based protocol, and the same as per the small cell lung cancer, the limited stage. And after that, 4 cycles, you do the assessment, you plan for the consolidation in the form of either a surgery or a CTRT or a radiation load, depending upon where our patient is fitting. And then the 4th point I might add, I mean, it's completely to individualize. You can add an adjuvant IU as well.
We are going to come to that. Yeah. Hold your thoughts on that one. So you spoke about platinum. Do you have a preference between cisplatinum versus carboplatinum? And does the extent of the disease matter to you in terms of your chemo selection?
Mostly if now we are having a patient of a bladder etiology and creatinine and creatinine clearance is all right, I would like to use cisplatin. And if I feel that the patient is elderly, you can have a lower EGFR in females, as you rightly know. So that particular subgroup, I can still think of using a lower dose of the cisplatin or a split dosing of cisplatin, and then you can always replace it with carboplatin. For me, if I were to choose in our setup, I think we are more eco-friendly with carboplatin. That's our go-to-go drug, carboplatin.
So any comments, Saurav, about
So if it is a curative intent, if you are treating, I would rather prefer cisplatin over carboplatin. In the metastatic setting, carboplatin is reasonably okay for me. And as far as the treatment regimen in neoadjuvant chemotherapy, it would be determined by the component which is more aggressive. Here it is neuroendocrine carcinoma. So etoposide and cisplatin is the way to go.
I had one comment, you spoke about bleeding. So let's say this patient comes in to have the hematuria controlled. How do you determine your dose of radiation now versus thinking about a more definitive therapy for this patient?
Yeah, if we are going for a more definitive, like it will be a more conventional dosage, like 2 gray per fraction, and usually we would go around 66 gray. But if it is like a hemostatic dose, like now is the era of hyperfractionation, like more of image guidance and intensity modulation, so we can go for at least 15 to 20 fractions, or maybe lesser, we can go for 40 gray in 10 fractions.
Would you include the pelvis too?
No, if hemostatic dose will not include the pelvis, but more in a definitive setting, we will include the pelvis.
I see. I have one more question back to Saurabh. Now, if we were to choose radical cystectomy, we typically do neoadjuvant chemotherapy. How do you feel about neoadjuvant therapy prior to radiation?
So in small cell carcinoma, the survival would be less compared to the pure urothelial carcinomas. Now my treatment decision would very much be determined by this. So if I am going for an aggressive procedure, a radical cystectomy, I would be very careful. So conservation would rather take a preference for me. So probably neoadjuvant followed by CTRT is something which I would be more comfortable with.
Okay. So I think our panelists agree that we want to do chemotherapy first. So this patient did receive 4 cycles of cisplatin and etoposide. post-cystectomy PET was negative for distant disease. This was just our patient. We have a very high presence of urology and the surgical group. So the patient did opt to have a cystectomy done, had an ileal neobladder done, and had bilateral lymph node dissection. Can we have our surgical oncologist just comment about the surgery, the presence of lymph node dissection? Would appreciate it.
Since there is an urothelial component, we have to go for the bilateral lymph node dissection. And rest study, surgery, what has been done, it is up to the mark. It should be done like this only. And bilateral lymph node dissection should be done because of the urothelial component.
Okay. So this patient did have that. Pathology came back as having a YPT2 N0 and had residual small cell with negative margins. Is that a tough read, in patients after they have received chemotherapy to know if there's any viable?
Just Dr. Sandy, whatever cases we see are generally mostly advanced small cell patients. So many of the patients don't come back with a cystectomy. They are not eligible because they are given systemic therapy, the responses are not great. And I can recall a couple of cases who underwent cystectomy, and generally you would end up finding some residual tumor in them. I don't know whether in this case I did see some carcinoma in situ also, and that was so that might be a relative contraindication to do a neobladder in our settings probably.
Okay.
Sandy, can I just ask a question to the pathologist? So is there a concept like yesterday we are discussing the Niagara study, pathology complete response in urothelial? Is there a concept here? Yeah, small or urothelial with small cell?
Dr. Saru. The
Or
numbers are too
urothelial
small
with
there.
small cell component? No, that doesn't make sense.
And then are there any special stains that you do at this time, or it's just morphology?
No, morphology, pretty much morphology. If it's already been done in TURBT, we wouldn't be repeating those IHCs in this.
Okay.
Generally don't do.
Is there a role for radiation in this patient? I mean, this patient ended up having a surgery. Is there a role for radiation in the adjuvant setting for somebody who has persistent disease after chemotherapy?
Yes, definitely, because we have residual tumor here. We can add adjuvant chemoradiation to this patient. Definitely there is a role of radiation because since node positive diseases along with any R1 resection with residual disease, definitely there is an indication for
So
radiation.
margins are negative, the bladder is out. Do you worry about radiation to the conduit and what that would happen?
Yeah, that is a significant concern because when we are radiating, we are also taking into consideration these critical structures and lowering the dose below the tolerance level so that in the long terms, the toxicity is not an issue for these patients.
Okay. So going back to Dr. Sarin, here is his patient now, post-cystectomy, and what would you recommend for this patient when she comes back to see you? Would you opt with surveillance? We had a discussion about radiation. You spoke about adjuvant immunotherapy. Can you comment on what the data that supports the use of adjuvant therapy?
So obviously in bladder there is no data as such. We have to again extrapolate it from our small cell lung cancer trials. But then again, it is, one can argue, if you are a purist, you can argue, you don't have the data, so I can say, okay, I'm okay not to use an adjuvant IO. It is something, it is an attempt out of desperation rather than the guideline indicated protocol. For if this patient were to come to me, I would have had three choices: surveillance, radiation, and adjuvant IO. On surveillance, I might have added a tablet etoposide as well, just to be on, keeping her under a little more than just surveillance. And all the three routes, I think, you have their pros, you have their cons, and you can fight for each route. There is no one correct answer in this kind of a scenario. But cost, again, no issue. Finances, no issue. I would be tempted to give an IO.
To give IO?
Yeah.
What about you, Saurav? Would you do immunotherapy?
No, probably I would just go for surveillance in this patient. I feel with appropriate neoadjuvant chemotherapy and then surgery, I feel the patient can be put on observation. I think lung also probably would do the same thing. If it was, of course, inoperable or they just gave chemotherapy, CTRT, there is still some residual disease. That is where probably I would like to incorporate immunotherapy like in limited stage lung cancer.
I see. So within immunotherapy,
So-
if you were to use it, right? So we have nivolumab as an approved drug for urothelial cancer that you give nivolumab. What do you do here? Would it be atezolizumab? Do you have durvalumab, which is what is used in lung cancer? What's your
You know, when
approach?
we are comparing both the organs, lung versus urothelium,
That's exactly what I'm saying. So
the second
we
point
don't know.
is, so that's the point. Nobody is going to say that this thing is going to be less aggressive or more aggressive. It is just going to be purely spectacle or a hypothetical discussion. So I'm not saying you are wrong or I am right. It's going to be, you know, all the roots are right. And for immunotherapy in small cell, I have to go with atezo.
With atezolizumab.
Yeah, there's no question about it.
And even the data in lung cancer was not that impressive, right? That difference. Yeah.
It's absolutely not that much.
So you have decided to do atezolizumab. What's your duration of therapy?
So it depends, you know, in this particular scenario where we are attempting for a cure and we have already achieved a cure, I think 1 to 2 years is good enough. But to be honest, I have never had any patient like this in our scenario.
Well, that's the whole idea, right? We are going to be seeing patients like this. So it's a good mental exercise, I think. So anyway, she was offered adjuvant nivolumab and she was on into it for 10 months for a planned 1 year of therapy. And within 10 months, she ended up having a very abnormal looking CT scan. And we ended up having access to a ctDNA and we chose the Signatera test and she did end up having a positive Signatera. So can we comment on what your next step would be in terms of maybe radiology assessment and maybe would a biopsy be needed?
So I think whenever we are having patient with recurrence, you need to prove that the disease is back. You can't go ahead without any biopsy. So obviously a biopsy is mandatory, and if I have not done an NGS in the upfront, so I might do an NGS now. And considering she is asymptomatic, she is not having any symptoms because of the disease. Would like to start her on the treatment again. I can again give a re-challenge.
I'm going to come back to treatment in a second. Would you do a biopsy?
Yeah, biopsy would be appropriate in this setting. We need to, because we are going to reinstitute systemic therapy, it would be appropriate to repeat the biopsy.
Okay. Do we want any additional imaging at this time?
So same thing, CT scan if it was done, or baseline PET CT scan it was done. So whatever was done as the baseline, we will just repeat that.
Okay. So she did get a PET scan, and I think I'll show you the PET scan in a minute. And the biopsy did confirm small cell. She asked us, why do I need a biopsy? You know, I just had this 10 months ago, and I think I tried to convince her saying, because she had both urothelial and small cell, it might make a difference, though we knew that this was most likely to be related to a small cell. So what would you recommend now? She's back again to the medical oncologist. Are you going to refer her to radiation now? Are you going to think about additional systemic therapy?
So for this patient, whenever small cell it is there, I feel systemic therapy would take a precedence over the local therapy. Now she is a platinum sensitive still. 10 months has passed after her prior platinum. So re-challenging with the platinum, and then if you have a good response, consolidate with radiotherapy. That is what I would think for this patient.
Do you agree with Saurav's definition of platinum sensitivity? Is that the same that's used in other
I
cancers?
think for us it's 3 months or so. If it's more than 3 months, you can still re-challenge with the primary regime. So the disease is coming back after 10 months. I think we are happy to use etoposide, a platinum-based regime again. So I just wanted to know whether the disease is still limited or is it spread?
Okay, so that's a good question. I think here is a PET scan. I just took a snapshot of the PET scan, and essentially it was mostly
Looks limited. No, there are some
where
lymph
the
nodes, is
bladder.
it? No, there are no lymph nodes in the midline? No.
So it's abdominal disease itself.
Yeah,
right?
just
It
in the
has not
pelvis.
spread.
So the patient does get cisplatin and etoposide. We chose to give the same drug. What would the alternates be if it weren't cis etoposide? What do you recommend? Let's say it was within 4 months. What would your chemotherapy choices be?
I read the data about DLL3 antagonist.
DLL3.
So I think tarlatamab is there. So obviously it's hypothetical only. I've never used it, but I think that might be something beneficial in this select subgroup. If you find that bispecific antibody, if that's available, would love to target it with that. Or I think lubrinectedin. So I think these are the two options, but obviously in India I've never used any of these. Although I will go to a conventional chemo like docetaxel or an irinotecan.
Topotecan.
Topotecan?
Yeah.
Okay, would you agree?
Yeah, I would do that. That's what we do.
Tarlatamab is available and it's FDA approved now for small cell. I didn't see any data in bladder, but they did have in that trial patients with prostate cancer who had neuroendocrine. It's not an easy therapy to give, so these patients end up getting admitted to the hospital. So, but at least something for the future. So this patient did end up getting consolidative radiation. Could you talk a little bit about, again, what would your type of radiation be, what the field of radiation would be?
Yeah, definitely. Seeing this patient like it has recurred and then we have again offered systemic therapy, then we have seen that the disease is regressing. So we can definitely add radiotherapy, but seeing the patient, if there are comorbidities, we can definitely chip in SBRT or hypofractionation in these patients, like 50 gray in 20 fractions we can do. And we can also include the pelvis. And we can also have a simultaneous integrated boost to the tumor area so that we have a good local control. So definitely I would use SBRT in these cases because we have seen a comparison SBRT with conventional radiotherapy. So definitely the local control is better with better outcomes with same toxicity.
So did she get radiation in the first line setting as well, or did she undergo with the surgery at that point?
She had surgery.
She had surgery.
And then she was YPT2s
Right.
N0.
So no radiation.
Didn't get radiation, went with adjuvant nivolumab, and now the role of radiation. So somewhat provocative, but I want to ask my two medical oncologists on the panel about, would you send the patient for a PCI, for cranial radiation?
So probably yes. I mean, we have done an MRI baseline. The patient has recurred, and 10 months and the subsequent recurrences, there is a high chance of CNS involvement. We do not know how long the patient is going to be. So considering the expectancy vis-a-vis toxicity with PCI, I would probably go for a consideration of PCI.
Do you have any thoughts?
Can we do PCI in the upfront setting as well? Once you have reported that the tumor has definitely shrunk, you can go for the PCI at that point as well. I mean, that's open for discussion.
So do you guys do it?
We need to see those patients in order to generate our own ideas,
There is definite evidence, like if it is a T3 tumor and N1 tumors, also M1, so the rate of brain metastasis is around 50%. And it has been seen if we add PCI, it comes down to 14%. So definitely there is a role of PCI to
Well, the patient did get consolidative radiation, currently is without any evidence of disease. We discussed PCI and I think she's opted not to do it. And I wanted to see if the audience had any questions that we can have our panelists answer.
So if this patient would have had a metastatic disease now, would you like to give etoposide, cisplatin or atezo now?
I mean,
after 10, would you like to change your immunobackbone?
Yeah, I probably would do topotecan. Any other comments? Final comments from our panelists?
Yeah, just my question is how much platinum you can give?
How much platinum? That's a good question. You know, I think it really ends up on their neurotoxicity, how much they can tolerate. But I think here having a diagnosis of neuroendocrine is certainly somewhat limiting their overall life expectancy. So I mean, most patients can take up to 8 cycles. If there are no other comments, I'd like to thank the panelists. We'll give them a
Son, you have
show of
anything to add?
hands. Yes?
I think our chairperson, Son, do you have anything to add?
Oh, I was just going to ask, if this were a ban and it were, we had a small cell that was in the pelvis, we're not sure if it's bladder or prostate, would that make any difference to what you would do, or does it not matter that you have small cell, it doesn't really matter if it's bladder or prostate?
No, it might make some, issues regarding our treatment regime. So I might need to add ADT to cater those adenocarcinoma component that might having a niche, because it can escape our, small cell neuroendocrine chemotherapy regimes. So yeah, that will matter if the patient is having a prostatic adeno CA along with a major component of a small cell adenocarcinoma.
Just to add to that point, many of these prostate neuroendocrine which we have seen small cell, they present as bladder mass. They are fast growing from the prostate and they present as bladder mass. Someone has evaluated outside the institute and they said it's a bladder mass. They do a TURBT and you get a small cell carcinoma. If the patient is in that age group of 60-65, we would discuss and definitely evaluate the prostate a bit. At least some kind of evaluation with the PSA levels and all that would be done to see if there is prostate with neuroendocrine deficiency. Because the bladder neck masses, sometimes they would be probably prostate in that.
Yeah, good
So
point.
that is my experience. I completely agree with Santosh. They came as bladder mass, but actually in a small percentage, they are prostatic tumors which has gotten into a small cell.
So I have seen 2 patients who presented to me at the around age group of 48 to 50 years old, upfront neuroendocrine carcinoma prostate, and again, metastatic advanced stage disease. There was PS 4.5 to be honest. And we just started with a low dose chemo and we just kept on going. Now they are doing fantastically well. And I had to add ADT because there was a small component of the adenos. So he was having both PSA somewhere around 8 or 9 and bulky disease, visceral metastasis, bony lesions, collapse, vertebral fracture, and now everything is vanished.
Well, that's how you end a conference on that note, to having such a good response to therapy, and that's what we want to do for our patients. So again, thank you all for a lively discussion and appreciate your...
Thank you everyone, the panelists in the chair. Would you guys come in the middle for a group picture? Keep Son in the middle, the tall man in the middle. Santosh, keep Son in the middle, the tallest man.
Lights off. Sir,
You have to follow his instruction. No. Do with that pose. Pose Melo.
Yes, sir. Camera look, sir. Sir. Ma'am. Yes. One more thumb. Yes. Good. Beautiful. Good, sir. Thank you,
Thank
sir.
you so much. Thank you. So I would like to have Son, would you mind sitting there as a chairperson for the next session? And Santosh also, because we have a nice bladder talk. And so the next one is the pathologic substaging of bladder cancer updates, controversies and guidelines by one of our friends, Ankur Sangoi, who is a professor of pathology and director of geopathology at Stanford University. Unfortunately, he is not here, but he has recorded his entire talk. Though it is a recorded talk, it sounds very lively and interactive. You can have the questions to me. I'll get all these things answered. And we'll have a conversation later on. So can we start?
My name is Ankur Sangoy. I'm a professor of pathology at Stanford. Firstly, thank you for the organizing committee for the invitation. And I apologize I was not able to attend this, present my talk here in person. I had some schedule conflicts. Thank you for allowing me to do so virtually. So today I'm going to be talking about the pathologic substaging of bladder cancer, and including some updates, controversies, and hopefully providing some guidelines. So without further ado, let's actually just dive right into a case. I think that'll kind of show some of the issues here. So we have a 55-year-old male presenting with hematuria who undergoes TURBT, TURBT for the bladder wall, posterior bladder wall tumor. So low power, you can see multiple fragments of this kind of papillary-looking proliferation. Looks like a papillourothelial carcinoma at this power, and ample muscle bundles. This looks like a very good sample. However, let me draw your attention to this particular focus here. And this kind of medium power, you can see, some background papillary structures in here, and then this discrete nest, has at least some, on this power, some areas concerning for lamina propria invasion. Higher power examinations, you can see these small irregular nests, some including some individual single cells, in keeping, as well as even here, with some kind of inflammatory reaction to it. So in keeping with essentially a touch, so to speak, of lamina propria, invasive urothelial carcinoma, and so you get this case across your desk, and one potential way to sign it out, which may be they're totally appropriate, and how folks are essentially signing these cases out, is a bladder tumor, posterior wall, TURBT, and it looks like a high-grade papillourothelial carcinoma invading the lamina propria. And as usual, we always mention the presence or absence of muscularis propria. However, let's take a closer look at that in terms of assessing or potentially, further evaluation of this lamina propria invasion. So the 9th edition of the AJCC actually states that an attempt to categorize PT1 disease is strongly recommended with the level 2 evidence. And they, in their definition of microinvasive carcinoma, do list out that it could include invasive tumor less than 1 high power field in content. It has a greatest invasive tumor diameter of less than or equal to 1 millimeter, or an invasive tumor above the MM, and MM being the muscularis mucosa. You'll see that throughout my talk. Above the muscularis mucosa, but extending to a depth of less than or equal to 2 millimeters. The College of American Pathologists, in their sort of synoptic summary form for transurethral resection specimens, under the subcategory of lamina invasive into the lamina propria, actually has essentially a blank, a free spot, a free text, for allowing you to specify the extent if possible. And under their subheading specifically state that pathologists are encouraged to provide some assessment as to the level of lamina propria invasion, albeit by maximum dimension of the invasive focus, depth of invasion in millimeters, or by level, being either above or below the muscularis mucosa. So let's go back to our case. So here, for example, we have our small irregular nests of invasive urothelial carcinoma. Looks like it's probably above where, maybe not potentially seeing the muscularis, we may not even see the muscularis mucosa in this field, but if we were to measure this, at least this looks like this, it would be around 0.33 millimeters across this way. Measuring it across this side here would be 0.58 millimeters. So I think one reasonable way to assign this case out would be high-grade papillourothelial carcinoma, focally, superficially, essentially less than 1 millimeter invasive into the lamina propria. And I think that offers probably a little bit more clinical information to our urology colleagues, and was fairly quick and dirty to apply some more detailed analysis that could be performed in this case. However, look, not all cases are necessarily as straightforward, as simple as that one. So here's another example. This was also a 55-year-old male presenting with hematuria who underwent a TURBT for a posterior bladder wall tumor. And again, like the other one, you can see these large frondulous papillary proliferations in keeping with a papillourothelial carcinoma. And I sort of want to draw your attention to this particular focus here with what looks like this power, 2 discrete tissue fragments. And again here, high-grade papillourothelial carcinoma with some necrosis along the periphery, and then 2 discrete tissue fragments here. And in this power, you can hopefully appreciate at least some of these, at least concerning for lamina propria invasion. On the upper right, you have 1 fragment. On the lower left, you actually have a second fragment. So applying some of those same modalities that I showed earlier. So let's just say, for example, we take our depth of invasion to this point here. It looks like there is an irregular nest along with all these other small irregular nests of invasive urothelial carcinoma. So the depth in this case would be 0.99 millimeters. However, if we assume, it depends on sort of where you draw the line, that the depth of the tumor actually starts here, invasive focus starts here, the depth of invasion to that same tumor nest would actually now be 1.04 millimeters, so above the 1 millimeter cutoff. It's a little challenging in here as to assessing muscular mucosa or vascular plexus, but in terms of depth of invasion, I've shown you, you have some problems in here. So a case like this, for example, you could theoretically sign this out as high-grade papilloepithelial carcinoma invasive into the lamina propria. Is it focal? Is it non-focal? And I showed you two discrete nests, although they were right by each other. Is it still microinvasive? Is it now extensive? Is it still superficial? I showed you the issues of measurements if you're going to use that 1 millimeter cutoff, which a lot of people in a lot of literature is actually cited in using. And then again, is it above or below the muscular mucosa? These are challenges that could be, that are quite evident in a case like this. And this is not a rare case. This, I would say, I come across cases like this almost every day, and I'm sure many of you do as well. So in an attempt to sort of deep dive into the literature in preparation for this talk, I reviewed the data on substaging of bladder cancer. There's a lot. There's quite a bit. A lot of it is good, and a lot of it is less good, let's just say, and less potentially reproducible. And I suspect that the members of this committee, it was actually a very nice survey study, a subcommittee that was done by the ISEP Society for Consensus Conference on some of the issues of bladder cancer. Specifically for this one was subcategorization of T1 bladder cancer. I'm sure they had the same challenges that I did in reviewing some of the literature. But I would draw your attention, or at least note that at least some of these, highlight some of these, the responses from the committee members and from the voting society members. So specifically in terms of T1 substaging, and I want to pause and talk about substaging for the T1, at least numerically. Although we don't provide a numerical PT1, 1A, 1B, or 1, T2, and all those kinds of things, a numerical one for TURBTs, those are reserved for cystectomy specimens. For the purposes of this study, they're talking about PT1. And for the rest of my talk, I'm talking about PT1 that you do apply theoretically in terms of T1 being a surrogate for lamina propria invasion or depth of invasion. So the question was, do you consider substaging in TURBTs, not necessarily cystectomies, relevant enough to apply in daily practice? And you can see there's an overwhelming majority that, yes, we should be doing this. So much so that the ISEP should actually support it and endorse substaging as part of the daily practice. However, you can see the numbers and the percentages are kind of all over the place in here in terms of what method is either preferred or recommended to apply in these subcategorization of T1 disease. And there's a small proportion said that we should do histoanatomic, which is essentially the millimeters muscular mucosa assessment. Other people talk about you use some sort of quantitative assessment, essentially using a micrometric, essentially, and I'll address some of these different topics throughout my lecture here. But you can see in others said, as long as you just essentially, describe some of the issues or potentially even a combination of these various modalities to stratify PT1 substaging. But you can see that there's really no consensus as to how to do it. So yet it's recommended to do it, but there's really any kind of guidance or consensus as to how to do it. So that's a problem. So hopefully, at least at the end of this talk, you've gotten some guidance as to how to potentially go about it and what are some of the issues. But let's start with just a kind of a basic primer on substaging of urothelial carcinoma. So I divide, and others have done similarly, but I divide PT1 substaging into these three modalities. So one is a descriptive modality, one is a histoanatomic modality, and one is a micrometric modality. And I'll go through these various techniques here. So the first technique is descriptive. So essentially this is a written, textual, subjective, just a word of mouth, just a kind of a gestalt, so to speak. Are we talking about something focal, or are we talking about something extensive in terms of depth of lamina propria invasion? Is it single or is it multiple? And you can see this is pretty quick. It's kind of quick and dirty. It's very easy to do. It's not dependent on the orientation of the specimen in any way, but obviously you can see immediately this is quite fraught with subjectivity. My focal may not be your focal. Or my extensive might allow for a little bit more than your extensive in terms of multiplicity as well. It can be quite a problem. So There definitely has some pluses, but it definitely obviously has some minuses, both in terms of inter-observer reproducibility and potentially even intra-observer reproducibility. And potentially something you called focal today, you might not call focal tomorrow. Another technique is what's called a histoanatomic technique. And essentially what that looks at is the depth of invasion, or essentially a level of invasion of it within the lamina propria, and it uses the muscularis mucosa or the vascular plexus as a key landmark. There are some places in the bladder, in some instances, where you may not have an MM present, and so when you don't, you theoretically can use the vascular plexus as a surrogate for the muscularis mucosa. And the one attempt is to substratify PT1 disease into 1A, a 1B, 1A being above the muscularis mucosa or VP, 1B being below it, or theoretically you could actually break it into 3 pots, 1A being above, essentially 1C now being below, and 1B being into, but not necessarily through the muscularis mucosa. This is, again, fairly quick, somewhat less subjective than the descriptive technique. However, the negatives with this one are this is clearly orientation dependent, and there may be variability in the muscularis mucosa or the vascular plexus as landmarks. If you're using this, essentially use these as the landmarks as your gold standard throughout, there can be quite a bit of variability within the bladder, and depending on if you're provided with that clinical information as well. So this is kind of a nice cartoon that many of folks have seen straight out of the AJCC, showing the various depths of invasions and how they sort of correlate on a cystectomy level in a cartoon format for bladder cancer. But in a practical format, let me show you kind of a nice low power correlate. This is just a nice section of a normal bladder wall section from the posterior wall. And so here, for example, so we're, obviously the goal in my talk is focused on PT1 disease, but anything essentially flat or non-invasive constitutes PTA. PT1 is essentially here within the subepithelial layer, all the way up into where the beginning of the muscularis propria starts. That would all be PT1. The inner muscularis propria is all PT2A. The outer muscularis propria is all PT2B. 3A and 3B substratification have to do with, if you can see the tumor only on microscopy, that is a PT3A into the subserosal adipose tissue. 3B is something you can see macroscopic. And then 4 would actually be invading to another structure, but not necessarily appreciable here on this section. But this is kind of a low power kind of correlate of the cartoon that I showed earlier. But obviously my focus here is on PT1 disease, but I want to sort of highlight in here, not necessarily intending to stretch it out on purpose, but show you there's a lot of room. There's a lot of gap between the subepithelial layer and where the muscularis propria begins. So, there's a lot of potential variability, not necessarily variability, but there's the range of how deep all constitutes PT1 can be quite extensive. So I think there are at least some importance of substratifying PT1, at least on a sort of geographic sort of level when you're seeing these. But I definitely want to give credit to these 2 studies, mainly by Drs. Gledel-Paner and Mahol-Amin, for really kind of providing guidance in terms of the histoanatomic landmarks on the different muscle layers and things like that in terms of histoanatomy, essentially going through multiple bladder sections and really helping to determine how the different sections and areas of the bladder look like and are clinically obviously relevant in terms of staging. So if you haven't seen these studies before, I sort of highly encourage you to at least review these to sort of understand some of the landmarks and the layers by anatomy. So let's kind of dive right in with some examples. So here's a nice section of the anterior wall. So here you can see these nice thick muscle bundles are muscularis propria. And this is a section of normal bladder in here, so you have some normal urothelium up top. Here is the muscularis mucosa, a nice thin muscle bundle here, and in the sections that potentially, if you didn't have that, you could always use the vascular plexus as a surrogate. You can see why, for the most part, it's at the same level. If the MM is not going to be present, that you can use the vascular plexus as a surrogate. So in a normal section of an anterior wall here, you can see some clear separation, urothelium here. Essentially everything here is above the muscularis mucosa or vascular plexus here, and the deep muscle bundles of the muscular propria are well below that. So this is a nice high power shot of showing the nice thin wispy bundles of the muscularis mucosa going across, and then potentially at the same level of where the vascular plexus is. So that's the anterior wall. The dome, however, looks quite different for the most part. The dome, you have these nice thick muscle bundles here down below in these kind of subserosal adipose tissue. However, the muscular mucosa in the dome can be quite hyperplastic. So here, if you use that anterior wall, for example, that's our friend, the MM that we saw coming across. However, you can see in here that the muscular mucosa goes quite high and is quite hyperplastic actually in the dome section. So staging-wise, that's actually very important and can be very helpful to know either on cystectomy or even on TURBT as to what you're dealing with. Because you can see here below it is some respectable muscular mucosa that we all sort of recognize. But here, this is also hyperplastic muscular mucosa. So the dome is sort of fraught and well known to have a very hyperplastic layer of muscular mucosa. So that can be clinically important when you're staging cases. And then in direct contrast, though, the trigone is well known to have a very, very thick muscle bundle of the muscular propria, so much so that essentially there is a very thin layer of muscular mucosa. Sometimes it can be essentially atrophic, and all you're left with is essentially the vascular plexus. So even here, this is probably just collagen, but essentially all the muscle bundle you're seeing down below are all MP, all muscular propria, and all that you've left is the vascular plexus. So there's really almost no to limited MM here. So essentially any muscle you see in the trigone is very often going to be probably MP. The MP essentially comes up quite high in here, but in this context you can see that using the vascular plexus is actually much more important than maybe just a sliver of MM here, but the vascular plexus is a better surrogate in this particular context here in this section of normal trigone. So, all right, so that's all normal and that's all great, but let's apply these to actual cases in here. So here's a beautifully oriented cross-section of a TURBT, and I will tell you that it is from the posterior wall. So you have a papillary urothelial carcinoma here, and here you can see a nice, well-oriented layer of the muscular mucosa kind of coming across. Here you can see it's sort of absent potentially, but you do have the vascular plexus as the surrogate here. You did have it here as well. And then the muscular mucosa comes back across in here. So a nice, beautiful section. You sort of hope that all of our cases are laid out and embedded like this with this histology. And here you can see the nice muscular mucosa kind of coming across. The gap of no MM, but you do have vascular plexus, and then the MM happens to continue there. So here, let's look at this particular corner where you do have a little bit of invasive lamina propria urothelial carcinoma with these retraction nests with some early desmoplasia. And here you can see in this section, you did actually have a little bit of muscular mucosa and potentially even the vascular plexus, but this tumor looks like it's essentially on the right side, essentially above the layer of either the MM or the vascular plexus. Here's another shot here. So in an example like this, the histoanatomic can be quite easy or quite helpful. This is a section from the trigone, these broad fronds of papillary urothelial carcinoma. This case is actually a non-invasive urothelial carcinoma, but I'm showing you an example of a real-life case of trigone to show you how high the muscle bundles come of the muscular mucosa and how atrophic, essentially absent of the muscular mucosa layer is. And essentially all you have left is a vascular plexus that you're supposed to theoretically use if there was invasion in here for a histoanatomical depth of level. So how about fat? I've talked about all these muscle layers. Can you use fat as a histoanatomical staging in TURBTs? And the answer to that is no. We did the study and should be out in press essentially sometime in 2025, looking at consecutive large series of both benign and malignant biopsies and transurethral resections, and as many of you know from cystectomy specimens, that the fat can come up quite high. You're not supposed to use that for staging, but for TURBTs, I still see consult cases and people substaging fat and using fat as a surrogate for, oh, okay, tumor is invading fat, and so now this is essentially indicative of extramural, essentially outside, or extravesicular invasion, and you're not supposed to do that. So just keep in mind that, fat can come up quite high, up to the level of the, it can be both in the LP, it can be the MP, it can be both of them, and you can have fat in essentially all the anatomical locations in various layers. So in a nutshell, you can't use fat in terms of for related to my talk here, for PT1 substaging, fat is not a reliable landmark to sort of help guide you. You're really left with essentially the MM or the vascular plexus if you're using the histoanatomic technique. So why does that even matter in terms of histoanatomy? Where in the bladder? You get a bladder cancer, does it really matter where? If it's in the trigone, posterior wall, or whatnot. And I think there's several good studies showing data that, for some sites, for example, like in the trigone, that you do have a significantly related shorter survival, In the trigone, for example, you have a decreased cancer-specific survival, higher incidence of lymph node metastasis. The bladder neck invasion cancers have a higher frequency of MP invasion, advanced stage. So I think knowing where you are in the bladder, histologically makes a difference in terms of where you're staging, but I think prognostically, for many of the urology colleagues and oncologists in the room, I think you may know this already, that where in the bladder actually does make a difference, or at least may make a difference in terms of outcome. So the final technique of histoanatomic, the final technique of PT1 substaging is the micrometric. And essentially what this uses is an optical micrometer to measure the invasive tumor. There's a couple different modalities or ways that it's been used in the literature, and I'll go through each of these, but they're listed here. But you can imagine this is quite precise. You're essentially taking a ruler or micrometer, essentially measuring the depth of invasion. It's clearly less dependent on the orientation or the landmarks, so it doesn't really matter if MM, BP, all those kinds of things, where you are in the bladder. But but the 3D relationship can be quite challenging in some cases, and I'll show you examples of what I mean. And if you're essentially adding or measuring multiple foci, or if there happen to be multiple, this is time consuming. And for many of you, probably like many of the pathologists in this room, I have a high volume and high cases of either urologic or any of the other specimen types. You may not have time to essentially pull out the ruler and actually do a depth of invasion or measurement on a bladder cancer for T1 substaging. So that can be potentially challenging and a potential limitation. So let's talk about some of those micrometric techniques. So one of them uses the terminology PT1 M for microscopic versus PT1E for extensive. And the microscopic is defined as a single focus of invasion with a diameter. Or sometimes it's depth of invasion across from the top, but essentially it could be that, but essentially it's whichever is the greatest diameter, period, across or from top down, of less than 0.5 or less than or equal to 0.5 millimeters, which is approximately, essentially less than a 40x objective. Or if it's extensive, then it's greater than 0.5 millimeters, or having multiple microinvasive foci, so multiple, essentially more than one. So either one of these would get you to T1 extensive or T1E. Another one is called RAL 1-2. And essentially the terminology is based on the original depiction of paper where this study was essentially came out of, the Urologic Oncology. And essentially for this one, you actually add all of the invasive foci diameter. So if you add them all up, if they're multiple, and you have a sum of less than or equal to 1 millimeter, that's a RAL 1. It's roughly a 20x objective. And then however, if it's a RAL 2, if your sum is essentially greater than 1 millimeter. So that's RAL 1 versus RAL 2. And then the final one is called ALICA, and that stands for an aggregate linear length of invasive carcinoma. And essentially, it's similar to the RAL. Essentially, you add all the diameters, all the invasive foci up, and you essentially spit out and come up with the number. But there are some follow-up studies showing that clinically, there's this cutoff of having to be of 2.3 millimeters. If your sum is greater than that's clinically relevant at that point. And roughly, if you had one tumor focus, that would be about a 10x objective, which is kind of a lot if you're seeing essentially wall-to-wall tumor. But again, that's for one focus. If you're adding that up, the objective is probably less relevant. Essentially, you add all the different tumor foci up. So I've shown all the different techniques now. I've gone through all the different broken down the different techniques, or sort of highlighted all those. Let's actually apply those in real practice. So going back to our case here, we had a TURBT with this focus of invasion here. It looks like it's probably above the layer of the muscular mucosa. It looks like the MM is probably absent here, even though this was the posterior wall. But here you can see you do have the MM going across, and then you can probably use it as a parallel line and where the vascular plexus is. And it looks like this tumor is probably above these thicker walls of where the vessels was, using the MM on the parallel layer where the vascular plexus was. Going back again, this was 0.33 millimeters this way, but the diameter is this way, which would be a little bit bigger, so 0.58. So if you're using the descriptive technique, this would constitute, you probably could call this focal, single depth of LP invasion. If you're going to use the histoanatomical technique, this would be a PT1A, right? Because this is above the muscular mucosa or the vascular plexus layer. If you're using the micrometric, however, because this is 0.58 above 0.5, this actually becomes the PT1E extensive, despite being that single, theoretically, quote unquote, small focal superficial invasive focus. So that is, it is what it is, but it's seemingly a little, unusual that you're calling this a PT1E. And then if you're using the micrometric, this would be a ROL1 based on the diameter, or an ALICA of a 0.58. These are somewhat related, but it's mostly the cutoffs of the greatest, or the sum of the diameters of the invasive carcinoma. Okay, so that was that case, which was seemingly straightforward, but I can brought up some immediate challenges and problems already. So let's go to this case. Another high-grade papillothelial carcinoma with 2 foci that I showed earlier. So let's look at the depth of invasion on here. So in this case, it's like you probably have a muscularis mucosa layer right here with probably some vascular plexus. So the tumor, which is you see here, this nest kind of stops right here. So if that's your assessment of where the muscularis mucosa is, this looks like this would actually be above it. However, if you draw your line here and you say, well, no, I think that actually the muscularis mucosa, I see a little wisp of pink and it looks like it's actually standing above here, you have tumor on the other side here. So now, is this wrapping around? Has this actually reached it? Has it gone through? Is it through the muscularis mucosa? It's a challenge, it's a problem. So it's not necessarily all that straightforward. In terms of depth of invasion, I talked about this or showed this earlier, it's 0.997 across that way, but if we said, okay, let's be conservative, let's use the larger one if we're using, the greatest dimension here, 1.04. Going across this way, the greatest diameter on this way was actually 1.4 on the other separate, smaller focus that I showed that was just kind of nearby. So it was smaller, so to speak, in terms of size-wise, but it actually had a greater depth of invasion, interestingly enough, of 1.4. So using the descriptive technique, would this actually be, would you still call this focal? If you're just using essentially words, even though they're both, quote unquote, small, so to speak, is it extensive? It's clearly multiple during 2 foci, but is the equational versus focal versus extensive. Histoanatomic, I showed you the issues with the muscularis mucosa. It would be on a 1A, 1B, is it really a B, or has it actually breached it? If you're using a 3-tier, is it a 1B versus 1C? You think you do have 2 foci, and I think you do have 2 foci here, so this would at least constitute a micrometric of extensive PT1E. But on the micrometric, if you add up all those individual foci, you actually get a score of 2.44. So this would be a ROL2 or an ALICA of 2.44. And if you recall that this is actually higher than that 2.3 millimeters, or roughly, that I showed earlier, that approximation. So clinically, this would actually be clinically relevant, being with the ALICA of this particular score. So those are the sort of 3 modalities. I will tell you that there are actually some studies advocating combining the PT substaging techniques, PT1 substaging. So if you thought any of those individual modalities was sort of challenging to either apply or sort of essentially grasp or sort of do on a daily basis, or time consuming, there are some modalities, at least showing good data, that when you combine, you actually provide better potential outcome in terms of how patients essentially progress. But again, you can see the issues in terms of time with some of these techniques. I do want to draw attention to this study. It was actually quite interesting, and I think essentially overlapping with a lot of the data that's happened in GI pathology world with polyps. Essentially having to do with polyp stalk invasion versus actually invasion into the base. And this really nice study with beautiful progression-free survival data showed that if you essentially stalk invasion only, which is essentially if you have a nicely oriented specimen in here, you can see the progression-free survival, how that sort of stratifies across, rather than base invasion, focal versus base invasion extensive. So you can see that here at kind of a low power. But that's a cartoon. Let's apply that in real life. So here's an example of a beautifully oriented PT1. And there is some invasion, I'll show you higher power, but a nice papillary urothelial carcinoma, which looks like there's just stalk invasion. It looks like the base on higher power, if you trust me, it was actually quite clean. So on high power, you can see here, you have some regular nests within the stroma in here. This looks like stalk invasion into papillary urothelial carcinoma, so stalk only. So that would be on the sort of better prognosis modality on that study I showed earlier. For the folks that also happen to do GI pathology in terms of tumor budding and have seen the data and literature coming out, that it seems like we're getting some of that sort of spilling into our GU land in here. And there's at least some studies talking about the concept of tumor budding and whether that can be sort of added into the algorithm of budding present or absent. But it's unclear how that's if you add budding into the various modalities or techniques of substaging, how that sort of applies. Is it an independent prognostic? Is it an independent variable or not? It's a little unclear, but it's showing you and at least telling you that there's data out there in terms of the concept of tumor budding in bladder cancer. I've already shown you several controversies already, but let me just kind of highlight a few other issues. So everything I've shown is pretty much related to typical urothelial carcinoma, NOS, essentially kind of routine typical papillary urothelial carcinoma. I haven't really talked about even variants at all, and I keep saying the word variants even though I still probably will, but officially it's subtypes, variants being essentially restricted to those tumor types that have a unique molecular alteration and divergent differentiation to those listed here, those 4. But everything I've shown you, all the data with substaging is theoretically applicable to substaging, but there's been limited data the substaging is theoretically applicable to other subtypes. But there's not a lot of good data. It's mostly for traditional urothelial carcinoma subtypes. So here's an example. You get a TURBT, for example. Let's pretend this was a TURBT specimen, that you see these small nests in here, and it looks like, okay, it looks like it's potentially just an invasive, possibly invasive urothelial carcinoma, or there's just even just florid von Brunn's nest proliferations, where the depth of invasion is kind of irrelevant. However, as you progress down deep, and it's a lot easier on a cystectomy specimen, you can see here this is actually a nested subtype of invasive urothelial carcinoma deep going through into the PT2B, into the outer musculars propria in here. So you can see the subtypes can be quite challenging in and of themselves. And, however, sometimes subtypes are not provided. So in this example in here, again, another nicely oriented papillourothelial carcinoma tissue fragment that comes across your stage, and history is not necessarily provided in terms of the location. But however, you could potentially assume, and you do a chart review, and you ask the urologist, you do see some abrupt transition due to non-keratinizing squamous monoplasia, so we're actually in the trigone. So at least you get that piece of information that you had to work for. So let's look at this potential corner here, this face or this aspect of the tumor, to kind of highlight some of the controversies. So you have a smaller papillourothelial carcinoma up top, and immediately you start appreciating some small irregular buds, essentially nests of tumor cells invading into the lamina propria in here, with these some smaller, some irregular, with stromal retraction. So it looks good for an invasive urothelial carcinoma. All right, so now let's highlight some of the issues. It looks like if you draw your line here, which looks like the thicker muscle bundles, I didn't really appreciate a great muscularis mucosa. However, we can use our friend, the VP, as a correlate. So this looks like this tumor is probably, still above that particular layer, right? So it's kind of not quite into the VP depth landmark. However, how would we measure this? Do we go from here to here? So then if you did that, that would be 1.73, which is, potentially totally reasonable. However, should you go in this particular direction, this would be 1.55, and this is just one focus. What if there was another tissue fragment that, also where you're having controversy and issues with the measurement? Should you use this? Should you use the leading edge? Should you actually measure here? And then for this is actually 1.09. A little bit smaller, just under 1 millimeter here. Do you take these individual foci, stop and abruptly and just add them, or do you go across and then add them all up together? So you can see some of the issues, in terms of, histoanatomic, for micrometric, that are potentially, seemingly good in terms of measuring and applying, but not necessarily easy to apply in every single case. So here's an example, TURBT specimen, nice papillourothelial carcinoma, some hyalinization, and here at the top of the field, looks like you have some invasive carcinoma, right? So we'll go here at the step of invasion, and whatever it is, and that's fine. But is that the orientation? I said sometimes you have issues with 3D orientation. Okay, so now, maybe the tumor is actually in the patient actually came out this way, right? And if that was the case, then the depth, and you say probably maybe the depth of vision is actually starting here, so I'm going to use this as my measurement. And this looks like the greatest dimension this way, right? You're not going to go across this way, you're doing this, okay? That's fine, but well, you know what? Maybe that's actually not the 3D orientation. Maybe the orientation is actually here, it's this way, and then if that's the case, the depth of invasion goes all the way, and you can see this is significantly more than if you went across the other way, across that way. So, than I showed earlier. So you can see this is also fraught itself with issues in terms of 3D orientation, in terms of how you actually go about measuring. So we talked about stalk invasion. I'm going to go back to that case because I actually lied to you. I showed you that one focus of stalk invasion. However, there was actually another focus in here. Both still stalk, and they're both shown here, but they were actually two separate foci, tiny little foci of invasion that are shown here on higher power. So these both small foci that would have still stayed as stalk invasion on one of those other studies I cited, both being quite small, both being, if you added them up, would probably essentially fall under the 0.5, yet this is now going to be extensive because there's two of them. So you can see, the controversy, with that if you're going to happen to use that particular modality. So we're talking and assuming that, invasion is essentially straightforward and obvious, and for the folks that obviously do practice GE pathology in terms of pathology sign-out, you know that that's not even always the case to even begin with. So here you have a papillourothelial carcinoma, no history is provided in terms of the anatomical site in the bladder, and you see this little area in here, which, potentially rounded, at low power, it just might be this is, to me, probably not invasive, it's just potentially tangentially sectioned kind of nest, and even here your eyes are drawn, looks pretty similar. Maybe it's just kind of a pushing pattern in here, or at least a funny, cut of the papillourothelial carcinoma. So, is this even invasive? But you can see here along the leading edge, it looks like there probably is some reverse or sort of paradoxical maturation with very sneaky little tumor buds, such that you can probably pull the trigger and actually call this an invasive urothelial carcinoma, probably into the quote-unquote inner lamina propria, but just highlighting this to kind of show you that just getting to invasion sometimes is a challenge in and of itself. And don't forget that hyperplastic muscular mucosa is definitely a huge pitfall in some instances, and would not constitute MP invasion, but obviously in itself challenging to even get to in terms of assessing across and dimensions and things like that. If this is even, if this is MP or is this even MM? This case was actually a hyperplastic MM. We've talked about TURBTs, but just remember that theoretically you can actually apply the histoanatomic, and that's obviously a lot easier in a cystectomy specimen. That the case I showed earlier of that hyperplastic MM, this is actually the resection specimen from it. You can see here at low power, these thick muscle bundles, you might think, ooh, this is potentially T2 disease, but at low power you can see this thing is, the true muscle bundles way on this side actually here, and this is just beyond quite deep if you happen to go that way, but really this way would be essentially extensive. So this is really kind of knocking on the door of a PT2A, but actually has not quite breached it. And at least in the US and the States and some areas of Europe are using the AUA guidelines in terms of recommendations to essentially go back sooner for repeat TURBTs. And how that sort of impacts with substaging is really, there's really not a lot of data. Up to a third may actually get upstaged to T2, and for that reason alone, and possibly whether or not they get muscle or not, whether they get muscle on the first time is not necessary. There's a lot of variables, and we'll go into it today, which many of you probably already know, is when you go back, how often you go back, but we're seeing this a lot more now. A lot more follow-up TURBTs, but there's actually limited data as to how to go about how this adds into the substaging. There's some data showing that you add the residual invasive foci on the REAT TUR to the original measurement. And you can see that, that could, in orientation, it was already problematic enough in an intact specimen, but either way, that there's data showing that the survival is actually better, that patients that just undergo TUR, period. So just undergoing the TUR is great. That's why they actually recommend it, but none of the substagings have really predict recurrences in terms of how you substage these redo TURBTs. So the data's, the jury's still out. Many of you may be seeing specimens, at least in our at Stanford, we're starting to see this a lot more, essentially these en-bloc resections, almost like GI, EMR, and endoscopic mucosal resections, where they essentially lift the entire tumor bed out, ink the peripheral margins, and then we do provide data in terms of this laterality of the margins, and it does theoretically make it more optimal for PT1 substaging, right? Because you get those nice, pretty specimens. We're not getting this on every case by far, so I'll tell you, it's sort of a new modality. There's plenty of literature out there, but theoretically it does give you improved orientation, improved landmarks. But in terms of how that impacts substaging, and potentially if all the cases came like this, I think a lot more folks would probably advocate for substaging. But that's I think not a lot of places are necessarily getting specimens like that. So in summary, the PT1 substaging techniques come in kind of generally three flavors: the descriptive, histoanatomic, or micrometric, each with its own pluses and minuses. There's definitely benefits for all of these, and which of the ones you end up choosing, if you even choose to substage, I think is really kind of up to you. But I think if you're going to do it, I think you should probably choose and apply a method that balances precision, applicability to the maximum number of specimens, with minimally dependent on the orientation and time, because some of those ones are seemingly quite good, and if you've done and practiced this, in preparing this talk, I actually went back and tried the different modalities and followed up some of those patients and saw, and it was like, wow, that, might have been superficially invasive, but actually came up with a really high ALICA score. Maybe that's the right thing to do, but it's time consuming, right? It really takes a lot of time. So I think you have to offer some sort of balance with that. In terms of future, we're in a world of AI, good or bad. I think there's sort of, the way I've been taught is, there's two pathologists. It's, AI is definitely going to be here to stay. It's the pathologists that either learn to incorporate AI or those that don't. That are, it's not going to replace pathologists, but it's definitely going to replace the pathologists that haven't really learned how to incorporate that into the practices. So is there some ability of AI to sort of, add in not only diagnosing bladder cancer, but intentionally offering potentially an easier substaging modality as well as molecular and other things in terms of outcome. But could that potentially help us for substaging? It's possible, and maybe that would make it a heck of a lot easier for measuring some of those histoanatomic or especially the micrometric modalities. But I think the jury's still out there, but I think that might be the next kind of wave in the future. If you're going to substage, let's see how AI kind of adds into that. And with that, I'll leave my email up here, and I think the members, organizing members, will post that or have that available. But please do send me any questions or comments or anything, and thank you again for your time.
So we can always take the questions and get it answered by Ankur. He has his email address, and eventually we're going to have an extended lecture, the same thing, in a virtual platform by probably in April or May. So we have the lunch open. Whoever hasn't got a chance to have lunch can go and eat. And then we can start in the next 20 minutes. We have 2 short recorded talk and 1 long recorded talk. They're very important topics, so I'll request all of you to be there. They have really worked hard for those talks. So I will go to the lunch area. Whoever has done, I'll just grab them, and you guys please go and have your lunch.
Distribution. So bringing up, again, going back to the differential, could this be potentially treated prostate cancer, especially given the patient's history? Could this be sarcomatoid urothelial carcinoma, given the sort of spindle cell-like appearance? Could this be a clear cell adenocarcinoma? Could this be an inflammatory or myofibroblastic tumor, especially with a sort of inflammatory-like background? Or could this be a funny nephrogenic adenoma? There's some additional things that were done. PAX8, you can see essentially lighting up all the cells, including the epithelioid and spindle cells, as well as the area that has kind of a myxoid-like appearance as well. So essentially everything is kind of mirroring the carrot stain that we saw. So this indeed was a nephrogenic adenoma, specifically a fibromyxoid pattern. So let's talk a little bit about nephrogenic adenomas. I think we've all seen these in our respective practices, essentially benign lesions along the genitourinary tract. We actually thought to be potentially metaplastic lesions. Some people actually term these nephrogenic metaplasia rather than adenoma. But there was some initial hypothesis that, hey, these are potentially maybe coming from the kidney. And also, despite one of my favorite studies, over 20 years old now, from the New England Journal, showing in patients that these are essentially coming from the kidney, with this really creative study looking at chromosome analysis of patients that had donor transplants from the opposite gender. So patients, essentially, when they did chromosome testing on patients, say, for example, a male patient, that testing the nephrogenic adenoma that had received a kidney, the patient received a kidney from a female patient, and then the nephrogenic adenoma actually had chromosome XY chromosome in keeping with the donor kidney. Or I'm sorry, an XX chromosome in keeping with the donor kidney, and inverse for the male patients as well that received kidneys from females. So that was kind of an interesting study. And a more modern version of this is actually a really beautiful study looking at RNA expression analysis by the Michigan group here, and showing that nephrogenic adenomas are essentially come from sort of the distal end of along the nephron tree here, and specifically are principal cell derivatives in that they show expression for L1-CAM both by RNA and by immunohistochemistry. So that can be kind of a useful thing. It's a very high sensitivity. So it's essentially kind of clinching on a biological level that these are truly coming from the kidney. So how about this unusual fibromyxoid nephrogenic adenoma pattern? This initial study from 2007 really was kind of brought it to the forefront, showing, sort of highlighting in a small series of 8 cases of nephrogenic adenoma. Notably, almost all these patients had prior therapy for other malignancies, but when they looked and they had the kind of unusual features of this sort of, and what they described as this fibromyxoid pattern, where the name sort of recapitulates the morphology, the spindle cells, myxoid-like background. You often see typical background nephrogenic adenoma elements, which can be quite helpful. You actually can also see the sort of amyloid-like appearance. These areas, these pink structures are all Congo red negative, so it's not amyloid. But importantly, all of, including the nephrogenic and the fibromyxoid typical patterns, all of them stay in with PAX2 and are all keratin positive as well. So it's just kind of an unusual pattern. And you can see in their initial series of 8 cases, almost all the patients had a prior history of prior therapy for a prior malignancy. And just last year, or in 2023, this really a nice study with a much larger series essentially highlighted the fibromyxoid pattern, and again, showing that they are often associated with other typical nephrogenic adenoma patterns. They are all PAX8 positive, essentially stain like typical nephrogenic adenoma, but importantly, they can be seen in patients that did not have any prior therapy or prior therapy for malignancy. So there doesn't have to be that particular association. So how do you recognize this fibromyxoid-like pattern of nephrogenic adenoma? I think finding typical, tubular pattern, I think is probably the most helpful thing. I think making this diagnosis, again, recognizing that it's fibromyxoid is not necessarily there's no prognostic relevance to the fibromyxoid pattern. What's more important is actually to make the correct diagnosis and not misclassify it as potentially something malignant, especially if that myxoid pattern is the predominant pattern that you see. But you typically do have, you often see the sort of amyloid-like background, which can be actually quite helpful. Like other nephrogenic adenomas, the fibromyxoid pattern will stain for PAX8 and Amicar, and this is a potential pitfall if you're going to use a PIN4 cocktail. And essentially say, for example, you see a TERP specimen like we shown here, and you're worried that this prostate cancer is going to have a loss of, essentially no expression of basal markers with overexpression of Amicar, so you have to be a little bit careful. So always keep in mind and add a PAX8 if you're thinking about at least considering an unusual prostate cancer. And then I just urge a little bit of caution of using other markers, probably to, again, use a panel approach, because GATA3, PSA, and PSAP can all be positive in nephrogenic adenoma. So just be a little careful there. Here was an interesting case. This was a neoadjuvant cystectomy, essentially no residual tumor. And again, if you happen to call this negative, I think that's probably essentially fine, but I kind of like this case because within the area of kind of scar fibrosis, which essentially looks like biopsy site change, which indeed definitely may be some of that, you do have some traditional tubular pattern nephrogenic adenoma. So if you're worried this is some residual bladder cancer, and some stains were done for that reason, you can see these are all PAX8 positive, along with all these cells within the sort of fibromyxoid-like area, kind of beautifully highlighting that this is actually a fibromyxoid pattern nephrogenic adenoma. And again here, let's see this kind of mirror image on the PAX8 and the H&E on the left, with the sort of amyloid-like areas along the periphery. Here was a case of it's kind of a TURBT for bladder cancer. Here is some typical urothelial carcinoma high grade on the right. On the left, you actually happen to have a lipoid-like variant. That's the point of what I'm showing here. But interestingly, sandwiched between the two, you actually do have a nephrogenic adenoma. This is a patient that had multiple prior bladder tumors. So the setup is perfect, having some bladder injury. So for developing nephrogenic adenomas, as you can see here, the high-grade urothelial happened to be lipoid-like variant on the left, with this very subtle fibromyxoid-like pattern on the right. Essentially looks like stroma with maybe weird, unusual-looking myxoid-like area. And if you do a PAX8 stain, you can actually see all the chains and cords embedded within this are all PAX8 positive here. So this is a little incidental, so to speak, nephrogenic adenoma fibromyxoid-like pattern. Again, if you happen to miss it or ignore it, it's probably fine. But the thing not to do is to call this now you have a high-grade urothelial, and to call it sarcoma to a differentiation. I have seen that done before, so just some point of caution there. This was a TUR-BT, another TUR-BT specimen in a patient that had I believe a nested pattern urothelial carcinoma. So you see these bland-looking epithelioid areas here that worry that this is some residual tumor of nested cancer. You can see these are all PAX8 positive, but strikingly within this background, you have this really prominent fibromyxoid-like pattern nephrogenic adenoma with these kind of chains of cells that are all PAX8 positive. So nephrogenic adenoma can come in a variety of different flavors: tubular, papillary, polypoid, cystic. I think these are the ones we sort of all recognize with general ease and are probably fairly more common. But I would just sort of bring forth fibromyxoid to highlight, obviously, and as I'm showing here, that it's probably a little bit more common than you potentially recognize. And if you happen to look in your other nephrogenic adenoma patterns, you may see that. Here's the more typical variety that we always see, kind of a papillary to polypoid, tubular cystic with this sort of nephrogenic adenoma with these hobnail-like cells. That's the more typical pattern. You often see it in association with other metaplastic, so to speak, conditions. You see this papillary-looking nephrogenic adenoma, and then on the right here you see some cystico glandularis, which happens to be a little intestinal metaplasia, benign, but kind of keeping with this kind of a reactive metaplastic, so to speak, pattern. Here, this was a TURBT for a bladder tumor that had a patient. The patient had a prior history of bladder cancer. You see, the urologist noted a very polypoid-looking lesion, beautifully recapitulated here at low power, but you can see all the cells here are quite cuboidal. So, and this is a really nice, almost pure papillary example of a nephrogenic adenoma being PAX8 positive. Sometimes they can have kind of a tubular or almost a hemangioma-like pattern as well, with these unusual secretions that are all PAX8 positive. There was an example in here, again, biopsy site changes in a TURP specimen, but another, and again, showing this fibromyxoid-like area, but oftentimes you do see other looking patterns of nephrogenic adenoma, and this is a PAX8 stain on the left in here. You can see this kind of fibromyxoid-like area, typical, and even a flat cuboidal-like pattern. Here's a very subtle flat pattern, nephrogenic adenoma. So all different patterns usually come kind of coexisting. Here was an interesting case. This was an erythematous lesion in a bladder biopsy. Patient had a history of bladder cancer. They went in and biopsied this kind of denuded inflammatory-looking area, but in the intact cells, some of these have somewhat smudgy-looking chromatin, but kind of medium-sized looking, potentially enlarged-looking nuclei, no mites, so to speak, but you may potentially worry that we're dealing with a urothelial carcinoma in situ, or potentially, patient some therapy-related thing in here. And so when you do your potential flat stains, and if you're thinking about it, at least you hopefully recognize that, hey, could this be a flat pattern nephrogenic adenoma, which is indeed the case here. All these lesional cells were all negative for urothelial markers, also negative for CK20, because that was done to worry about CIS, but this is just a very subtle, sneaky, flat pattern nephrogenic adenoma. Nephrogenic adenomas are frequently seen in urethral diverticular specimens, almost 10%, so that's something to be aware of. Here's, most of the time you get this kind of inflammatory-looking lesion in these nephrogenic urethral diverticular specimens, but sometimes you can get these irregular epithelioid-looking areas, even with cleared cytoplasm, with these unusual-looking nests that sort of, in part the potential, is this, clear cell adenocarcinoma, especially in a urethral resection specimen in a woman, you might worry about that. But these are all bland-looking. They're all PAX8 positive, no mitoses, no deep invasion or anything. So it's just a very beautiful example of a nephrogenic adenoma in a urethral diverticular specimen, which, as I said, was for about 10% of the time you do see that if you do look. Here was a nice case that patient came in with a bladder tumor, had a history of bladder cancer, just this polypoid-looking thing, cuboidal, and you say, okay, I got it. I'm going to do a PAX8, and I'm going to clinch this as a nephrogenic adenoma, right? And you see this cuboidal look, type-looking epithelium, and you would be absolutely right. The pitfall is sometimes what you're looking at is up top, and you forget sometimes on these things is to look what's below. And actually, you can see there's a more cellular-looking lesion with kind of medium caliber-looking nuclei, potentially a few mites, but some of the nuclei are enlarged with eccentric-looking cytoplasm. And this was actually, yes, there is a nephrogenic adenoma highlighted with the PAX8, but don't forget that it can frequently go along for the ride. So the urologist saw this, but there actually also was CIS underneath. Here you can see highlighted by the CK20. I'll draw your attention to this potential issue with biopsies if you're potentially thinking about a nephrogenic adenoma. which is indeed the case in here in this bladder biopsy with fibrosis and, cuboidal looking epithelium up top, is I am seeing, so PAX8 is positive in the nephrogenic adenomas, but I am seeing PAX8 overexpression in a lot of bladder biopsies. I don't know if it's a clone issue. I'm seeing it from a lot of different institutions as well. Just something to be aware of, that sometimes the urothelium can show overexpression for PAX8 as well. So when you're doing stains, I always do a panel approach. And so here you can see the nephrogenic adenoma elements are all P63 negative. So just a word of caution, if you're going to do things, potentially do it in a panel approach. Top differential diagnosis is of course, especially in cases with this more clear-looking cytoplasm, is clear cell adenocarcinoma. Here is an example that you see of kind of a fibromyxoid-like area here, with this papillary-looking area, and then kind of a more desmoplastic infiltrative-looking area here out into the muscles. So here you actually see a beautiful example of a fibromyxoid nephrogenic adenoma, and on the right, kind of a papillary-looking appearance. And there are some school of thought that these clear cell adenocarcinomas, which is what this is, are potentially derived from nephrogenic adenomas, or at least potentially seen in association with nephrogenic adenoma. And here you see a mitotic activity, but a lot of this very much looks like a nephrogenic adenoma. So just a word of caution with clear cell. But here you can see this is something that you really should not see in any respectable nephrogenic adenoma, deep desmoplastic invasion here with these kind of epithelial-looking areas that are all PAX8 positive. So, PAX8 is great and it's highlighting nephrogenic adenoma, including as well the fibromyxoid-like area. But just a word of caution that it will also pick up clear cell adenocarcinoma, and really sorting that out is morphology and typical features, including mites, atypia, desmoplasia, true invasion. Those are things to kind of be aware of when you're kind of assessing for clear cell adenocarcinoma. And with that, I will leave my email up here, and please do send me a follow-up with either comments or questions. And thank you again.
Thank you, and again, you can always email Ankur, and these are all again going to be discussed in April. So we are moving on to the last talk of this of the conference. Best practices recommendation for IHC marker in renal cell tumors, and it is by Dr. Mahmood Agul, who is recently started as an associate professor at the Brigham and Women's Hospital, Harvard, Boston. Very important topic for the residents and all of us. This is a little, so for the next 40 minutes, he's going to walk us through this topic.
Pathologist at Brigham and Women's Hospital in Boston. Today, I want to talk about one of my favorite topics, which is immunohistochemical assays and their smart use in renal cell tumor diagnostics. I have no relevant conflict of interest. So my brief outline is to mention the latest recognized and major changes in the latest WHO edition, which was released in 2022. And after this introduction, I'm going to start building up a morphology-driven diagnostic workup for kidney tumors. And after this, and along with this building up, we are going to mention immunohistochemical assays, their general rules in kidney, and some diagnostic algorithms to diagnose kidney tumors. So this is an intimidating list of recognized entities in the latest WHO edition on kidney tumors. And there are also 5 or 6 emerging entities that are not listed here. This edition has major changes in kidney tumors, which will require a diagnostic mindset change as well to accurately approach kidney tumors. So some of the changes includes the abandonment of type 2 terminology as a diagnostic line in papillary renal cell carcinoma, due to the fact that type 2 papillary RCCs are not just one single entity, but an umbrella group of several distinct entities. We are not using this category anymore as a single diagnosis. We can use them as a descriptive tool, but it is not a diagnosis. It is not a single diagnosis anymore. Oncocytic tumors of the kidney have expanded over the years, and right now we have several emerging entities with distinct morphology, immunoprofile, and molecular alterations. They include low-grade oncocytic tumors, eosinophilic vacuolated tumors, and hybrid tumors. The hybrid tumor category is only designated for the tumors that are in patients with Burton-Dubé syndrome. And we also have oncocytic renal neoplasm of low malignant potential category. Instead of labeling these low-grade oncocytic tumors as renal cell carcinoma, this terminology seems to be more accurate in terms of identifying the outcome or predicting the outcome in these tumors, because most of the low-grade eosinophilic renal neoplasms are actually very indolent. One of the major changes is also the clear cell tubulopapillary renal cell tumor title change. So we demoted this tumor from carcinoma to a neoplasm with low malignant potential, although we know that there are unequivocal evidence of very rare metastasis in these tumors. The vast majority of them will have a benign course. There's another entity called eosinophilic soil and cystic renal cell carcinoma, which is very rare, mostly seen in female patients, and there are some distinct morphologic and immunoprolific features in this entity. And lastly, and I think what makes this fifth edition very pivotal is the addition of this subtitle called molecular defined renal carcinomas. So most of the time, actually, despite the fact that we have a lot of changes in terms of chemical assays or molecular alterations, or even though our molecular alterations increased, still we are using morphology most of the time to identify kidney tumors. 90% of kidney tumors, which are highlighted here, are classified, not just diagnosed, but classified by their morphology. Less than 1% of tumors are associated with the background disease. There's only one entity so far, which is acquired cystic kidney disease associated with cell carcinoma. And very rarely, the location of the tumor may determine the diagnosis or help determining the diagnosis, which includes collecting duct carcinoma and renal medullary interstitial cell tumors. Those tumors are almost always arising from renal medulla. Collecting duct carcinoma is currently a diagnosis of exclusion. Again, I mean, location will not be sufficient at all to diagnose these tumors, but it basically refers to, and it may help diagnosing these tumors. And this important change, as I mentioned, molecule-defined renal carcinomas. And if you are somewhat curious about the kidney tumors, you will know that most of the renal tumors actually have distinct molecular alteration. So clear cell renal cell carcinoma will have VHL mutations, 3P deletions. Papillary renal cell carcinoma will have 7 and 17 chromosomal gains. And there are a lot of other examples by means of distinct molecular features in kidney tumors. What makes molecule-defined renal carcinoma different is you need to document the molecular alteration to diagnose these entities. You want to have the documentation of TFE3 rearranged renal cell carcinoma, either a surrogate or an actual documentation of the alteration to diagnose it. Whereas in clear cell renal cell carcinoma, you don't need to document the VHL mutation to diagnose clear cell renal cell carcinoma. So before diving into information overload, I want to mention two important principles in kidney tumors. One of them is, and I think it is the most important one, only a handful of renal tumors account for more than 90% of all renal tumors. So if you want to focus your energy in several kidney tumor entities, you will be able to diagnose more than 90% of kidney tumors. You need to know everything about these tumors. You need to know their differential diagnosis. Eventually, you will need to update yourself with the rest of less than 10% of the tumors. But if you know the most common tumors in kidney at a certain level, your job will not be as hard as you think. And the second thing is most commonly used immunohistochemical assays in kidney follow general rules. So these are the entities that you need to know. In kidney and anywhere else, the common subtypes are common. Clear cell RCC, no matter how many new entities we have in kidney, will account for more than 70% of kidney tumors. It is followed by papillary RCC, which is about 10 to 15%, and we have other tumors, chromophobin cell carcinoma, oncocytomas, clear cell tubular papillary renal tumors, angiomyolipomas. We can just name 5 or 6 entities, and if you know them really well, with their morphologic heterogeneity, with their distinct immunohistochemical profile, you will be able to diagnose most of the kidney tumors you encounter in your daily practice. And when you sign out, when you work on kidney tumors, we should remember that the morphology, again, I'm using that word, is the key. And we are going to have an approach of predominant histology and archetype lesion to diagnose and also mention kidney tumors and their immunohistochemical assays. So let's talk about some main features of immunohistochemical assays in kidney tumors. First of all, there is no specific kidney marker in daily practice. Any marker you use, and I think the most general marker for renal cell tumors or primary tumors arising from the kidney is PAX8, and it is not specific. It is expressed in more than 90% of renal cell tumors, which means tumors arising from the nephron, kidney nephron. Although it is non-specific, there are 2 main clones, polyclonal and monoclonal clones, and it will impact the extent of positivity in different organs. And on the top of everything, sometimes renal cell carcinomas can be negative. A negative PAX8 should not, exclude primary renal tumors. And immunohistochemical assays is becoming more and more important, and we are going to mention that in a moment. So there's a study on PAX8 using thousands of tumors from about 150 different tumor entities, and they show that, yes, most of the tumors arising from the kidney express PAX8, but there's always a certain portion of those tumors that are negative with PAX8. Another thing is, commonly used immunohistochemical markers are either somewhat indicating the cell of origin in kidney tumors, or they are somewhat manifestations of background genetic mutation. For example, clear cell renal cell carcinoma and papillary renal cell carcinoma are from proximal tubules, whereas chromophobin renal cell carcinoma, low-grade oncocytic tumors, and oncocytomas are arising from distal tubules, and their immunoprofile are impacted by that. For example, CD10 is a proximal tubule marker, and it will be expressed in clear cell and papillary RCC. On the other hand, KIT, GATA3, and L1-CHEM are markers of distal tubules, and you will see varying degrees of expression in tumors arising from distal tubule. In chromophobe renal cell carcinoma or oncocytoma, KIT is always positive, almost always positive. In LOTs, KIT is negative, but GATA3 and L1-CHEM is positive. Because depending on which segment of the distal tubule, the expression profile of these specific markers will change. Although we should be very careful when we interpret immunohistochemical assays in terms of the cell of origin, because sometimes overlaps happen. For example, CD10 can be present in as a fraction of chromophobin cell carcinomas. or despite the fact that racema is a proximal marker, proximal tubule marker, clear cell is positive in only about 20% of the time. So another thing, as I mentioned, some of the immunohistochemical markers, especially in molecular defined renal carcinomas, are actually manifestation of the mutation. In the lower half, you will see the loss of fumarate hydratase IHC expression, and the loss of it, and the overexpression of 2,6-cysteine. This is basically due to the fact that the fumarate hydratase deficient renal cell carcinomas have mutant fumarate hydratase. There's loss of function, and it impacts the protein as well as the overexpression of the byproduct. Whereas carbonic anhydrase 9, although it's not a direct marker, but it shows the constant pseudohypoxia state of the clear cell renal cell carcinoma tumor cells due to loss of function of VHL mutation and the interruption of the ubiquitination pathway. And lastly, other few important features of the immunohistochemical assays in kidney tumors. There is no single IHC that can make a diagnosis of kidney tumor. And if you cannot find a diagnosis with more than 5 immunohistochemical assays, you either do not know what you are doing, or you are dealing with a molecular defined renal carcinomas, which means if you know kidney tumors very well, and if you use immunohistochemical assays widely, this first option will not work for you because you will know what you are doing. Whereas if you have this situation, you are probably dealing with a molecular defined renal carcinoma, or you will need further immunohistochemical workup. So this is a summary of the immunohistochemical workup. Actually, it's my mental map to diagnose kidney tumors, and you will see these slides many times in my talk. So first of all, we are going to separate kidney tumors in terms of their predominant cytology. It is not a perfect separation, but we are going to have major classes of tumor cells with clear cell cytology, tumor cells with eosinophilic cytology, tumors with papillary formation, and other tumors. And after that, we are going to break down these major categories into archetype tumors. Every cytomorphologic feature will bring an archetype tumor, and we will try to focus on that archetype tumor or tumors in our diagnostic approach. I'm going to show you or mention some of the most immunohistochemical assays, must-have immunohistochemical assays in each type. And others categories, it's somewhat confusing, and I'm going to mention that because it is not perfect. I'm still working on it. But we are going to walk through all of those categories one by one in the rest of my talk. So tumors with clear cell cytology are the most common tumors that you will see because of the clear cell renal cell carcinoma and chromophobe RCC. Clear cell renal cell carcinoma and RCC probably are somewhat 80%, 85% of kidney tumors. And we also have clear cell tubulopapillary renal cell carcinoma, and these three major differential diagnoses are actually sufficient for you to just start your workup in tumors with clear cell cytology. Of course, morphologic features will be important, and if you have some key morphologic features that would indicate other tumors, for example, tumors with clear cell cytology and perfect fibrovascular course and some monomatous bodies, you will start thinking of translocation-associated renal cell carcinomas. But I think you got what I mean here. And when you see these tumors, when you see tumors with clear cell cytology, you need to start building up your immunohistochemical assays. And in this category, the most important must-have immunohistochemical assays are CA9 and keratin 7, carbonic anhydrase 9 and keratin 7. If you do not have these immunohistochemical assays, your workup is incomplete. I currently do not believe signing out kidney tumors. There are very few exceptions, but or very few scenarios, I should say, I don't think you should make a diagnosis of any kidney tumors without immunohistochemical assays. And in this particular category, CA9 and keratin 7 should be present in your diagnostic workup in tumors with clear cell cytology. There are other additional immunomarkers, and it will depend on the context. You don't have to add them all at once, but it will basically be shaped by the context and the morphology. They include, the most common ones include KIT, CD10, pancytokeratin, and racemase. So the archetype lesion in tumors with clear cell cytology is clear cell RCC. It is the most common tumor, and their classical look is clusters and acini of tumors that are mostly clear cells. Sometimes you will see eosinophilic change. Sometimes you might see other, morphologic manifestations of clear cell, which I will briefly mention. And these clusters and acini will be wrapped up by a delicate vascular network. These two features are extremely important, and more than 90% of the time, you will see at least focally this classical morphologic feature in clear cell. Although, again, there is a level of acceptable heterogeneity. One of them is a chromophobe-like look. Another one is microcystic and cystic changes. It is very common in kidney tumors. They are very delicate. I guess because of the delicate vascular network, these tumors tend to, form a lot of cysts. And another thing is, sometimes you can have very interesting tumor cells, including these syncytial type multinucleated giant cells. In this category, in tumors with clear cell cytology, CA9 and keratin 7 are vital, especially CA9, because diffuse, strong, and membranous carbonic anhydrase 9 expression in the context is almost diagnostic for clear cell RCC. There are rare occasions where you can have diffuse CA9 expression, but it is not in this context. So if you have tumors with clusters of these beautiful cells with clear cell cytology and vascular network, and on the top of it, if you have diffuse, strong, and membranous carbonic anhydrase 9 expression, you are probably dealing with a clear cell RCC. CA9 should be coupled with keratin 7 in this context, and a lack of diffuse keratin 7 should make the diagnosis of clear cell with compatible morphology and diffuse strong membranous CA9. I say diffuse lack of keratin 7 lack of diffuse keratin 7 expression because sometimes you will have patchy keratin 7 expression in clear cell. Chromophobe RCC is one of the tumors that are arising from the distal tubules. That's why they show expression of distal tubule markers. One of them is KIT, it is diffuse positive, and the other one is keratin 7. If you have a tumor with biphasic features like this, which is composed of large tumor cell with clear cell cytology and somewhat smaller cells with eosinophilia, perinuclear halo, and these innate nuclear membrane irregularities, raysonoid nuclei, you will most likely have a chromophobe RCC, and dual expression of KIT and keratin 7 will help you making the diagnosis. Clear cell tubulopapular renal tumor is again a critical diagnosis at the moment due to the fact that we are probably dealing with a most likely benign tumor. The morphology is usually there, which is basically mostly tubules and sometimes papillae, a cystic small tumor, well circumscribed, with tumor cells that are clear and having low-grade nuclei with abdominal localization of these nuclei in the cell. And cup shape, carbonic anhydrase 9 expression and diffuse keratin 7 expression is very important diagnostic markers. And they are the diffuse keratin 7 expression is almost always there. Sometimes carbonic anhydrase 9 cup shape expression is not there, but it is always diffuse. Another important marker for clear cell tubulopapular tumor is GATA3. the importance of GATA3 is increasing in kidney tumors, and I'm going to mention that briefly. You will hear or you will read varying degrees of positivities of GATA3 in clear cell tubular papillary renal tumors in the literature. Although in my personal practice and in my consultations with more knowledgeable people in that field, I believe more than 90% of clear cell tubular papillary renal tumors will be positive with GATA3. Other tumors in that category include papillary renal cell carcinoma with clear cell features, TFE3, TFE-B rearranged renal cell carcinomas, and renal cell carcinoma with fibromatous stroma. I'm going to briefly mention this morphologic umbrella terminology. Those tumors are in this category. Papillary RCs with clear cell features, TFE3, TFE-B rearranged renal cell carcinomas will lack diffuse, strong, and membranous carbonic anhydrase 9 expression. So if you have a tumor with clear cell cytology and lack of carbonic anhydrase 9, you should start thinking of molecular defined renal tumors. Again, GATA3 is becoming more important in kidney tumors. We recently wrote a brief, cute editorial about that, and sometimes for kidney tumors, GATA3 can be prototypic, which means you need to have GATA3 expression to diagnose it. And I think papillary renal neoplasm with reverse polarity is one of them. The other one is highly supportive, the previous example of clear cell tubular papillary renal tumors. GATA3 expression is very helpful in low-grade oncocytic tumor. Actually, it is almost prototypic for low-grade oncocytic tumors. But we should also think that the fumarate deficient renal cell carcinomas or some other tumors might express GATA3. I believe chromophobe renal cell carcinomas can also express, a portion of them express GATA3. Let's start talking about eosinophilic kidney tumors. Again, if your predominant cytology is eosinophilic, you might be dealing with some of those entities. And the prototypical entity, the archetype tumor, is oncocytoma, which is the most common, actually, low-grade eosinophilic tumor in the kidney. It is followed by eosinophilic chromophobe renal cell carcinoma. And in the past, we had that dichotomy of oncocytoma versus eosinophilic chromophobe renal cell carcinoma, but now we have new players. One of them is low-grade oncocytic tumors. We are going to mention that tumor, and angiomyolipoma is also a tumor that we kind of overlook when we talk about eosinophilic tumors, but they are actually mostly eosinophilic. And in this category, there are also other tumors like low-grade fumarate deficient renal cell carcinoma. A very important one is succinate dehydrogenase deficient renal cell carcinoma. You can have, actually, it is not infrequent to have predominantly eosinophilic clear cell renal cell carcinoma. That's why your diagnostic workup should be shaped by the morphology. And there are many other tumors, like TFE3 RCC can present with low-grade oncocytic features. And the very first thing you should do is to order KIT and keratin 7. KIT and keratin 7 are must-have assays for diagnosing eosinophilic kidney tumors. And you can add pancytokeratin, smooth muscle actin, keratin 20, CA9, and GATA3, depending on the context. Oncocytoma is very low-grade tumor. They are considered benign, and they are composed of varying sizes and shapes of clusters of bland low-grade eosinophilic cells in the background of loose connective tissue. So this is called, or this is described as archipelago-like, look. And these tumors are positive for KIT, and you will have scattered expression of keratin 7. So usually the books mention the perfect negativity of keratin 7 in oncocytomas, but I become a little bit restless when I see, when I don't see just scattered cell expression in oncocytoma. Again, due to the fact that oncocytoma is considered benign, we should be very careful. And as the saying goes, the planets should be aligned. You should have everything you need, and you shouldn't have everything you are not supposed to have to diagnose oncocytoma. One of the caveats of oncocytoma is about 1/3 of them will have a central scar. It is not specific for oncocytomas. Every slowly growing tumor will have that. But if you have this change, these areas may present with morphologic disruption as well as immunoprofile change. For example, if you have an oncocytoma with central scar, you might have extreme keratin 7 expression, and even carbonhydrate 9 expression on the top of clear cell change. So it may really confuse you if you are dealing with an oncocytoma with central scar. The new kid on the block is low-grade oncocytic tumor. They are identified by low-grade-ish tumor cells with overlapping features, morphologic features of oncocytoma and eosinophilic chromophobe, and lace-like edema. Instead of archipelago-like look, you will have this lace-like edema. I want to point these small intracytoplasmic vacuoles. It will help you. It's a helpful trick, actually, and it is very recently described by one of my friend. In these tumors, you will have a reverse immunoprofile when it is compared to oncocytoma. It will be negative for KIT, and these KIT positive cells are actually mast cells. These are nice positive controls in these tumors. And on the other hand, keratin 7 is extremely positive. And GATA3 will again be very helpful in this tumor category because most of the time GATA3 will be expressed. So if you have an acceptable morphology like this, low-grade oncocytic tumor, overlapping features with oncocytoma and eosinophilic chromophobe, KIT negative, keratin 7 diffuse positive, GATA3 positive, you have your diagnosis. These small vacuoles are recently described by Dr. Alghamdi in this recent paper coming from MSK group. I believe it is the largest cohort to date in terms of low-grade oncocytic tumors. They showed that these tumors are almost always positive with GATA3, and they almost always express L1-chem, and these small inclusions are present in most of the LOTs. So it might help you in differentiating them from oncocytomas, for example, because oncocytomas never have these vacuoles. There is a long-lasting debate in terms of whether we can diagnose low-grade eosinophilic renal neoplasms, like we can just pinpoint them as an entity in the biopsy. Some people think we cannot do that, we should not do that. But if you look at the morphology of both tumors, as an example, and immunoprofile, they are both distinct for each of those tumors. My answer is you can probably make a diagnosis. There are other eosinophilic tumors include eosinophilic vacuolated tumor, eosinophilic solid and cystic renal cell carcinoma, hybrid tumor. The hybrid tumor terminology is only used for patients with Bertok-Dubé after the 5th edition, and angiomyolipomas. Again, angiomyolipomas are under the category of eosinophilic tumors. So eosinophilic vacuolated tumor are notoriously positive with cathepsin K, although unfortunately cathepsin K is not always available, and you should end up relying on the morphology and probably sending out the case if you have this entity. Eosinophilic solid and cystic renal cell carcinoma are, as the name implies, mostly solid and cystic, and you will have keratin 20 expression at least focally. But you should keep that in mind. There are anecdotal evidence that TFEB amplified RCCs, which are also eosinophilic, can express keratin 20. Hybrid tumors, usually the clinical history will be better than the immunochemical profile. If you have patients with early age manifestation of kidney tumors, pneumothorax, pneumothorax and other manifestations of the Bertok-Dubé, it is more important. Another thing is in AML, of course, there will be negative PAX8 and pancytokeratin, and you will have smooth muscle actin, HMB45, and melanA expression. Other differential in low-grade oncocytic tumors include TFE3 RCC, as I mentioned, and low-grade familial hepatitis deficient cell carcinoma and stage deficient RCC. When we think of tumors with papillary cytology, we should think of papillary RCC, mucinous tubular and spindle cell carcinoma, and some other tumors. And when we start having tumors with particularly papillary formation, our job is becoming a little harder because molecularly defined renal carcinoma and some other marginal tumors are becoming, apparent in the differential diagnosis. If you have a tumor with formerly known as type 1 cytomorphology and papillary formation, and on the top of it, if you have keratin 7 expression and dual keratin 7 expression and racemase expression, you are probably dealing with papillary RCC. And that's why in tumors with papillary morphology, you must have keratin 7 and racemase at least, bare minimum, in your differential. And depending on the context, on your morphologic features, you can think of pancytokeratin, CA9, and melanate to include. So type 1, or formerly known as type 1, and right now it is papillary RCC classical type, or you can just say papillary RCC. They are composed of mostly low-grade tumor cells with cuboidal shape. They are nicely lined, papillary, delicate papillae, and those papillae are stuffed with foamy macrophages. These are usually consistent with papillary RCC. They can have mixed, formerly known type 1 and type 2 features, but there are multiple studies, particularly one from the MSK, going over more than about 200 cases. They found that type 1 and type 2 mixed tumors are probably type 1 tumors. These tumors, again, have dual positivity for keratin 7 and racemase. And they're also positive for CD10. Why? Because they're arising from the proximal tubules. Papillary RCC will have subtypes, and one of the well-known is biphasic papillary squamate renal cell carcinoma. And in these tumors, although you will have dual expression of keratin 7 and racemase, you can also have enriched expression of cyclin D1 in the squamoid or large epithelioid tumor cells. But cyclin D1 is a non-specific marker, and you will, of course, have scattered expression in quote unquote type 1 tumor cells in this particular tumor. Another differential in type 1 papillary type tumors includes mucinous tubular and spindle cell carcinoma. Usually when you see these packed tubules forming sieve-like spaces and low-grade spindle cell proliferation, it is not very apparent in this corneal biopsy example. But particularly extracellular mucin, you should start thinking of mucinous tubular and spindle cell carcinoma. Their immunoprofile is somewhat similar to papillary RCC. There is a new, although not very available, in situ hybridization assay called VSTM2A. And if you are stuck between the two entities, like papillary RCC and mucinous tubular and spindle cell carcinoma, you can send this case for chromosomal analysis. And papillary RCC, as I briefly mentioned, have multiple gains in 7 and 17th chromosome and loss of Y, whereas the mucinous tubular and spindle cell carcinoma will have multiple losses on somatic chromosomes, which is similar to chromophobe RCC. Another entity in this category is papillary neoplasm with reverse polarity, very delicate eosinophilic papillae with low-grade nuclei, and those nuclei are looking to the lumens, and they are positive for keratin 7, and again, they are almost always positive for GATA3, and you will have KRAS mutations, which is very weird in kidney tumor realm. This is an example of most common kidney tumors and most important immunohistochemical assays. It's a busy slide. You can refer to my recording and I'm going to just go over briefly on these, in this table. One of the things you should be mindful of is the inclusion of these immunohistochemical assays. We can discuss Wymantin. I don't trust Wymantin as much as I used to. But if you have carbon ganglion 9, keratin 7, KIT, racemase, GATA3 and CD10, you're good. Some labs don't have CA9 for some reason. Please include carbonic anhydrase 9 and please get rid of RCC IHC. I really cannot, tell you more that you should get rid of RCC and you should include CA9 in your lab. Lastly, we have other tumors, and when I say others, I talk about two things. One of them is sometimes there are rare entities that you can see and make a diagnosis, and of course, it's also based on history and epidemiology of the patients. For example, the gender of the patient might be important for tubular cystic renal cell carcinoma, but sometimes you can just make a diagnosis of these tumors, rarely. And the other category mostly includes the tumors that will probably need additional workup or molecular investigation. And there are some scenarios such as tumors with clear cell and papillary formation, especially type 2 morphology, renal cell carcinoma with fibromyalgia stroma, and high-grade infiltrative tumors. One example for these like slam dunk diagnosable tumors include acquired cystic kidney disease associated renal cell carcinoma. If there's a patient with end-stage kidney disease, long-term hemodialysis, and these usually cystic, usually small tumors with kind of syncytial type cells, they usually have high-grade, ISAP-WHO high-grade nuclei. And if you have these like empty spaces and oxalate crystals, it is probably diagnostic. You can actually make a diagnosis of acquired cystic kidney disease associated with cell carcinoma. I think keratin 7 is valuable in these tumors, and they are consistently negative. So let's talk about some problematic scenarios. One of them is renal cell carcinoma with fibromyalgia stroma. As the name implies, you have a tumor with very muscle-like thick septae separating mostly clear cells. So these tumors is not a single entity. It's an umbrella term. But most of the time, when you encounter these tumors, they are either mTOR mutated or they are ELOC mutated. ELOC mutated RCC is under the category of molecular-defined renal carcinoma. I wish these tumors, like renal cell carcinoma with fibromyalgia stroma and mTOR mutation, should be somewhat under the molecular category, but I guess it is not always there. So when you look at these tumors, when you encounter this type of morphology, think about mTOR mutation, ELOC mutation. And these tumors probably almost always express CA9, and they always express keratin 7. And it also complicates things. One, we have a diffuse strong and membranous expression in clear cell renal cell carcinoma, which is an important marker, and probably you will end up having clear cell whenever you have a tumor with diffuse strong and membranous carbonic anhydrase 9, but these tumors can also express that. And the clear cell is in the differential in these tumors. Another one is clear cell tubular papillary renal tumor. I apologize for the typo. For some reason, I just forget to use the new terminology here. And there are recent entities called hemangioblastoma-like RCCs. They are now actually under this umbrella differential diagnosis. So let's briefly talk about molecular-defined renal carcinomas. We have 7 or 8 entities in here, and they have common features. One of them is they have even focally distinct morphology, such as in this scenario, it is fumarate deficient cell carcinoma, and you have these tumor cells with prominent nucleoli and papillary formation. In the other feature is you have to document the molecular alteration in these tumors. So you have to document fumarate hydratase deficiency to diagnose fumarate hydratase deficient cell carcinoma. They are most likely negative for keratin 7, but it is not enough for the diagnosis. And morphologic overlap will present between the two and between the common entities. And, the morphologic spectrum will keep expanding. One example that I recently have was a biopsy material on a tumor with clear cell cytology and papillary features. And when you have, papillary features, abundant clear/eosinophilic cytoplasm, and subsammomatous calcifications, you should think of TFE3 rearranged cell carcinomas, and keratin 7 was negative in this tumor. It is a nice marker form, and if you have keratin 7 negativity and racemase expression, racemase can be used as a dirty screening tool. Most of the time, TFE3 RCC can express racemase. Of course, it is not sufficient, but it is something that might help you. And keratin CA9 will be negative in these tumors. And again, pancytokeratin is expected to be negative in these tumors, but it was positive in this particular entity. Particular case that I had. And TFE3 IHC, if it is strong diffusely positive in the nuclei of the tumor cells, and it is negative, cleanly negative in non-tumor cells, IHC can actually make a diagnosis. In this case, we sent it for FISH and it turned out to be negative, but in the end, we did the NGS and it turned out to be one of those, TFE3 rearranged cell carcinoma with intrachromosomal translocation. And in those scenarios, sometimes the conventional FISH probes may not catch up the FISH break apart. Another case was 20 centimeter tumor with the familiar look. And long story short, I did a lot of immunostains on this particular tumor. It didn't help. Again, I used more than 5 immunohistochemical assays, and it turned out to be fumarate hydratase deficient renal cell carcinoma. But sometimes you might have, fumarate hydratase immunohistochemistry retaining in those tumors. Therefore, you should couple it with 2SC, which is a byproduct, and nuclear and cytoplasmic overexpression is important. Succinate dehydrogenase deficient renal cell carcinoma, young patients usually, and these low-grade eosinophilic look with intracytoplasmic vacuoles should prompt you to think of STH deficient RCC, and STHB stain will be lost, and there will be nice positive controls in non-tumor elements. So there are lots of things you can do. Immunohistochemical assays usually are insufficient in TFE3 rearranged cell carcinomas unless you are dealing with ALK, STHB, or FHRCC. Usually you will end up having FISH or sequencing technologies. We recently briefly mentioned this problem. Our labs are becoming more and more challenged by newly identified entities, but again, as I told you, if you know most of the kidney tumors, if you know what you're doing, you will be able to make a diagnosis. We have a very limited time, and this is my last slide. I just put it for you to see the most important slides at the end of the presentation. I'm really grateful to be one of the stellar speakers. I'm humbled to be one of those. I'm humbled to be among one of those mentors. To speak. I'm their humble student and friend, not merely a mentor. I really thank you for listening to my presentation, and I wish you a great day. Thank you.
Thank you, Anku, Mahmood. And so we are moving on to the end of the session. May I call upon Dr. Saurabh Mishra and Dr. Ranjana Giri to join me for the valedictory function. So we're going to announce the oral presentation.
Showing you the examples of 2 cases. I have no relevant conflict of interest. So first of all, we are going to take a look at the list of mesenchymal tumors that are common in genitourinary tract. There's a specific chapter for that in the latest edition of the WHO. And then after this brief introduction, we are going to mention some of these examples with case presentation, and we are going to briefly touch base with immunohistochemistry and some diagnostic algorithms. So here's the list I mentioned. So of course, these are not the entire spectrum of soft tissue entities that we can see in the genitourinary tract. For example, liposarcomas of the spermatic cord is very common, but it is mentioned in a respective chapter in bone and soft tissue edition of the WHO. Here you will see that these entities are very diverse and can be seen in multiple different areas. One of the interesting phenomenon we see about these entities are they tend to be seen most commonly in one or two areas in the genitourinary tract. For example, angiofibroma family of tumors are usually seen in paratestis and scrotal, inguinoscrotal area. Solitary fibrous tumors are particularly seen in kidney. In my limited experience, I see them particularly arising in the perihilar soft tissue and involving the kidney. But there are examples of intrarenal parenchymal solitary fibrous tumors. Inflammatory myofibroblast tumors are notoriously present in the urinary bladder. Hemangiomas, glomus tumors, synovial sarcomas are common. I mean, relatively common. These are rare entities, but they are relatively common in kidney, whereas rhabdomyosarcomas are common in spermatic cord and paratestis. Similar to the soft tissue entities anywhere you see, they are associated with distinct molecular alterations. So, hemangiomas are associated with GNAQ, GNA11, or GNA14 point mutations, whereas rhabdomyosarcoma molecular alterations will be dependent on the subtype. For example, alveolar rhabdomyosarcomas will be associated with PAX3 FOXO1 alterations. So again, it is impossible to go over with the entire spectrum of soft tissue tumors seen in the genitourinary tract. So I decided to give you some examples of these entities that I have personally seen in my daily practice. One of them is a 75-year-old male with Gleason score 2 plus 4, 7 grade group 2 prostatic adenocarcinoma. After seeing this prostate cancer in multiple cores, patient underwent prostatectomy, and it was a Gleason score 2 plus 4, similar to the corneal biopsy diagnosis, and it was actually confined to the prostate, although very close to the inked tissue margin. We have seen a separate, distinct lesion. Basically, it is seen as sheets of very small, bland-looking cells with some syncytial type, conglomeration, as well as some sieve-like spaces. And if you look at here, you can see some, like wrinkle type spaces that may give you a hint of vascular, origin. We tried NKX 3.1 to make sure we are not dealing with a high-grade prostatic adenocarcinoma, because high-grade prostatic adenocarcinomas can actually look like these, and it will be a major thing that we need to distinguish in that particular scenario for obvious reason. And CD31 showed diffuse staining in these lesional cells. We did not use ERK because 50% of the time, due to ETV family alterations, rearrangements, so to speak, you will have ERK overexpression in prostate cancer. So in this particular differential, using ERK may not be very helpful. But we did pancytokeratin, NKX 3.1, and CD31, and the first two were negative, the pancytokeratin and ERG were negative. NKX 3.1 were negative, and CD31 was positive. So it was an incidental hemangioma of the prostate, which is extremely rare. Another example was another incidental subcentimetric mass in a elderly female with a 4.5 centimeter renal mass. The renal mass itself was clear cell renal cell carcinoma, but we also had this lesional tissue. And so if you think about the clear cell renal cell carcinoma, because of the high vascularity and a wide spectrum of acceptable heterogenic morphology, clear cell RCC can actually look like this. On the other hand, first of all, we do not have much, manifestation of these well-known tumor cells with clear cell cytology. You do not have SNR or a nested collection of tumor cells. What you have is basically not very well circumscribed, but kind of lobulated lesion with multiple different small kind of globules like empty spaces. And you can see extravasated blood, and you can see red blood cells inside these small empty spaces. And it kind of should prompt you thinking of a vascular lesion. And we ordered CD31 and ERG immunohistochemical assays to establish the diagnosis of hemangioma. Hemangiomas are usually entrapping nearby non-neoplastic kidney tubules or kidney structures. So you can see that CD31 is expressed in the lesional cells, whereas they are negative in these tubule structures. There was no brisk atypia. There was no mitotic activity. The Ki67 was proliferation index was very low. That's why we called it hemangioma. There are some debates about the use of different descriptive terminology in hemangiomas. For example, some authors think that I think it's a common or it's probably the predominant thought that you may not use capillary terminology anymore or cavernous terminology anymore. I think anastomosing terminology is still being in the use, but these are some advanced discussions of the bone and soft tissue pathology, and I'm not super familiar with that, so I'm just going to stop here. Recently, actually very recently, a couple of days ago, we just got the largest cohort to date collected paper accepted. So we collected 39 cases of intrarenal hemangiomas, and we excluded, hemangiomas arising from pararenal soft tissue like perinephric fat or renal hilum or renal vein itself. And we also excluded other vascular lesions, and we collected 39 cases. We saw that they are benign and mostly asymptomatic, but they can be the reason of nephrectomy. So sometimes, imaging studies, which are very strong, powerful, can detect these lesions, and they can actually mimic renal cell carcinomas, because most common renal cell carcinoma, which is clear cell, is actually a very vascular lesion. So it is extremely hard for radiologists to distinguish these tumors. So they can be mistaken as renal cell carcinoma, and they can be resected. Anastomosing subtype, which is seen in these images, are the most common subtype in kidney, and they are also associated with extramedullary hematopoiesis. So you can have macrophages or other elements of hematopoietic system, or immature elements of hematopoietic cells in the lesion. Another example was the malignant counterpart of these vascular lesions. we had a 78-year-old male with remote history of prostate cancer and now gross hematuria and bladder lesion. And the urothelium was simply okay. It was just reactive, but we have these very high-grade epithelioid-looking lesion with atypical mitotic activity, pancytokeratin and NKX 3.1 were negative, and GATA3 was also negative, but CD31 was completely positive. And we also realized that the patient did not have prostatectomy because it was a low volume, low grade prostate cancer, but he received radiation treatment, and MYC amplification was also present in this lesion. So we signed this case out as epithelioid angiosarcoma. And as in the comments, we say that history of radiation treatment may be associated with this lesion. The second case I want to present today is a 32-year-old female with 7.3 centimeter exophytic kidney mass, and in the core biopsies, you will see on low power a predominantly eosinophilic lesion with brisk cytologic atypia. And in this brisk cytologic atypia, you can actually be able to see some mitotic activity as well, which is relatively uncommon in kidney tumors. Even we are discussing clear cell renal cell carcinoma or other tumors, mitotic activity is usually not something that we frequently encounter in kidney tumors. And we ordered several immunohistochemical assays, and it turned out that these tumors PAX8 negative and pancytokeratin negative. So we realized that we are dealing with a mesenchymal tumor, and SMA was diffusely positive, and melanistic marker HMB45 was also diffusely positive. And this is the nephrectomy material of an epithelioid angiomyolipoma or epithelioid picoma. These are in contrast with the classical counterparts, are malignant tumors, and in the nephrectomy, we also see multiple higher lymph node positivity. Also, patient has a 4 to 5 centimeter para-aortic mass, which turned out to be epithelioid angiomyolipoma. These tumors can be seen in a sporadic setting or in patients with tuberous sclerosis complex. It is important to keep that in mind because the young age and epithelioid morphology may be associated with tuberous sclerosis complex. This is a relatively recent case, so we are still waiting to hearing, or the institution that I used to work is currently waiting to hear from this patient regarding the germline status. But we also recommended the germline testing in this patient. These tumors have most likely mTOR pathway mutations, but recently we have several unequivocal evidence of TFE3 rearrangements in these tumors. And I am not 100% sure, but mTOR pathway mutations and TFE3 rearrangement may actually be mutually exclusive in these tumors. These are the two entities that I wanted to share with you. I wish we were together in India right now. In September, during the European Congress of Pathology, me and some of my best buddies in gastrointestinal pathology were together. Dr. Samit Mohanty and Dr. Ankur Sangoi. We did not just attended the conference, and with Dr. Al Obaidi and of course Dr. Williamson, who is in India right now. We were together and we spent a really good time in Florence. I hope next year or anytime soon I will be able to join you guys. Thank you so much for listening to me, and I wish you a great day.